going to start. I request everybody who is not inside the auditorium to please come inside the auditorium. We are about to start the scientific program for today. We are already half an hour late and even more. Everybody please come inside the auditorium so that we start with the scientific program for ICP-CON 2025. A very good morning to all. On behalf of the organizing committee of ICP-CON 2025, I, Dr. Harsimar Singh,
and I, Dr. Madhulata,
extend a most respectful and heartfelt welcome to our esteemed faculty members, distinguished speakers, honored guests, delegates, residents, and students. It is indeed a great privilege to gather in the company of such esteemed clinicians and scholars.
Now, I request our organizing chairman, Dr. Uttam Kumar Paul, Professor and HOD of Department of General Medicine from Mata Gujri Memorial Medical College, to kindly come upon the stage and welcome our guest.
Good morning to all. My respected faculty members, respected delegates, my dear postgraduate students from my institute and from other institutes from West Bengal and Bihar, and all my dear participants, I welcome you all to this academic feast of ICP-CON 25, which is jointly ventured by Bihar and Bengal physicians. Our scientific committee has planned an excellent scientific program, which I think all of you will enjoy this scientific feast. Thank you all.
Conferences such as ICP-CON hold significant importance as they serve as the platform for intellectual exchanges, evidence-based dialogues, and dissemination of contemporary advances in the field of medicine. They allow us to collectively reflect upon evolving challenges, strengthen our clinical acumen, and reaffirm our commitment to excellence in patient care.
As we commence today's proceedings, it is our shared aim to engage meaningfully with the scientific content presented, to foster constructive interactions, and to derive insights that can refine our professional practice. Such academic congregations offer invaluable opportunities to broaden perspectives, encourage collaboration, and cultivate a deeper understanding of emerging trends and innovations.
We sincerely hope that each participant benefits richly from the session ahead and carries forward learning that contribute to continued growth and success in their respective endeavors. We look forward to hosting you all with warmth and professionalism, and we extend our best wishes for your future academic and clinical pursuit. With these words, we take the honor of initiating the first scientific session of the day, which is platform presentation as well as the poster presentation.
And therefore, we respectfully request our honorable judges, Dr. Anita Datta ma'am, ex-professor in HOD, Department of General Medicine, NRS Medical College, Kolkata, Dr. R.N. Sarkar sir, ex-professor in HOD, Department of General Medicine, Medical College, Kolkata, Dr. Krishnendu Roy sir, professor, Department of General Medicine, Midnapur Medical College, to take their seats to evaluate the upcoming presentations by our student participants.
I now take the opportunity to announce the names of the students presenting in today's platform presentation session. That is Dr. Gurjot Gill, Dr. Shuryans Pratik, Dr. Arzu Nagpal, Dr. Avirup Mehti, and Dr. Taranjot Singh. A gentle reminder to all the presenters, the maximum time limit for each platform, paper or case presentation is 8 minutes, followed by 2 minutes for discussion. We request all the participants to kindly adhere to the allotted time. We wish you all the best.
Now that we are about to begin with the platform case presentation, the poster presentation participants are requested to move to Hall 2. I request the esteemed judges evaluating the Group A as well as the Group B poster presentation to proceed to Hall 2 for the session.
I now call upon Dr. Avirup Methi to present his paper. You may please take the podium, sir. Thank.
Good morning, everybody. I welcome you, Avirup Methi, for the first case presentation. Please start your presentation.
Good morning, respected judges, respected teachers, and my dear colleagues. Today I am going to present to you a case titled When the Rare Becomes Reality, Antisynthesis Syndrome in a Young Adult Man. My patient, a 32-year-old male, non-smoker, married, Hindu, an auto driver by occupation, presented with chief complaints of dry cough with exhaustional shortness of breath for last 6 months, weakness of all 4 limbs for 4 months, and fever with multiple joint pain for 15 days. Now, on expanding the history further, the cough was non-productive with no diurnal variation. Shortness of breath, which was exertional, was insidious in onset, gradually progressive, and worsened from MMRC grade 1 to MMRC grade 3 over the last 6 months. There is no history of PND or orthopnea. Now, coming to the proximal muscle weakness, it was present in all 4 limbs, was symmetrical, insidious onset, gradually progressive, characterized by difficulty to get up from squatting position, and also associated with difficulty in combing the hair. There was pain and stiffness in the bilateral knee joint, wrist, and multiple small joints of the hands bilaterally, involving the MCP and PIP joints. There was also the diffuse, non-radiating, intermittent, mild pain in bilateral thighs, buttocks, and lower back. The fever was intermittent and of low grade and was relieved on medication. Now, coming to the examination, the general physical examination revealed pallor in the patient, and during the examination, the patient has a raised temperature and tachypnea. Now, coming to systemic examination, the chest had reduced expansibility during inspiration, with the expansion being around 2 centimeter. On auscultation, there were fine inspiratory crackles over the lower lobes. Now, coming to CNS examination, it was generally within normal limit, except the following motor findings, which was mild wasting present in the proximal muscles of both upper limb and lower limb, and the power being 4/5 across the hip and shoulder joint. There was some amount of waddling rate. The musculoskeletal system examination revealed swollen MCP and PIP joints of both hands, with bilateral knee joint involvement and bilateral knee involvement. There was coarse hyperkeratotic skin over the dorsum of the both hands. On palpation, the tender joint count was 21 out of 28, and swollen joint count was 13 out of 28. Other system examinations were within normal limit. Now, with this history and these examination findings, the differential diagnosis we thought about was rheumatoid arthritis with ILD, SLE with ILD with myositis, and mixed connective tissue disorder. The entire spectrum of inflammatory myopathy was within our purview, and we also thought of infective myopathy. Now, coming to investigation, the hemoglobin was 8 gram per deciliter with peripheral blood smear revealing anastocytosis and leukocytosis. There was raised ESR and CRP count with the LFT showing raised SGOT and SGPT levels. There was also raised LDH and creatine kinase. The iron profile done revealed raised serum ferritin level, which is probably due to an ongoing inflammatory procedure. Now, coming to other investigation, the rheumatoid factor and anti-CCP levels were within normal limit. The pulmonary function test done showed a restrictive pattern. This is the chest X-ray, which showed reticular patterns with patchy opacities. Following this, we did an HRCT thorax, which showed bilateral ground glass opacities in lower lobes with extensive peribronchial bronchial cuffing with centrilobular nodules, suggestive of NSIP pattern of ILD. ANA with ANCA profile was done. ANA was positive in the titer of 1:320 with coarse, speckled, and cytoplasmic pattern. ANA profile was negative. Following this, the myocytic profile was done. We showed anti-PL7 antibody positivity with PM-SCL75, OJ, and MI2 antibody positive in the borderline. The electromyography done showed short duration, low amplitude, polyphasic motor unit potential with early recruitment and increased incisional activity suggestive of inflammatory myositis. We also did an MRI thigh of the patient. We showed hyperintensity in start sequence, suggestive myositis, and a muscle biopsy was done from the vastus lateralis of this patient. We showed perimysial and endomysial mononuclear cellular infiltrates with necrotic deposits, suggestive of myositis too. With these findings, we found out that the patient had interstitial lung disease and inflammatory myositis, along with arthritis, fever, and early changes of mechanic hand. And there's also positivity of anti-PL7 antibody. With this, we came to a diagnosis of anti-synthesis syndrome according to Solomon's criteria 2011. Following this diagnosis, we gave the patient injection methylprednisolone 1 gram for 5 days, followed by a course of oral prednisolone. Now, in view, the patient had inflammatory myositis with interstitial lung disease. We gave tacrolimus for immunosuppressive therapy so as to reduce the further progression of ILD. Now, now this is a follow-up of the patient after 3 months. It showed a significant increase in the proximal muscle strength with increased exercise tolerance, and their reduction in myalgia and arthalgia. Serial blood monitoring showed a decrease in creatine kinase and NDH levels. The pulmonary function test was repeated after 3 months, which showed no further degeneration in the restrictive lung parameters. Currently, the patient is stable and on regular follow-up. Now, coming to case discussion, anti-synthesis syndrome was first described in 1990s in the subset of idiopathic inflammatory myositis patients. Currently, it is estimated that
I will just stop you, Oviru. This is not time. No, we will have a discussion.
Okay, fine. The current prevalence is 1.5 to 2 patients per lakh population, which has a female preponderance in their 4th to 5th decade of life. And the most common antibody that is found in anti-synthesis syndrome is anti-Jo1 antibody. In our patient, who was a male and was in his 3rd decade, and the antibody positive was PL7, which makes this case unique and a presentable one. Thank you.
Thank you. Good, nice case. What are the myositis specific antibodies?
Sir, myositis specific antibodies would be, sir, MI2 antibodies, then, sir, PMSCL antibodies, and, sir,
main characteristic feature of this anti-synthesis?
Sir, anti-synthesis syndrome, sir, would have, sir, first, sir, amino acid T, RNA, clinically, sir. Clinically, sir, there are true criteria, sir, would be there, or major criteria or minor criteria. The major criteria, sir, will have ILD, which is could be an SIP or, sir, cryptocol COP type of ILD, and followed by, sir, ILD and, sir, active myositis.
That patient had mechanic send.
Yes, sir.
Yeah, that was very.
Yes, sir. And, sir, the minor, it will come in the minor criteria, sir. 4 of the minor criteria is there: mechanics and Raynaud's phenomena, and there are unexplained fever and arthritis.
Thank you very much. Okay, next Dr. Gujri.
सर कौन सा वाला माइक्रोसॉफ्ट पावरपॉइंट सर ये देखिए ठीक है चेंज तो इधर से हो जाएगा
Good morning, respected faculty and our delegates. I am Dr. Gurjot Singhil, and I'm here to present my paper on gender association of impulse control disorders in patients of Parkinson's disease and its impact on quality of life. Impulse control disorders are characterized by failure to resist an impulse or a temptation, and throughout the past decade, it has been a known phenomena that dopaminergic medications, which we administer to remedy the motor symptoms in Parkinson's patients, are associated with enhanced risk for non-motor symptoms like impulse control disorders. ICDs such as pathological gambling, compulsive buying, compulsive sexual behavior, compulsive eating, hobbyism, punding, dopamine dysregulation syndrome, and walkabout have been reported in Parkinson's patients. These are relatively frequent, affecting 18% of the population and associated with risk factors such as young ages of onset, male gender, depression, and family history of such behaviors and genetic factors. Now we have to know one thing. ICDs are under-recognized in our clinical practice because we focus on motor symptoms and not on the non-motor symptoms of Parkinson's patient. So a questionnaire for impulsive and compulsive disorders in Parkinson's disease, which is the QUIP questionnaire, is used to detect such disorders. In the Indian scenario, ICDs relevant are, there is limited data, hence certain possible presentations of impulse control disorders in Indian scenario have yet to be explored, which hence this research was aimed to analyze the gender disparities, to assess the impact of ICDs on quality of life, to explore and identify the ICDs in our Indian scenario, and to examine the association with dopamine replacement therapy and the spectrum of risk factors in patients. In this study, it was an observational cross-sectional study in which 192 patients were studied over a period of 18 months. Inclusion and exclusion criteria were followed, hence only the patients with idiopathic Parkinson's disease and who did not have any cognitive abnormality were included in the study. The data was collected in a structured performer, and a control group of 190 healthy volunteers were also included so as to see the frequency of ICDs in normal population also. And all the patients were asked to fill this QUIP-IS questionnaire in the English and Hindi language. Now, QUIP is a screening instrument which has high discriminant validity in multiple language, which has been searched throughout the world. The QUIP has 3 sections. First section discusses the impulse control disorders. Second section, the dopamine dysregulation syndrome. And third section, the other compulsive disorders. In this study, we also included impulse control disorders not elsewhere classified, such as body repetitive disorders. Levodopa equivalent daily doses of all the patients taking the therapy were calculated to see its association with ICDs. and to analyze the risk factors, a very detailed performa, including all the demographic and clinical variables, was taken, and modified Hone and Yar scale was seen to see the severity of the disease. To specially focus on impulse control disorders not elsewhere classified, such as body-focused repetitive disorders like trichotillomania, hair-nibbling, pyrophilia, it was also included in the part of the study. To see its impact on quality of life, we used the validated PDQ-39 questionnaire, and a statistical analysis was done. This was the performa which we made, and patients were asked to fulfill it, and PDQ-39 questionnaire, which has 39 questions, patients were asked to fulfill it. This was the master chart, and the analysis was done accordingly. So coming to the results, total 192 patients were taken, and the mean age of onset was 51 years, whereas the mean Parkinson's disease duration was 5.3 years. At least one ICD was seen in 41% patients, whereas patients who had more than 2 impulse control disorders was seen in 14% of patients. In this, 3.2% patients also had impulse control disorders, such as trichotillomania. Punding, which refers to repetitive and purposeless activity of patients, was the most common disorder, followed by compulsive medication use, and followed by compulsive hobbism. And the most significant part of the study was that we were able to identify trichotillomania and other body repetitive disorders, which have not been identified in other Indian studies yet. This was a chart prepared and which was analyzed. Now coming to the gender difference in the ICDs. In males, at least one ICD was present in 39% of the population of Parkinson's disease, whereas in females, one ICD was present in at least 44% of patients with Parkinson's disease. Now, it was seen it is more frequent in females, which is contrast to the Western publications, where it has been found it is more common in males. Now, if we dive in further, punding and compulsive eating were found to be more common in women, whereas hypersexuality and compulsive medication use were found to be more common in men. Now, we'll come to its impact on quality of life. Here we can see the PDQ summary index is more in patients with ICDs. Hence, the total quality of life was much worse in patients with any ICD rather than those without ICD. Also, quality of life in emotional domains, stigma, communication, and social support domains were worse in patients with ICDs. Now, when we calculated the levodopa equivalent dose, it was found when compared with patients without ICDs. In patients with ICDs, patients consumed higher dose of levodopa and dopamine agonists and longer duration of treatment. Demographic data was also collected, and when compared with patients without ICDs, it was found patients with ICDs had higher Hone and Yaw staging, that is more severe Parkinson's disease. They had more severe motor disability, and they're likely to have right-sided onset. Now coming to the discussion, we found higher frequency of ICDs in an Indian Parkinson's population. This is because we also included impulse control related behaviors along with just impulse control disorders. Punding was found to be the most common, followed by compulsive medication use and impulse control disorders. The most relevant part of the study was, in the Indian scenario, we were able to explore some of the disorders which haven't been explored in other Western countries, such as body repetitive disorders. By univariate analysis, we were able to find that patients with ICDs have young onset Parkinson's disease, severe motor disability, right-sided onset, higher Hone and Yaw staging, higher dose of levodopa, and longer duration. ICDs tend to be more frequent in female. Historically, we know that gender-related differences in addictions have not been studied much because hormone fluctuations in women are rarely investigated, and levels of estrogen and progesterone may have larger impact on behavioral and pharmaceutical investigations. Also, in our study, prevalence numbers found to be higher because in the Western countries, there are 3 groups: ICDs, ICD-related behaviors, and impulse control disorders. So, the prevalence numbers may vary to 35%. Now, due to genetic and environmental factors, there can be different expression of ICDs. This is because we are a multi-ethnic population in India itself. Due to cultural and social factors, the prevalence and the variation may be different, and this has to be further studied. Now coming to the conclusion, ICDs have been included in behavioral pattern of non-motor symptoms. Parkinson's disease, patients are at risk of developing such impulse control disorders which interfere with important activities, and we have an obligation to study them because they can lead to legal and psychological consequences with great impact of quality on life. Hence, more investigation into genetic susceptibility for ICDs needs to be done, more prudent use of dopamine agonists, and I repeat, more prudent use of dopamine agonists in our In our life, we as physicians, we have to take care of that, and periodic screening of presence of ICDs has to be volunteered. Thank you.
Thank you for a nice presentation. Do you have something to tell about the recent treatment in Parkinsonism? Any surgical interference? You know?
Surgical interference, yes, ma'am. We have brain scanning done, and a surgical intervention you're asking, right?
Any surgical interference
Yes, ma'am.
is a choice in the treatment of modern treatment
Yes,
of
in
Parkinson's
modern
disease.
treatment, surgical interventions have brain mapping and exploration, and ma'am, there have been some new latest interventions have been there for surgical interventions Parkinson's, which are
Is there any role for deep brain surgery, DBS?
Ma'am, it hasn't been studied much yet, but studies are underwent, but it hasn't been implied as if it has to be done in every patient.
Okay, it's a treatment of choice.
Choice, yes, ma'am.
in
Treatment
some
of choice.
centers.
Yes, ma'am.
One
The
question,
upgraded centers.
Did you include the drug-induced Parkinson's?
No, sir. Only idiopathic Parkinson's patient. The secondary causes, like the other causes of Parkinson's, they were not included. Only idiopathic patients, according to the United Kingdom's criteria of Parkinson's Society, they were included.
Did you go ask for the patient who were taking some prokinetic drugs which usually cause Parkinson if taken for more than 3 months, particularly
Yes, sir. Yes, sir.
because many people in our country, they usually take over the counter.
Exactly, sir. That was the issue. So in this performer, we asked for the history of any other drug intake. Apart from that, we asked if there were any psychiatric medications. So they were excluded from the study. We specifically asked any history of any drug intake.
Levosulpride is very.
Yes, sir. Levosulpride can lead to, yes, sir.
Then one more. What is did you compare this with
Normal.
OCDs?
Yes, sir. OCDs, sir, OCDs weren't included in this. We just, since OCDs are different as compared to the ICD-11 guidelines, OCDs and impulse control disorders are under different categories. So the obsessive disorders were not included, only the impulse control disorders were included.
And you concluded that these dopaminergic drugs may increase this?
Yes, sir. In fact, it was found the patients which have compulsive medication use, which is one of the ICDs, they take more drug than they have to. 12% of the patients are in this category. They had more ICDs, impulse control disorders, because they were taking more of the drug. Yes, sir.
Thank you.
Yes, sir. So this is a screenshot of the first page of the master chart.
You considered in the master chart you disclose the name of the patients?
Yes, so that I have included those who gave the consent. Yes, sir. Those who didn't give the consent, they have included as patient 27, patient 22.
Whatever that,
Yes, sir.
in your master chart, do you write down the original names of the patients, or it has to be written by
Okay, sir.
abbreviations?
Okay, sir.
What is
Because to avoid the bias, interview bias, and
what you
yes.
have to do in your whenever you produce your thesis or anything, whether you put the original names or abbreviations?
so abbreviation, sir. Thank you, sir.
Okay. Thank you.
Thanks, sir.
Next, Dr. Arju.
A very good morning to all of you. Myself, Dr. Arjun Akpal, PGT first year in General Surgery Department at MGM Medical College and LSK Hospital, Kishanganj. Today, I am here to present my paper on the topic Management of Case of Burn Injury in a Neonate with Respiratory Distress and Sepsis. Heading towards introduction, burn injuries in neonates are although rare but fatal, often happen due to an accident or iatrogenic causes, example, pulse oximeters, temperature probes, warming blankets, and other sources in a neonatal unit. Presenting case report, patient presented to the hospital on 8th day postpartum with a body weight of 3.8 kg with a complaint of burn of left forearm 6 days back. On examination, patient was febrile with a temperature of 100.6 degree Fahrenheit. He was tachypnic with a respiratory rate of 80 per minute. SpO2 99% on room air. Respiratory distress was present. Pulse rate was 170 per minute. S1, S2 present with no added sounds. Chest was clear with bilateral air entry present. Patient had 3rd degree burn on left forearm, which covered 5% of total body surface area and had gangrene of fingers. Here in the image, we can see the injured child covered in the oxygen hood. Putting some light on past history. Patient was born in an outside hospital to a diabetic and hypertensive mother at term. Patient developed respiratory distress at birth. Admitted to NICU, suffered electrical burn, most probably due to pulse oximeter. Here in the image, we can see that the palmar aspect of the burnt child with the necrosis in the fingers. Treatment on admission. Moist oxygen inhalation at the rate 4 to 6 liters per minute was given. Intravenous fluid RL was administered with maintenance of target urine output 1.5 to 2 ml per kg per hour. Antibiotics, penicillin, and clindamycin were started. Dressings with hydrocolloid and paraffin gauze were given. Keeping in mind, sulfur sulfadiazine dressings are not done in infants. Child was covered with blankets to prevent hypothermia. Blood was sent for routine investigations. Swab from wound for culture and sensitivity was sent with a normal chest X-ray. Here in the image, we can see a scar formation, necrosis of the fingers, and wet gangrene. Investigation reports on admission. HB 10 gram percent, TLC 35,000, which was quite high, platelet count 2.5 lakh, normal range, which is a good prognosis, CRP 8 mg per liter, serology was non-reactive, coagulation profile was within normal limit, sodium 136, potassium 4.2, which was again in the normal limit. On 5th day, debridement was done under general anesthesia and necessary drugs were given. After debridement, patient was shifted into NICU with moist oxygen support. Treatment for sepsis continued. Here in the image, we can see the debridement done. Investigation reports on day 8. HB 11 gram, TLC 11,000, platelet count 2.5 lakhs, chest X-ray was within normal limits, CRP 4 mg per liter. Culture report showed methicillin-resistant Staphylococcus aureus, and patient was immediately started on vancomycin. On 9th day, it was a big day as skin grafting under general anesthesia was done. Skin graft from baby as well as mother was taken. This case was a first case of allograft in neonate in North Bengal, which is an achievement in itself. Treatment for sepsis and wound dressings continued. Here in the image, we can see split skin graft done using autograft, and in the second image, we can see split skin grafting done using allograft. This first image shows healed hand, second image shows successful graft, third image shows happy mother and baby with successful graft. Patient was discharged on 14th day with follow-up. Heading towards the discussion part, management of neonatal burns is quite different and challenging than adults. Challenges of neonatal burn management are on all levels, from resuscitation, temperature control, pain management, neonatal anesthesia, debridement and excision, and skin grafting. Fluid resuscitation. Extremely difficult for neonates due to undercalculation of fluid requirements by the existing formula. Fluid requirement in neonates is high, but overhydration and cardiac overload to be avoided due to thinner skin and immature renal and immune systems. Calculation of fluid is done using Parkland formula, and maintenance of fluid is done in children using holiday cigar method. Talking about hypothermia, neonates are prone to develop hypothermia due to large body surface area in relation to body weight. immature heat regulating systems, low energy reserves, high metabolic needs. Prevention of hypothermia can be done by providing blanket, close dressing, warming up fluids prior to administration, and encouraging mother to cuddle the baby to provide warmth. If not taken care, it can lead to seizures and convulsions. Heading towards pain management. Poor pain management can lead to hypermetabolism and burns. Pharmacological acetaminophen and NSAIDs are preferred. Opioids given by closed monitoring. Opioids like aspirin to be avoided as they can lead to Ray's syndrome in infants. Talking about neonatal sepsis. Neonatal sepsis can present as irritability, feeding difficulties, isolated tachypnea, hyperthermia, skin lesions like petechiae, septifoci, heart rate more than 160, vomiting, diarrhea, abdominal distension, respiratory symptoms like apnea, cyanosis, grunting, and dyspnea. Management. Supportive care and antibiotics are two equally important components of management of neonatal sepsis. Supportive care includes maintaining temperature, airway, breathing, and circulation. Early onset of antibiotics. First line antibiotics given are penicillin, gentamicin. Second line includes cefotaxime. Third line includes meropenem and vancomycin. Heading towards neonatal anesthesia. Neonatal anesthesia is obviously a difficult condition due to larger tongue in neonates as compared to adults, position of larynx, funnel shaped of larynx, floppy epiglottitis, and larger head with a shorter neck, and the length of trachea is also shorter. Here in the image it can be depicted as well. Heading towards the summary. An 8-day-old neonate brought with an iatrogenic burn injury of 5% body surface area was brought to us. Patient was treated promptly with resuscitation, management of septicemia, respiratory distress, and wound care. 2 surgical procedures were carried out in the patient under general anesthesia with satisfactory results. We were able to save the life as well as the limb of the baby. Here in the image we can see saved limb, and here we can see the happy child. Now moving ahead towards the conclusion part. Neonatal burns are rare, and the management of these burns is extremely difficult, as the exact protocol of the management of these patients are not given clearly. But we have treated patients successfully a severe burn injury in this neonate with a note on how to manage such cases. Immediate and adequate resuscitation, close monitoring, intensive and proactive management of these patients is the cornerstone of the treatment. Here in the image we can see that child is using its treated hand. These are my references. Thank you.
Very good case and very good management also.
Thank you.
Can you tell me one thing, why the sulfatazine is not used in case of the neonates? You have mentioned that there is one thing that in case of the adult, which in the adult burn, you have used something, and in neonates you have used something else.
I said sulfonamide dressing. It is due to because in if in children silver sulfonamide is used, it can lead to kernicterus, it can lead to leukopenia, and children have body surface area to weight body weight ratio higher, which leads to quicker rapid absorption of SSD, leading to sulfa toxicity and methemoglobinemia.
Very good. Another thing you have mentioned that in case of the child, there is you have to, in time of when there is a hydration corrections, you have mentioned that Holiday-Segar formula. Can you able to tell that? What is that formula?
When we have to do fluid management in children, initially within first 24 hours, according to Parkland phenomena, fluid is given. Maintenance fluid is given according to Hager-Segar formula, which includes if the body weight is 0 to 10 kg, 4 ml per kg per body weight per hour is given. If the child is between 10 to 20 kgs, 4 ml per kg per body weight plus 2 ml for each kg more than 10 kgs, and further if it is between 10 to 20, then 60 ml plus 1 ml for each kg more than 20 kg. Thank you, sir.
पता हम सीट भेजते हैं यही है सर घंटे चाहिए क्या सर
Good morning, everyone. My name is Dr. Suryansh Pratik. I am here to represent a topic, a middle-aged man with confusion and cramps, an electrolyte puzzle. The chief complaints of the patient were a 52-year-old male presented with the chief complaints of painful leg cramps, predominantly at night for the past 3 weeks, 2 episodes of confusion over the last 5 days. History of the presenting illness. The patient was apparently well until 3 weeks ago when he began experiencing intermittent painful cramps in both the calves, primarily at night, which progressively increased in frequency and intensity. Patient also gives history of 2 transient episodes of confusion, each lasting approximately 5 to 10 minutes since 5 days before the presentation. During these episodes, family members give history of disorientation, difficulty in recognizing familiar people, incoherent speech, without any associated convulsion, incontinence, or loss of consciousness. It resolves on its own. Past history, the patient had been taking omeprazole 40 milligram 2 to 3 times daily for the past 3 years for gastroesophageal reflux disease. There was no history of fever, trauma, headache, vomiting, visual disturbances, limb weakness, palpitations, chest pain, breathlessness, syncope. There was no history of diabetes, hypertension, thyroid dysfunction, or any other comorbidities. Family history, no family history of epilepsy, metabolic disorder, or sudden cardiac death. Coming to the personal history, sleep disturbed due to the leg cramps, diet mixed, appetite normal, bowel and bladder habits are regular. There is no history of any addiction or alcohol intake. Brief case summary. A 52-year-old male presented with progressively worsening nocturnal leg cramps and 2 brief episodes of confusion in the preceding 5 days with history of chronic use of omeprazole. General examination. Patient was conscious, alert, and oriented. Pulse 78 beats per minute, regular in rhythm. BP 132 by 80 mmHg. Right arm sitting position. Respiratory rate was 16 cycles per minute. Temperature afebrile at the time of presentation. Saturation was 98% on room air. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy or pedal edema was present. Trousseau's sign was positive and Chopstick sign was positive. Central nervous system examination. Patient consciousness. Patient was alert, fully oriented. Cranial nerves were intact. Motor, bulk and tone normal in all limbs. Power 5/5 in all the muscle groups. Reflexes were BIS 3+ positive in biceps, triceps, knee, and ankle jerk. Plantar, bilaterally flexor. Sensory, intact to all modalities. Cerebellar, finger nose test, and heel shin test were normal. Gait was normal. Systemic examination. Cardiovascular system. Normal, S1, S2 heard, no murmurs. Respiratory system, vesicular breath sound heard bilaterally, no added sound. Gastrointestinal system, abdomen was soft, non-tender, no organomegaly was present. Bowel sounds were present. Clinical summary and differential diagnosis. A middle-aged male with subacute onset of nocturnal leg cramps and brief confusion episodes with history of chronic use of PPI. On examination, he was neurologically intact but had positive neuromuscular signs. Differential diagnosis included PPI-induced hypomagnesemia, secondary hypocalcemia, drug-induced metabolic imbalance, transient ischemic episodes, early toxic metabolic encephalopathy. Laboratory investigations. Hemoglobin was within normal limits, 13.5 milligram per deciliter. WBC count was 7,800, which was also within normal limits. Platelet count, urea, creat, sodium, potassium, all were within normal limits. Magnesium was found to be 0.6 milligram per deciliter. Corrected calcium was 8.1 milligram per deciliter. Phosphate, TSH, vitamin B12, parathyroid hormone, ECG, NCCT head, and even ABG was found to be within normal limits. Treatment. The patient received intravenous magnesium sulfate 2 gram every 8 hours for 3 doses, followed by oral magnesium oxide 400 milligram twice daily. Oral calcium carbonate 500 milligram twice daily was added briefly. Omeprazole was stopped and replaced with ranitidine 150 milligram twice daily. He was advised a magnesium-rich diet. Follow-up. At 1 week follow-up, symptoms had resolved. Serum magnesium was 1.9 milligram per deciliter and corrected calcium was 8.8 milligram per deciliter. Neurological examination was normal. Oral supplementation was continued for 3 weeks with monthly magnesium monitoring planned. Conclusion, hypomagnesemia may present with vague neuromuscular and neuropsychiatric symptoms. Classical signs such as carpopedal spasm and positive Troisier sign can provide important clinical clues. Chronic PPI use is a common but under-recognized cause. Timely evaluation, including magnesium levels, when initial labs are inconclusive, is crucial. Discontinuing the offending agent and correcting the deficiency results in the rapid and complete recovery. Routine magnesium monitoring should be considered in a long-term PPI users, especially when unexplained neurological or muscular symptoms occurs. Discussion. Proton pump inhibitors can cause significant magnesium depletion by interfering with active intestinal absorption via TRPM6 and TRPM7 channels. Symptoms may include muscle cramps, tremors, fatigue, and even altered mental status or seizures. In this patient, carpopedal spasm observed during the BP measurement raised the clinical suspicion of latent tetany due to the electrolyte imbalance. While sodium, potassium, calcium, ECG, and PTH were normal, low serum magnesium ultimately explained the neuromuscular sign and the secondary hypocalcemia. The chronic high-dose omeprazole use was the only identifiable cause with no evidence of renal or GI magnesium loss. This case underscores the need to consider hypomagnesemia in patients with the neuromuscular symptoms, especially those on long-term PPIs. Clinicians should be vigilant and include serum magnesium in the routine monitoring of high-risk patients to prevent complications and guide the therapy appropriately. Thank you.
Thank you for a nice presentation. Is there any role for cholecalciferol and magnesium combination drug?
Ma'am, magnesium itself regulates the parathyroid hormone. So if magnesium is deficient, it will cause resistant hypocalcemia. The bones won't be able to absorb the calcium. So there the magnesium comes to play a role.
So you are advising magnesium alone, intravenously?
Yes, ma'am. IV magnesium was given first for 3 days, and after that, ma'am, calcium supplementation was given on discharge.
Okay.
This patient presented to you with a history of nocturnal muscle cramp.
Yes.
So why this patient have hypomagnesemia, don't have any daytime muscle cramp? Only there is a nocturnal muscle cramp.
So
or in other words, I will want to know from you, then in nocturnal muscle cramps, which conditions are more common that may not present in this patient, but you have to think about in a nocturnal muscle cramp or these things?
Peripheral vascular disease and basically during the night time the patient has the blood flow is reduced to the legs plus the electrolytes are exchanged during the night.
Peripheral vascular disease, can the muscular cramps in the night times or it is in
It will be during exertion.
Then
And during rest.
so actually in nocturnal muscle cramp,
Hypocalcemia.
which situations you have to face?
In hypocalcemia there will
Have
be
you think about the restless leg syndrome?
But he complains of the muscle cramps in the calves, specifically in the calves.
But
Not
you have
of-
specifically, you have mentioned that this patient is only present these cramps only in the night times.
Yes, sir.
But if a patient is having a hypomagnesemia, that patient should also have been presented with also the daytime cramps also. Why there is only the night times cramps?
Thank you.
Dr. Taranjot, Yes, sir. Good morning, sir.
Yeah, good morning. You please share your slides.
Sir, I have shared the slide. Wait, I'll do it again. Sir, are the slides visible?
Yes.
Okay, sir. Good morning, everyone. This is Dr. Taranjot Singh, JR2 of Department of General Medicine, MGM Medical College and Hospital. Today, I am going to present a case which is a rare addiction in Indian setup of tramadol addiction. We received this case in our OPD. So, tramadol is a synthetic opioid used for moderate to severe pain, acts via mu opioid receptor binding with inhibition of serotonin or norepinephrine reuptake. Chronic or high dose use suppresses the CRH and ACTH, leading to decreased cortisol, further leading to adrenal insufficiency. Rare but increasingly recognized with opioid misuse these days, specifically in Southeast Asian population and in the east of the world. So, he was a 27 years old male worker at a petrol pump, presented to OPD with swelling of body since last 6 months, which started with face, later involved the lower limbs, which was gradual and progressive in nature, associated with darkening of skin, specifically the palmar creases and the knuckles of the hand. Patient also complained of purplish lesion over abdomen, which he developed gradually over the last 6 months. He also complained of swelling of the left leg since past 15 days, which was warm, red, and tender with shiny skin. Over the time, he has also developed shortness of breath, which was more on exertion and was relieved on taking rest. He was a known case of hypertension since the last 2 months, but he was not on any medications, as according to the patient, he developed a localized allergic reaction around the lips on taking medication, though there was no official document of him being hypertensive, or and the medication which he was taking was telmisartan 40 mg. There was no documents for this. On taking further history, he gave history of taking tablet Spasmoproxivon Plus, which is a combination of dicyclomine, tramadol, and acetaminophen for recreational purposes since the last 2 years. He started to take these medications 2 years ago under peer influence for recreational purposes. He started with 1 to 2 tablets per day, and along the course of 2 years, he ended up consuming 15 tablets per day as he developed tolerance as the course of time. If somehow he delayed the dose or skipped the dose, he started to feel anxious and generalized weakness in the body. 6 months ago, his presentation in the OPD, he decided to stop taking the pills, and he stopped it abruptly and did not took any since then. He had a history of smoking, but he left 10 years ago. There was no history of alcohol use. He did not have any other comorbidities, and he was not on any other medications. So now we come to the clinical examination of the case. On clinical examination, purple abdominal stria was present, hyperpigmentation of the skin was present, pedal edema was present, the mental functions, higher mental functions were normal, no muscle weakness, and all the deep tendon reflexes were intact. This is the picture of the purple abdominal stria, which we appreciated in the OPD when the patient came. In this picture, we can clearly see the hyperpigmentation in the palmar crease. This was the pedal edema of the patient. Now, general physical examination. The patient presented with general body edema, face followed by the lower limb. Left lower limb was having erythema, warm and tender. Hyperpigmentation of palm creases, knuckle, purple abdominal stria. Pallor was present. Vital signs all within normal limit. Cardiovascular system examination, all within normal limits. Respiratory system examination, mild basal creps present, rest within normal limits. Central nervous system examination, all within normal limits. On doing the investigations, the hemoglobin was 8.2. He was slightly anemic. WBC count was 21,710. SGOT was more than SGPT. SGOT was 112 and SGPT was 47. CRP was raised in the tune of 24. Sodium was slightly on the lower side, 128. And potassium was mildly on the higher side, 5.2. On 2D echo examination, it was LVF was 45%. We did early morning cortisol, which came out to be critically low, which was 0.07, and ACTH came out to be 8.2. From this, the history and the symptoms and the clinical examination, and further low morning cortisol and inappropriately low subnormal ACTH, we came to the diagnosis of secondary adrenal insufficiency, which was caused due to the tramadol, which the patient has been consuming since last 2 years. So, chronic opioid suppresses the CRH and ACTH secretion, which leads to the HP axis suppression, reduced adrenal cortisol production. This is often reversible after stopping the opioid, but it may take months to years depending upon how much duration the patient has been consuming the drug. Other differentials which came to our mind initially was primary adrenal insufficiency, any pituitary disorders, chronic liver or kidney diseases, hypothyroidism, or drug-induced AI from any other agents apart from tramadol, which the history was taken and was willfully ruled out. So what management we did, as he was not taking any drug at that time, offending drug, so it was stopped, so nothing was to be done. If he was taking the drug, we would taper it down slowly. Glucocorticoid replacement therapy was started. Hydrocortisone was preferred. We monitored electrolytes, BP, and other symptoms. Long-term follow-up for HP axis for recovery has been advised, and the patient is currently on follow-up. It's been a few months, and he's been on monthly follow-ups. Now, the conclusion of my case report. This case report reveals the significance of recognizing the potential impact of tramadol on adrenal function, particularly in individuals with prolonged or high dose usage. Despite being a rare occurrence, tramadol-induced adrenal insufficiency can have serious consequences if left unrecognized. It is critical for healthcare providers to consider the possibility of adrenal insufficiency in patients with a history of long-term opioid use, especially when presenting with non-specific symptoms such as fatigue, weakness, skin changes, or abnormal vital signs. Early diagnosis and appropriate management and tapering down or discontinuation of the positive drug are essential to preventing the further complications. Thank you.
Taranjot,
Early diagnosis and appropriate.
can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Now, if you treat this patient, how do you, apart from your adrenal supplementation, how do you de-addict the patient from this tramadol?
How do we de-addict the patient from
Yeah.
tramadol?
What drug you should use? Because you know how these drugs affect this
Sir,
endogenous opioid receptors are altered, no, due to this tramadol. So what you do?
sir, we start with initially we start to taper down, and then naltrexone, clonidine.
Naltrexone. You have to
We
give
can use
naltrexone.
clonidine,
Naltrexone you have to give. Because the
naltrexone,
endogenous,
ibuprofen or clonidine can be used.
yeah, clonidine is also used. Okay. Thank you. Any question from your side? Good case.
Thank you, sir. Thank you.
Record.
Thank you, Honorable Chairpersons, for your valuable time, guidance, and for conducting the session with such grace and academic rigor. This concludes the platform presentation segment for today. All chairpersons and participants can collect their mementos from the registration desk. We now move on to the poster presentation. Poster presentation participants are requested to move to Hall 2, and I also request the esteemed judges who are evaluating the Group A poster presentation, Dr. Supriyo Sarkar sir and Dr. Nandini Chatterjee ma'am, I will escort you to Hall 2. Please accompany us. Thank you so much.
We now proceed to take our scientific program forward and begin with the session titled Research Session. I humbly request the Honorable Chairperson for this session, Dr. Ashish Saha sir, Professor and HOD Department of General Medicine from Jagannath Gupta Institute of Medical Science, Bajbaj. Dr. P.K. Agarwal sir, Professor and HOD Department of General Medicine from Katihar Medical College, Bihar. Dr. Malay Vikas Mandal sir, Professor and HOD Department of Physiology from Mata Gujri Memorial Medical College. And Dr. Gautam Sarkar sir, Professor and Department of Community Medicine from Mata Gujri Memorial Medical College, to kindly come up on the dais and take the proceeding forward.
Good morning. This is the session 2, research session. We call upon dais Dr. Ashita Budev Rai to give lectures on research and publication, introduction part.
A very good morning, everyone, and a warm welcome to all the delegates for this ICP-CON here. So, since we are running behind time, we will not take much time for this session. We have decided that we are 3 speakers, so we'll speak maybe 8-10 minutes each, because we'll again have the inauguration session at 11:15. Now, I have been asked to speak on how to write introduction for a research paper. Now, all of you must be knowing about pop music. But what is pop in research? Any idea? The pop culture is publish or perish. Now, this is followed in many institutions, that if you do not publish, you have to perish. Now, with this in mind, we also have the NMC guidelines for the faculty members to publish for promotion. We also had guidelines for the postgraduate students to publish before they appear for their final examinations. But of late, that has been made optional. Now, coming to my topic, learning objectives, By the end of this session, the listeners shall understand. I have specifically mentioned listeners because many of you might not be listening. Purpose and structure of an introduction, how to build a logical flow, common mistakes to avoid, and useful templates and examples. So this introduction, when you write for a research paper, is basically the gateway that gives you a first impression. Now, whenever if you all are experienced in sending research papers to publishers or to journals, you will see that many of the time that it is rejected at the desk. So it is called desk rejection. Now, desk rejection, the first impression for a desk rejection is the abstract and the introduction. If your abstract, the title, abstract, and introduction are not proper, the articles are mostly rejected at the desk. So that is why introduction has to be the gateway, the first impression of a paper. Now, what is an introduction? It sets the context of the study, shows why the topic is important, identifies the gaps in the existing knowledge, and it leads the reader, basically your audience, to your research question. So to write an introduction, what we follow is a funnel approach. That is from a broad base to a narrow bottom. So that funnel approach, you have to start broad, then narrow down to identify the gaps, and finally state our aims and objectives. So the crux of this session, the take-home message from this session is basically this funnel approach. PGTs who are attending this, please keep in mind this funnel approach will help you to write the introduction. So whenever you are writing the introduction, give a first 2-3 sentences should be on the broad context. Then you come to the, what has been told in the literature, what are the gaps, and then your aims and objectives. So stepwise, it is the background and the context first, then the problem statement, then the gap in the knowledge, and finally your aims and objectives. I'll break down these steps a little bit. So the first step is, as I said, to provide a general background. So in this general background, what you do is you include the basic concepts, some global and national trends of relevance, some data, definitions if required, and some brief epidemiology if associated with your research question. Then coming to the step 2, which is the existing knowledge. What is already known about the subject? That is very important. So you have to summarize the key studies. Now this, you have to keep in mind, this is not a literature review. The introduction, the word limit is around 400 to 500 words, depending on the journal requirements. But then you have to summarize whatever is there in the existing knowledge. What is known? So the tip is you use 5 to 7 strong references, strong and updated references to instead of keeping long descriptions. Then you identify the research gap. Now, whenever you are writing a research paper, you cannot rewrite a previously existing paper, right? You cannot copy paste, or you cannot take the idea and just elaborate. You have to find out what is the gap in the already existing knowledge. So that gap you have to address. So you have to show the inconsistencies in the literature, the unanswered questions, previously published literature, if it has any unanswered questions, lack of local data. Now, maybe this particular topic of importance has been published somewhere else, somewhere maybe down in Tamil Nadu, Kerala. But what is the local data here in Kishanganj, Bihar? Any technological or methodological limitations. If there were any technological, methodological limitations in the previous study, you may address those limitations in your research. Step 4 is the most important thing. Why do you need this study? The rationale behind the study. Now that is what explains why the study is necessary, the public health importance if at all, any clinical or educational value. If you are doing a study, if it is providing any clinical value to your therapeutic regimen in going forward, or any educational value maybe in teaching, learning, and also some policy implications if there. Finally, the last step is to clearly state the aims and the objectives. Aim is a broad thing which your research paper will denote, and the objectives has to be the specific objectives. I'll show you some example. Now, I don't know how legible it is from the audience, but if you see in a recently published paper of mine, which was on International Academy of Cytology Yokohama system in the evaluation of male breast lesions, the first sentence here is, structurally male breasts like those of females are made up of both glandular and fatty tissues. You see, it's a very broad thing, broad sentence that we are addressing. That what is basically when we are talking about breast, so what is breast composed of? And then when we finally end the introduction, here we write that with this background, the objectives of the study are. So we are enlisting the objectives here at the end of the introduction. Similarly, here is also another study where we have seen the students' perception of problem-based and limerick-based learning methods. Here also, we started with the traditional lecture methods. What are the traditional lecture methods? And finally, here at the end, we are saying the aim of the present study was to implement PBL and LBL methods. So finally, the concept again, to reiterate the facts, that you start with a broad base and narrow it down to aims and objectives, again the funnel approach. Now what not to include? So it's also important to know what we should not do. So we should not include a detailed methodology in introduction. Results or conclusions cannot come into the introduction. You do not write an overtly long literature review, any irrelevant history, or personal opinions. Don't give your personal opinions or anything which is unsupported, no reference. You're just writing out of the blue. So those things are not recommended. So basically the structure of the introduction should be first paragraph, general background, second paragraph, what the studies show, the existing studies, third paragraph is the research gap, what is not known, fourth is the need of the study, why do you want to do the study, and finally the paragraph 5 is the aims and objectives. So a quick mnemonic, so we all shorten it down to intro. So when we call it intro, I is identify the broad context, N is narrow it down, T is tell what is known, R is reveal the gap, and O outline the importance or the rationale of the study. So to conclude, I started with that the pop culture in research, that is publish or perish, but I would rather say don't come under the pressure of publishing, rather publish and prosper academically. So it's better to use the term papa than the term pop. Thank you.
Wonderful presentation, Dr. Rai. As you know, research is the backbone of any scientific progress. And morning shows the days. Any research paper, the introduction is the backbone. And you have rightly included all the important points, particularly in your mnemonics, intro. This suggests the important points a researcher must keep in mind. Thank you for your wonderful and lucid
Thank you so much, sir. Thank you all the chairpersons for your presence here. Thank you, sir. Sir, you have a question? Yeah.
Just a minute. First, I congratulate and appreciate your very nice and excellent presentation. So here to tell that Dr. Ashida Devrai is also Vice Chancellor, Vice Principal and HOD in the Department of Pathology. So this was, I think, missing. And regarding, I wanted to make a small comment that though you have narrated, you have described wonderfully, and very nicely, sometimes that introduction comes in the beginning, just after abstract. So sometimes it may be written after completing everything. Yes, that right. Last part, as a last, though it comes in the first, but it may be convenient to write it at the later.
Yes, right.
So that point I wanted to make. Thank you very much.
Thank you so much, sir. It's also very nice to see Ashish sir back on the stage in the same institution. Thank you so much. Thank you.
One thing, can I divide the objectives into primary or secondary?
Yes, sir, surely. That can be done.
That can be done.
Yes. Thank you. Thanks.
Our next speaker is Dr. Deepmala Das. She will be talking on the methods. So she is HOD and professor, Department of Microbiology of this Mata Gujri Memorial Medical College. Madam Deepmala, please.
Thank you, sir. If chairperson allow me, can I start? Yeah.
Please.
Respected faculty members and my dear PGTs, today I have been allotted to speak on the topic how to write the methodology for a research paper. Although it is a big topic or a long topic, Uttam sir has told me you have to finish within 5 minutes. So I cannot take more than 5 to 6 minutes. And mostly, and I have, this topic is for the postgraduate students. And as my Professor Asitavo has already told you about that why we are publishing. What is the purpose of doing research? The answer are actually to finding facts, to establish already existing facts, or finding something new. But in our career, or as postgraduate trainees also, you are also under pressure that I have to present a paper, ma'am, I have to present a poster, ma'am, again you come, ma'am, do I have to publish a paper, ma'am? So all these are the pressure you are now, it is taking to publish or present a paper or poster. Again, for the faculty members who are working in a medical college, if I present this slide, if you see, for the post of professor, see the point B, have published at least 2 research publications after becoming associate professor and must be among the first 3 authors. All these pressures are on us. And for this, what is happening? The quality of research is not improving, in my opinion. Others might differ in this. So, as the first speaker has said, the pop culture, I have quoted 2 reports. There are many reports or on the news items are coming on the publication, not from our country, but from different countries, also from developed countries, like this. This Indian watchdog is cleaning up mess in academia, and this report is from very top institute like IITs. This year only many good universities have been named for false publication. That I will come to it. But as my topic is on the methodology, now I will come to my proper topic. Now this I will skip. Coming to the methodology, it can be named as materials and method also, because as the researchers in medical college, many times we use samples to study, as like we in microbiology, pathology, we deal with samples. Okay. So what will be the methodology depends on the study design. So whenever you write the methodology, that there is a subheading called study design. Now, what are the study design? All the postgraduate students and also the faculty members have to clear the BCBR that exam, and that is a very good structured program. And if you see, these are the types of studies from the lower: case series, case control studies, cohort studies, then the randomized control studies, systematic review, and the meta-analysis. These are the evidence-based studies. Again, we can divide the studies on the basis descriptive or analytic, and analytic studies can be observational, or again, it can be experimental, and experimental and observational, the analytic study. So in this cross-sectional cohort, then in the experimental studies, it will come the randomized control studies, case control studies, like that. And on that basis, the methodology you have to write. In my next slide, I have mentioned when you prepare a sabji, if the ingredients has to be perfect and the sequence has to be perfect. Like that, when you write the methodology of a paper, then it has to be proper in a sequence to publish in a good journal. Why I am saying a good journal? If you can write a paper, you can publish in predatory journal. There is no problem. But if you want to publish the journal in a Scopus index, PubMed index, which is important for us, then you have to write a good paper. And before writing this, already I am crossing 5 minutes, I think, there should be a blueprint, and writing and rewriting will improve your methodology. And what are the points that have to be included in methods are the participants or the sample in case of microbiology, pathology. Then you have to include the inclusion criteria and exclusion criteria, the sampling method, okay, that you have to include, sample size, that you can take help from your PSM department, research tool. Now, what are the research tools? Anyone from backside? Like it can be a questionnaire or a survey tool. Any online survey tool, anyone can name this row? Google Form is, you can use like monkey survey. Have you heard of that name? That can be used. Okay, then coming to the data analysis technique or data management. The postgraduate students, anyone? The common we are using for decades, SPSS. And now the students are using R, Python. Okay, these are the tool, analytic tool they are using. Then we have, very important is the ethical consideration, institutional review board. You have to take permission, consent, and very important is confidentiality of your work. One thing I have not mentioned, what is that? In that, the list. That is the funding agency. If you are planning a very big project, you have to write the protocol, and for getting funding from a big agency like ICMR or other, then you have to also, and you have got the funding, you have to mention in the methodology about the fund, okay, where from you have got. Now, if in the second or third slide, I have mentioned about data fabrication, data falsification. Now, what is fabrication? Data fabrication is the making up of data, okay? And we should not follow this. Whatever you get, that you should publish. And what is falsification? Manipulation of your data, okay? Sometimes when we put our data in Excel, there are some data missing. But there is a statistical protocol how to fill up the missing data. I think Dr. Alapani was there from PSM department. There is a proper protocol how to fill up the missing data. So we have to follow that. Another thing is, yeah, he is there. So plagiarism. What is plagiarism? Copying of the text from one journal to other. No, we can do that, but we have to give reference and we have to do modification. Okay, but we cannot copy that. Now, again, for the PGTs and also interns are there, what is salami publication? Anyone? You have done one work and you are slicing that and publishing in different journal, that is salami publication. And as researcher, we should stop all this. And in all these things, we have to keep in our mind and do our research. And then I think our research will be more genuine, and all this news regarding our fraternity and our researcher will not come and publish. Thank you so much.
Thank you, Dr. Deepmala, for your excellent presentation. Any question from audience regarding this? From the PGTs? PGT should ask.
Yes, this, okay.
Okay,
Sir is
thank
there.
you.
Maybe in the next tea time, it may be
You can ask.
considered.
Yes, okay. Thank you.
Last, Dr. Uttam Kumar Pal, Professor, Head and Department of General Medicine, MGM Medical College and LSK Hospital, Kishanganj. His topic is research and publication discussion part.
Respected chairpersons, respected faculties, delegates, and my dear postgraduate students, you are going to print and publish your thesis, and also you are going to publish articles. So discussion, how to write discussion, it is most important. So all of you know this emirate structure. When you ask my postgraduate student what are the parts of an article, most of the students starts with abstract like that. But you have to remember this IMRAD structure. IMRD. I for introduction, M for methods, R for result, D for discussion. RA, small a is there. Result and analysis. That's why RA. The discussion, what do your findings mean? That is discussion. Introduction, what question did you ask in your primary objective as well as secondary objectives? Methods, how did you answer the questions put in your objectives? Result, what did you find it in your study, what you have find. Main functions of discussion part, you have to answer your primary and secondary objectives and how the results support your objective. This is main. This is the main part of discussion. Highlighting new and important finding. What important finding you have got from your study? Identify the core point. Correlate and explain. Avoid repetition. Due to lack of time, I am starting short. This thing you remember, I will tell only this slide. Component of discussion section, highlighting new and important finding. Correlating the findings derived from your results. Corroborating with the previous works, what you have studied from the literature review. Summarizing the implications of the current work. Identifying contradicting and unexpected finding. Stating the limitations of the methods used. Providing a concise conclusion. Suggesting further and future areas of research. Next slide is very important. Main elements of the discussion. First, you explain your finding, what you have find out from your result. Then compare the findings with the previous studies. Then evaluate your findings. Then take an inference. When you take an inference, you can develop your own viewpoint and ideas based on the facts and result. Do not leave findings in the statistical form, as no one would be able to understand. Make sense of your findings. Be creative and do not be afraid to speculate. Corroborating and contrasting with previous work, corroborate, support the existing knowledge, identify contradictions, address discrepancies, and provide reasoning regarding the discrepancies. Summarizing the implications of the current work, broader impact, generalizability, be specific. And this is main element in the conclusion, how you will conclude your study, integration of your study, findings plus analysis, plus interpretation, plus synthesis. Then it is your conclusion. Acknowledging study limitation, providing concise conclusion, stating limitations, impact assessment, concise conclusion. Suggesting further and future areas of research. What are the unanswered questions from your studies? That will be the future research. Methodology improvements and new direction of the study. This will be your future research. Checklist. Your discussion part should be clear, coherent, it must be credible. What new things you are contributing in the scientific field, that is contribution and conciseness. Thank you. Thank you for patient hearing. Any questions? If there is any questions, and in the tea time, I am always here. You can ask any time. Thank you.
Thank you, Dr. Pal.
We conclude the session.
Thank you so much for this enlightening session. We extend our sincere gratitude. Now we'll be requiring 5 minutes for arranging the dais for a very important milestone in our scientific program. That is the inauguration ceremony of ICP-CON 2025. Please be seated. We'll be taking 5 to 10 minutes for arranging the dais. Thank you. We now arrive at a truly significant milestone in our scientific program, the inauguration ceremony of ICP-CON 2025, marking the first ever Bihar-Bengal joint venture. It is indeed an honor to commence this landmark event. With great pleasure, I now invite Dr. Vibleen Kaur to kindly take over the proceedings and lead us forward.
Thank you, Harsimar. A very warm good afternoon to this distinguished gathering of luminaries, scholars, dignitaries, and esteemed guests. Today, history is being written within the walls of Mata Gujri Memorial Medical College and Lion Seva Kendra Hospital, an institution that proudly carries 34 glorious years of service and selfless dedication. It gives me immense pleasure to present to you ICP-CON 2025, that is Indian College of Physicians, first ever collaborative conference between the medical fraternities of Bihar and West Bengal. It is my privilege to stand before you representing this momentous inaugural celebration. I request our ushers to courteously escort our dignitaries to the stage. With deep reverence, I call upon our organizing chairman, respected Dr. Uttam Kumar Paul Sir, HOD General Medicine, MGM Medical College, to please come on dais. I request Dr. Faria Zainin to please escort Dr. Uttam Kumar Paul Sir on dais. I invite our distinguished chief guest, guest of honor, Dr. Jyotirmoy Paul Sir, President National API, to please come on dais. I request Dr. Farhan Hashmi to please escort Dr. Jyotirmoy Paul Sir on the dais. Now, with utmost respect, I invite our honorable special guest and inaugurator, guest of honor, Dr. Sudipta Bose Sir, Vice Chancellor of MGM Medical College, to please come on dais. I request Dr. Jyoti to please escort respected Dr. Sudipta Bose Sir on the dais. With great honor, I invite guest of honor, our Registrar Sir, respected Dr. Ishit Bharat Sir, Registrar MGM Medical College, to please come on dais. I request Dr. Rashid Rizwan to kindly escort respected Dr. Ishit Bharat Sir on the dais. I welcome our guest of honor, Dr. Bijan Chandra Datta Sir, Principal MGM Medical College, to please come on dais. I request Dr. Vishi Pragyan to kindly escort respected Dr. Bijan Chandra Datta Sir on the dais. Our guest of honor, Dr. Asiteva Debroy Sir, Vice Principal MGM Medical College, to please come on dais. I request Dr. Faria Zainin to kindly escort Dr. Asiteva Debroy Sir on the dais. Our guest of honor, Dr. R.N. Sarkar Sir, Chairman ICP, West Bengal Chapter, to please come on dais. I request Dr. Jyoti to kindly escort Dr. R.N. Sarkar Sir on the dais. Our guest of honor, Dr. P.K. Agarwal Sir, Chairman API Bihar Chapter, to please come on dais. I request Dr. Vishi Pragyan to kindly escort Dr. P.K. Agarwal Sir on dais. Our guest of honor, Dr. Assis Saha Sir, API Secretary, West Bengal Chapter, to please come on dais. Request Dr. Faria Zainin to kindly escort Dr. Assis Saha Sir on dais. Our guest of honor, Dr. P.S. Karmakar Sir, Chairman Scientific Committee and Secretary ICP, West Bengal Chapter, to please come on dais. I request Dr. Jyoti to kindly escort Dr. P.S. Karmakar Sir on dais. Our guest of honor, Dr. Atul Bed Sir, Organizing Secretary, to please come on dais. I request Dr. Rashid Rizwan to please escort Dr. Atul Bed Sir on dais. Now, the felicitation of distinguished guest on dais. May I request Dr. U.K. Paul Sir to felicitate our chief guest, Dr. Jyotirmoy Paul Sir. Fast. May I request Dr. Deep Mala ma'am to felicitate our special guest, Dr. Sudipto Bose, sir. May I request Dr. P.S. Karmakar, sir, to felicitate our guest of honor, Dr. Ishit Bharat, sir. May I request Dr. Atul Bed, sir, to felicitate our guest of honor, Dr. Bijan Chandra Datta, sir. May I request Dr. Animesh Dev, sir, to felicitate respected Dr. Asiteva Debroy, sir. May I request Dr. U.K. Paul, sir, to felicitate respected Dr. Asiteva Debroy, sir. May I request Dr. Kela NVSS Prashu, sir, to felicitate respected Dr. R.N. Sarkar, sir. Now may I request Dr. Vanna Kumari ma'am to felicitate respected Dr. P.K. Agarwal, sir. Now I request Dr. Pranav Devre, sir, to felicitate respected Dr. Assis Saha, sir. I again request Dr. Deep Mala ma'am to felicitate respected Dr. U.K. Paul, sir, respected Dr. P.S. Karmakar, sir, respected Dr. Atul Bed, sir. Yes. Light symbolizes knowledge, purity, and the eternal victory of truth. I request Honorable Chief Guest, Honorable Special Guest, Honorable Registrar Sir, and other honorable dignitaries for lighting of the lamp, marking the auspicious, radiant beginning of ICP-CON 2025. Every milestone deserves to be etched for prosperity. I request our honorable dignitaries to kindly unveil the souvenir. May I request Dr. P.S. Karmakar sir for very next important felicitation of ex-faculty members. Okay. Okay. I request the illustrious Dr. Uttam Kumar Paul sir for welcome address to our delegates.
Respected dignitaries in the dais, respected faculties, respected delegates, and my dear postgraduate students from this institute and other institute from Bengal and Bihar. I welcome you all in this scientific feast, which is well planned. I think everybody will enjoy this scientific program. Thank you all.
Thank you, sir, for your warm welcome to our delegates. We now welcome the Honorable Vice Chancellor, sir, Dr. Sudipta Bose, sir, to offer their valuable insights.
Thank you. A very good morning to all of you. Honorable Director in absentia, respected Registrar Mata Gujri University, respected Principal, Vice Principal, dignitaries, resource people, all faculty members, my dear students, both undergraduate and postgraduate, all categories of staff, ladies and gentlemen. It is indeed a proud privilege for me to welcome you all to an unique occasion. I've been told that this is the first of its kind where two states, Bihar and Bengal, have combined together in the eastern part of India and in this institute also. It has been very well planned. But I'm sure the faculty members who have been spending time over all the topics of discussion involving as many as specialities as possible, and that it will be a wonderful program. And here I would like to sort of highlight particularly the postgraduates, the amount of interest with the authorities here take. No stone is left unturned in case of educational excellence and performance. It is up to you to carry on with it. I give a warm welcome to all the delegates who have come in this weather, but this is a beautiful place, weather is good. I wish you all the best and a grand success for this conference. Thank you.
Thank you, sir, for your words of wisdom. Now I invite our distinguished chief guest, Dr. Jyotirmoy Paul, sir, to share their word of wisdom with us.
Respected Honorable Vice Chancellor, Principal Sir, Vice Principal, Registrar, Chairman of API Bihar Chapter, Chairman ICP Bengal Forum, Secretary API West Bengal Chapter, Dr. P.S. Karmakar, Dr. Uttam Pal, all the dignitaries, students, ladies and gentlemen. I am extremely happy as President of Association of Physicians of India that first Bihar, Bengal together jointly is conducting ICP-CON one-day program, 2 days program rather, in Medical College campus of Kishanganj Medical College. The day I was dean 2 years back, from that time I advocated that the program, API program, should be mostly held not in 5-star hotels, but should be in academic institute, particularly in the medical college campuses. There is mushrooming of medical college across the India. So this organization has a special role. Why? Because so much medical college, medical infrastructure or the availability of teacher is not even across the country. So our organization have an immense potentiality. All the faculties, specialties, all starting from cardiology to hematology, nephrology, and senior professors of the medicine are in our fold. So we can help to fill up the gaps where there is some deficiency of some faculties or some infrastructure or whatever may be. So from that viewpoint, we advocated there is the faculty development, ICP faculty development program, where if any medical college wish to conduct one-day program with a particular, inviting a particular faculty from any part of the India of any specialty, headquarter will bear the faculty's logistic. Only the local logistic should be taken care by the medical colleges. And from this project, even in Andaman, people are very happy where no such ICP program has happened. This year, we have conducted program in Andaman. And Professor Shoikat Datta from Coach Bihar personally went there, taken a whole day classes there. And such a program even we prefer to do in all the remote places. So API from its born 1944 is committed for academics, for publication, for the research. For the research, we advocated that India is ahead in every field, maybe from space technology, defense technology, IT, but not so in medical research. So basically, while formulating our protocol, we should develop our guideline, our protocol based out on our data. But we are heavily dependent on the Western data because our research infrastructure is not so good. So that is why API is trying from last couple of years to improve the research infrastructure. Particularly, API has not so much money to invest in the API, but what we can do, what our faculties can do, what our branches can do, can motivate the student, can motivate or teach the student regarding the research methodology, or we can increase the awareness or interest of the research among the younger generation. So my request to all the senior faculties, at least you take some project in your institute, maybe of low budget research, just to increase the interest of the younger generation, so that even after 30, 40, 50 years, India can develop guidelines on its own. My request to all younger generation, you diagnose so many good cases, but it is not published. So now API has a 2 journal, one traditional JAPI, everybody knows, but from this month we started another journal, there is the API Case Report Journal. You can go to the website www.apijcr.com, and here you submit your best cases, because India has so many good cases, but if we do not publish it, the world cannot see what we can do, what we can diagnose. So our cases, best cases, will be cited even by the Western literature. So this will increase the prestige of your institute worldwide. Finally, what I want to say, that API is committed not only for the academics, research, publication, also the touch with the people is very important, because I have seen many boards in the college campus that what Swamiji has told, if you serve the mankind, you are serving to the God. So you have to, along with your curriculum in the research, in academics, in publication, give some time, devote some time, and organization also, give some money, whatever you will save out of the conference, for the direct public benevolent activity, because doctor-patient relationship is a challenge in this decade. So we should do some activity that directly touches the people. We are doing everything for the people. We are seeing the patient in OPD, indoor, we are doing the people, but still there is some gap between the doctor-patient relationship. So my request to all the leadership of every state, all the Bengal, Bihar and other state also is there, Odisha also there. So give some time, motivate students, take the student to participate in the different camp, health awareness program. Even when there is a large gathering like Ratha Yatra, Ganga Sagar Mela, or there is some flood, what our North Bengal, Dr. Dipanjan, Dr. Shekhar, Dr. Shoikat Datta has done during the flood in North Bengal, they have taken the student in the flood victims area and done very successful camp. Such type of public activity can increase the bondage between the doctors and the people. And I think this will be the future direction of the API members and younger generations. So I hope along the academics, research, publication and public benevolent activity should be the future aim and objective of API. Thank you. Jai Hind, Jai API.
Thank you, sir, for your gems of knowledge. Now, with great honor, I invite our Honorable Registrar, Sir, Dr. Ishrat Bharat, sir, to deliver their inspiring guiding thoughts.
Honorable Vice Chancellor, Mata Gujri University, Principal, MGM Medical College, Vice Principal, API President, National President, all guest faculty members, and delegates. First of all, on behalf of this university, I welcome you all in this national conference, ICP-CON 2025, in Mata Gujri University, Kishanganj. This is the 9th national conference we are organizing in this university this year. I always tell two things is important in any medical institution. One is academic activities. Second is clinical material. Clinical material means patients. We are having more than 3,000 patients per day. 3,000 patients per day in our OPD. We believe We believe in service to man is service to God. The theme of this conference is importance of scientific diagnostic in today's era of medicine and health. And I'm sure that this will boost up the knowledge of all the delegates and especially the PGTs for their upcoming journey. I extend my heartfelt gratitudes to all the guest faculty members who have traveled across from the country to make this conference a grand success. I can see the faces. Dr. Sanjay Ghosh sir, dermatology, he was my guide, thesis guide when I was doing my PG. I can see Dr. Ashish Saha sir. His wife treated me as a son when he was in HOD in this college, general medicine HOD. I can see Dr. Anita Datta ma'am. She was HOD when I was doing MBBS in this college. So it's a nostalgic feeling. And I personally very much thankful to the organizing committee, the organizing chairperson, Dr. Uttam Pal sir, HOD General Medicine, Dr. P.S. Karamkar, organizing scientific secretary, for organizing this conference in this university in a very systematic way. What I have observed when I was sitting downstairs, Dr. P.S. Karamkar and Dr. Uttam Pal is doing the name tag. Serially वो कर रहे थे खुद से. तो this is a very tiny things, बहुत छोटी चीज है ये, but इससे ये पता चलता है कि dedication कितना है. This shows the dedication of the organizing committee. Even the name tags has been arranged by the organizing chairperson. So I think in the upcoming days, we will organize more conferences in this university. And this is the 9th one, and we are last of this year. So in 2026, I hope this university will organize more than 15 national conferences. For this, we will always give support, management support, for all the departments, not only medicine, for all the departments to organize the conferences in the university. Honorable Vice Chancellor sir has to catch the flight. He has the flight at 2:45. So I will request him to leave this inaugural ceremony, and the inaugural ceremony will continue, but he has to go to the Bagdora airport. So thank you, sir, for your valuable time. And thanks to all the delegates, all the faculty members for coming in this university. I always try to welcome and give our best for the in terms of hospitality. Thank you.
Thank you, sir, for your precious time. Let us now hear from our Honorable Principal, sir, Dr. Bijan Chandra Datta, sir, to briefly welcome our audience.
Good morning to everyone. Honorable Vice Chancellor, sir, in absentia, Mata Gujri University. Honorable Registrar, sir, Mata Gujri University. Honorable guest speakers, all PGTs, and all the office staff present here. It is really a privilege for me to be here for the inaugural session of ICP-CON 2025, an academic wing of API, which is the first ever Bengal-Bihar joint venture conference organized by the Department of Medicine in collaboration with the MGM Medical College. Under the leadership of Dr. Uttam Kumar Pal, Dr. P.S. Karmakar sir, Dr. Lalit Boyd, and supported by all the organizing team to make this conference a grand success. First of all, I would like to welcome today's distinguished guest speakers, medical professionals, as well as all the participants coming from different medical colleges, institutions, and organizations to share insight and advancement in the field of modern medicine. As we are all aware of that, NMC has directed to all medical colleges that any CME programs, conference, academic activities conducted by any university or institution to be uploaded in the NMC website, and it is made mandatory. Therefore, I expect more and more conference, CME, workshop, oration program, etc. will come up in our institution, creating an academic environment in the coming days from other departments too. Anyway, today and tomorrow, there will be a hectic session with full educational activities held to maintaining the high standard of care through continuous learning process, keeping medical professionals updated with the latest medical research technologies. Before I conclude, I would like to end up by expressing my best wishes to all the participants, and I request your presence, support, and cooperation in the session so that the 2 days program will end up with a grand success. At last, ending my speech, I would like to express to the Board of Management for providing support, help, cooperation, including the platform for exchange of knowledge for today's event. Thank you all. Jai Hind.
Thank you, sir, for your valuable time. Our guest of honor, Dr. Shekhar Chakrabarty, sir, immediate past secretary, National API, to please come on dais. I request Dr. Farhan Hashmi to kindly escort Dr. Shekhar Chakrabarty, sir, on the dais. May I request Dr. UK Paul, sir, to felicitate respected Dr. Shekhar Chakrabarty, sir. May I call upon respected Dr. Auditorium Debrai, sir, to extend his warm brief greetings to the audience.
A very good morning once again. Honorable Vice Chancellor, sir, in absentia, Honorable Registrar, sir, respected Principal, sir, Professor Dr. Jyotirmoy Pal, sir, and all other guests of honor, respected faculty members of this institution and other institutions, postgraduate students, and I can also see some interns here. So a warm welcome to you all to this conference, national conference. Like our registrar sir was mentioning that this is the 9th national conference that we are holding this year. So in the month of July or August, we were holding the 7th, and we had a strike rate of 1 per month. So I thought ki by end of this year, we will have a strike rate of 1 per month, and we'll have a total of 12 conferences, but somehow in between it got a little bit here and there. But as said, next year we'll definitely have that in mind, and we'll have more than 12 conferences in a year. Now you should keep in mind that conferences are also a way of networking. Like our registrar was mentioning that we have got so many senior faculty members who are a part of this institute now coming in for this conference. We are getting a chance to meet them, to network with them, to interact with them. So apart from your academic discussions, this is also a platform to network. And when the departments, when the faculty members, when the management is taking so much of effort to conduct conferences of this big size and this glamour, I think the postgraduate students and all the other students should take the full opportunity to attend this and take the best of it. Thank you so much. Welcome once again.
Thank you, sir, for your warm welcome. With pleasure, I invite respected Dr. Shekhar Chakrabarty, sir, to offer his brief blessings for ICP-CON 2025.
Respected Dr. Ichit and all the Professor Pal, President API, and all the senior dignitaries on the dais, and dear students and delegates of the dais. It's my great pleasure to come over here to address this august gathering. I can recollect my reminiscences for a pretty long time with Dr. Dilip Jashwal, who has the instrumental to make this organization from a seed to a banyan tree. So therefore, I am very happy to see that in front of us this organization is growing. This medical college is now one of the famous medical college in the country. The very important part is that the students who are getting passed from this college are spreading across the country, even in abroad, and the qualities of the faculties and quality of the education this particular institute provides to the students is actually commendable. I hope that all the students who are passing from this college will have a great future. API and ICP is committed to do the academic activities and research across the country. And we have got more than 25,000 members across the country who are instrumental to do all these activities. Here, the API of different states and branches, and I am very sure that the Bihar branch of API is also coordinating with all these programs. And I hope that one day academic program will be a fantastic one. And I am very glad that one of the very renowned teacher from Bengal, Dr. Partho Karmakar, is the scientific chairman of this program. So a great applause to Dr. Partho Karmakar. And Dr. Ashish Saha, who is the instrumental to drive the API West Bengal branch, is also over here. Thank you, Ashish. And Dr. R.N. Sarkar, who is one of the mentor of our API Bengal, has come over here. I am very pleased to see all these, and my brother, Dr. Dipanjan Bandyopadhyay, HOD North Bengal Medical College, who is one of the great teacher of this part. All these, presence of all these luminaries, and above all, a person who is actually driving and making the shape of API, Professor Jyotirmoy Pal, who is the HOD Medicine in Sagar Datta Medical College, Kolkata. He is a figure in India now who is making and giving the great shape. So his presence is make the program something different. And many other persons like Dr. Nandini Chatterjee, Dr. H.S. Pathak, many more dignitaries and all the luminaries from the college. Personally, I know all them, but I know very well Dr. Uttam Pal, who is your teacher. He is one of the great teacher which I have seen. So thank you, Dr. Pal, and all, above all, the driving force of this whole institution, Dr. Ichit Jaishwal, who is though young, junior to us, but he is a person who has made this a flag of this institution so high. So I know Dr. Jaiswal, Dilip Jaiswal is very busy in other aspect, but the academic program and the quality and the service of this institution is in the hand of Dr. Ikshit. So I wish that today's program will be very, very successful and very academically one of the very highly qualified program, and I wish that great success to all you students. Thank you very much.
Thank you, sir, for your blessings. I request respected Dr. R.N. Sarkar, sir, to briefly enlighten us with their thoughts.
Good morning. Respected dignitaries on the dais and off the dais and my PGTs, a warm welcome to this two-day extravaganza. Now, the credit goes to Dynamic Secretary of the ICP West Bengal, Professor Partho Kormakar, and HOD of this institution, MGM Medical College, Professor Uttam Pal. Now, Uttam is my student, our student actually, when I was in NRS. So I now see him growing to such height. It's really a pleasure. Now, I wish this conference a great success, and all credit goes to the team of Professor Uttam Pal and Partho Kormakar. This is a academic activity of the ICP. We are now trying to do this CME in all the districts. Actually, we have done many CMEs around Calcutta. Now, if in future we can do this joint CME with Bihar and also with Jharkhand also. Thank you. Welcome to all of you.
Thank you, sir, for enlightenment. May I now invite distinguished Dr. P.K. Agarwal, sir, to briefly welcome our audience.
Respected Dr. Jyotirmay Pal, our National President, API, Dr. Ikshit, Registrar, and other dignitaries on the dais, esteemed faculty from Bihar and Bengal, distinguished members of the ICP, colleagues from the Association of Physicians of India, invited speakers, resident, postgraduate students, ladies and gentlemen. Namaskar, and a very warm welcome to all of you. Today is indeed a historic day for all of us. For the first time, Bihar and Bengal, two states with a rich legacy of medical excellence, academic culture, and clinical acumen, have come together under one academic platform to conduct this joint ICP-CON. This collaboration is more than just a conference. It is a celebration of shared knowledge, shared vision, and shared commitment to improving patient care. As chairman of API Bihar, I feel proud and privileged to stand before you on this special occasion. The ICP, which represents the academic soul of the API, has always upheld the highest standards of education, research, and clinical skill building. To host this joint program is both an honor and a responsibility. The theme of today's event reflects what modern medicine truly demands: collaboration over isolation, learning over hierarchy,
and innovation over tradition-bound thinking. Our two states together produce some of the finest clinicians, researchers, and teachers in the country. When we pull our strengths, our clinical insights, our academic curiosity, or patient-centered wisdom, we create a far stronger, more dynamic, and more progressive physician community. This conference will not only highlight cutting-edge topics in internal medicine, but also showcase our regional challenges, solutions, research contributions, and future direction. I'm especially happy to see enthusiastic participation of postgraduate students. The future of medicine lies in your hands, and today's academic exchange will certainly strengthen our journey. I also extend heartfelt congratulations and thanks to the organizing team of both API Bihar and API Bengal, along with the dedicated ICP faculty for their tireless efforts in making this joint event possible. This partnership sets a benchmark for regional academic collaboration in India. Before I conclude, let me say this. When knowledge is shared, it grows. When states collaborate, healthcare strengthens. And when the physicians of India unite, patients across the country ultimately benefit. While these thoughts, I wish this joint ICP-CON tremendous success. May it open new doors of learning, research, and interstate academic harmony. Jai Hind, Jai API.
Thank you, sir, for a warm welcome. May I call upon respected Dr. P.S. Karmakar, sir, to welcome to our audience.
Distinguished dignitaries on the dais, President, National API, our Registrar of the University, Dr. Ichit, sir, our Principal, sir, Vice Principal, sir, Organizing Chairman, Chairman, ICP, West Bengal Chapter, Chairman, API, Bihar Chapter, Chairman, API, West Bengal Chapter, and Organizing Secretary, Dr. Abdul Bed, and the present learned delegates of the dais. Very much good afternoon to you all. So, to come short, I have invited some of the ex-faculties of this institute, and I think we, the faculties of general medicine as well as PGTs, feel proud of felicitating our ex-faculties of different disciplines of this institute. They have come here all the ways from the different places of West Bengal and Bihar. And we are felicitating them on behalf of our MGM Medical College, Kishanganj, which is now one of the best private institutes in eastern zone of India. I feel proud of being associated with this. And definitely, as Dr. Shekhar Chakraborty has said, Dr. Ichit sir is to be given, and our Vice Chancellor sir and the Director sir is to be given credit for that. So I will call upon one by one, as time is very short, all the ex-faculties to come on the dais. I will request my students to escort those ex-luminaries. I first call upon Professor Anita Datta, who is here. You please guide. Professor Anita Datta, HOD, ex-HOD, Professor, Department of Medicine of Kishanganj Medical College. Please come over the dais, madam. Now I call upon another very senior, revered professor, ex-professor of this medical college. I call upon Professor Emil Join to come upon the dais. Please, sir. Now I call upon another very distinguished professor, ex-professor of this Department of Dermatology, Dr. Sanjay Ghosa. Please come on the dais. Someone please escort Sanjay Ghosa. Now I call upon, who is already on the dais, Dr. Ashish Saha, sir, immediate past HOD of this medical college, Department of Medicine. Now I call upon Dr. Jamal Uddin, ex-professor, associate professor of this medical college. Please come on the dais, and I ask someone to escort Dr. Jamal Uddin. Now, Dr. Kalishankar Bhattacharya, has he come? Dr. Kalishankar, yes, come. So I call upon another very distinguished person from the Department of Surgery, so Dr. Kalishankar Bhattacharya. Why I am felicitating him? He is not ex-faculty of this, but I am felicitating him whenever the first day ICP-CON was declared. From the first day he was associated with this, and he has taken all the initiative to organize one Pratima Bhattacharya Memorial Oration. So his attachment to this ICP-CON is from his core of his heart. So I do like to felicitate Dr. Bhattacharya sir also. I call upon Dr. Deepmala on the dais. Ma'am, please come. Dr. Ichit sir is felicitating our ex-faculties. It is definitely proud privilege of the Dr. Ichit sir as well as the ex-faculties who were attached to different departments of this medical college. Now, so far the scientific program is concerned, okay, we have come to an end, and I would request Dr. Otul Bed to express vote of thanks to all of you. Thank you. And Deepmala is another pivotal role, playing pivotal role in making the scientific program with me. So,
Thank you, sir. I'm honored to be part of the scientific committee. Thank you, sir. Thank you, the organizing committee and the management. Thank you so much. Yes.
wants to speak one line.
Now I request Professor Dr. Ashish Saha to say a few words.
For the institute. From 2019 to 2023, I was here as an HOD in medicine. But many students passed and were working in different parts of India, from South India to North India to Eastern India also. But this medical college, it is always in my heart. Though I am working in the Calcutta, but it is always in my heart. The hospitality of the management, I have never seen in any. I have done many colleges, many private working in many private medical colleges. But this type of management, this type of hospitality, this type of PGD students and faculties, I have not seen. That is my word.
Good afternoon, everybody. So Dr. Vibleen has already warned us and used the word very succinctly to be very brief. I can understand what is going inside our stomachs in this pre-lunch session. So, honorable chief guest, respected dignitaries on the dais, esteemed faculty, delegates, colleagues and friends, ladies and gentlemen. On behalf of the entire team of the ICP-CON 2025, it's my privilege and honor to extend the vote of thanks at this inaugural ceremony. First, my sincere gratitude to our chief guest and honorable registrar for accepting our invitation and gracing this occasion. Your presence adds inspiration and value to our efforts. To our inaugural speakers and eminent faculty, thank you for setting the tone for this conference with our words, your vision for clinical excellence, and your encouragement to the younger generation. We are motivated to make the next 2 days very meaningful. To our delegates who have traveled across the country, because in the morning I came to know that there is a poster presentation from a postgraduate from Ahmedabad as well. So it's very, very delightful actually to know this. Actually, a conference is not about the hall, the banners, or the program booklet. The real energy comes from the curiosity, your questions, and your willingness to learn and share. And I promise we have kept enough scientific content to make sure nobody escapes without learning something new. To our industry partners, thank you very much for sponsoring the academic activities also. Without you, the organizing conferences would be like doing ward rounds without a stethoscope. Not that it is impossible, but it is very, very difficult. A very special acknowledgement goes to our organizing committee, volunteers, registration team, hospitality staff, AV crew, and the countless hands working silently backstage. You are the ones who turn planning into the reality. If everything looks smooth, it means someone has worked hard to hide the chaos, and we really appreciate that. I'll be failing in my duty if I do not acknowledge the postgraduates, especially the Department of Medicine, PGTs, and the interns, who have been working tirelessly for last 1 month, managing their duties, managing their own academic activities, their own routine, but they have been working tirelessly, and they deserve a huge round of applause for that. Thank you, and welcome to ICP-CON 2025.
Thank you, sir, for your vote of thanks. Ladies and gentlemen, ICP-CON 2025 is not merely conference. It is celebration of science, service, and shared purpose. Let's look forward to it. Thank you.
We have a mistake. Professor H.S. Pathak was ex-professor of this college. So now we are felicitating Professor H.S. Pathak. I apologize with folded hands. हाँ
डुप्लीकेट कर लीजिए मतलब वहाँ से आ जाएगा वहाँ स्विच ऑफ है We shall now proceed to the next important session of the day, titled Pratima Bhattacharya Memorial Oration.
I respectfully call upon the Honorable Chairperson for this oration, Dr. Uttam Kumar Paul Sir, Professor and HOD, Department of General Medicine from Mata Gujri Memorial Medical College. Dr. Atul Bed Sir, Professor, Department of General Medicine from Mata Gujri Memorial Medical College, to kindly come upon the dais and take the proceeding forward. Thank you.
I am requesting Professor Soumitra Ghosh, Head of the Department of Medicine, Medical College, Kolkata, who is a good orator, and he will speak on Pratima Bhattacharya Memorial Oration.
Respected chairpersons, all the dignitaries in the dais and of the dais. So it's a fantastic opportunity to deliver the oration in the name of Pratima Bhattacharya. My deepest respect and homage to Mrs. Pratima Bhattacharya. She is the proud mother, rather the immortal mother of her jewel of the jewels son, Dr. Kali Shankar Bhattacharya. It is the first oration in this kind, in this first ICP endeavor, and I must thank Dr. Kali Shankar Bhattacharya, the able son of Pratima Bhattacharya, to establish this oration in her name. So this talk of this day will be the food, the culprit agent of modern diseases. So it is very important to note that the food is becoming the culprit agent of modern diseases. In the last few decades, we have established a significant medical progress. The longevity has increased. But what happened in 2025 after a few decades, where there is a shift in this clock? We see obesity, hypertension, atherosclerotic cardiovascular disease, diabetes, dyslipidemia, fatty liver disease, PCOS, cancer, stroke, CKD, so much. So what happened in this time? And the obesity is right at the center of all these non-communicable diseases, giving rise to all such things. And 74% of the people now die out of this kind of diseases, non-communicable diseases, and India is not far behind. All these major causes are non-communicable, and they top the list. We are the second in number of the diabetics in the world. We are the third in the most obese country in the world. We are fourth in the highest increase in the childhood obesity in the world. So there is an erupted volcano of obesity, diabetes, hypertension, dyslipidemia, ischemic heart disease, fatty liver, PCOS, and cancers. We have seen these twin epidemics of obesity and the diabetes together, and the twin threats of coronary disease and the cancers. Now we very commonly see a 38-year man presenting with myocardial infarction, who is obese, diabetes, hypertension, having dyslipidemia and fatty liver. And the beauty is that, tragedy is the parents are bringing these sick children to the hospital. What is responsible for this new trend of the diseases? Hippocrates, the father of medicine, told that let food be your medicine, but are we eating food or food is eating us? This was our grandmother's favorite. Many items together. Now these items has been completely been replaced by this formulated food or the processed food. All these ultra-processed food have been the choice of our grandchildren, and the energy source, which is the tasty poisons, are very likely of our grandchildren. But what is the unhealthy food ingredients in the modern foods, which is the culprit agent of the modern diseases? We all knew that the three things, host agent and the environment, are actually interacting for disease. Now this new item has been added, that is the food. The agent for disease prevention has turned into the disease causation, because 5 of the 8 ingredients of these non-communicable diseases are food related and 2 are habit related. So they taste excellent, look excellent, smell excellent, they have instant calories, they are ready-made, heat and eat type, long shelf life, very cheaper. But what are the ingredients of this modern food? They are tasty, ready to eat, gluten, and these fructose, refined carbohydrate, this trans fat and monosodium glutamate, they are energy dense, nutrient poor, they are high in sugar, sodium and unhealthy fat, but low in fiber, vitamin and minerals. They are designed for good taste, but long shelf life. So there has been a transition, 4-stage transition. Now we are in the 4th stage, where almost all are actually artificial food ingredients. The fructose has become the new alcohol, trans fat is the plastics in our body, monosodium glutamate, which is the food addiction, and there is a big mismatch in the technology and this physiology of our body, because physiology has not changed over millions of years, and this technology has changed, and this has made our activity poor and the energy dense food. But the physiology, which is constant, are mismatching with this technology. So energy intake is increasing and the expenditure is decreasing, gap is increasing, and basically all these energy sources, the battery size was so much, now it is a small button, and all this technology has been put into a smartphone. Similar has happened in the food also. So one kind of food is the combination of many. It has become energy dense. So only this combination of these two can take this whole day's calorie intake. And minimal, this kind of 10 rupees packet can be digested after walking for 2.1 hours. And if you take this kind of food, it is very difficult to digest if you walk throughout your night. And all things we take very easily, it has become so rich, it is very difficult to digest in time, even if you take so much of physical activity. So food has to be taken, as we take medicine, quantity limited to the need, but it is a very deceptive one, because our stomach cannot see these kind of small things are producing this much of energy sources. So rapid nutritional transition, but the muscle mass of the Indians are very poor. As a result, this mismatch is causing so much of the disease processes, and we see this new kind of non-communicable diseases are causing havoc in the India. Cancer, diabetes, cardiovascular disease, and the stroke are the new things. They overfeeds, they undernourishes. So excess energy from the carbohydrate or fat, which one is more important? It is from the carbohydrate, not fat. And this carbohydrate is a synthetic carbohydrate. It is not the natural carbohydrate. But it is this artificial carbohydrate is the problem, because high fructose corn syrup is the mainstay of this kind of sweetening agent now, rampant use of these. And this average intake of this per capita intake of fructose per year is almost 70 kg per person. This is the sole caloric sweetener, whatever you see in the market today. And this less expensive than the original sugar, and it does not ferment it. And that is why this is the choice. But physiologically, if you see, that is 100% lipogenic, and it escapes the satiety signal. It is not insulin dependent. And this 100% lipogenic thing enters from the other side of the liver as fructose, but does not leave the liver. It is 100% lipogenic, causing all this fatty liver, epidemic in the world. So it can affect this pregnant mother as well. It can transmit through, it is the new alcohol. Only difference is that these kind of drinks can be taken in front of the seniors, which is people feel hesitant to take in from the guardians. So all things are actually common. Metabolically, all things are actually same. So all these things you can imagine, all kinds of newer items of food contains fructose, and they do not contain these, sucrose like sugar. So all these things, the tasty poisons sold in the energy drinks contain these kind of things. So this drinking fructose is almost drinking fat, because they do not leave the liver. So what this industry is talking about, this is the fruit sugar, sugar substitute, no added sugar, fat-free, but these are all traps, because they are rich in added sugar. Hyperinsulinemia is the cause, and the weight gain is the major thing. So no to this fructose. Non-nutritive sweetener as an alternative to sugar, but this actually doubles the risk of obesity, aspartame and these other acesulfame, etc. So indiscriminate use of the wrong fat is another thing which is making these, food as a poison. These, we need fat very much in our body for everything, the cell membrane, organelles, everything. But there are different kinds of fat, these saturated, unsaturated, monosaturated, polyunsaturated. We all know the saturated fat was the worst thing in the ghee, cheese, coconut oil, cream, etc. But this kind of candy bar of small thing, you can be astonished to see that this 60% was the saturated fat. So this is actually to this kind of fast food centers, they use the pig fat, fast food favorite. They use this cattle fat for these all kinds of restaurants use this cattle fat. Now this monounsaturated fat, this olive oil, sunflower oil, etc., they actually may cause insulin resistance. But this polyunsaturated fat, the steroids, so all these body things, sex hormones, myelin sheath, they contain these polyunsaturated fat. But the problem in this polyunsaturated fat, they can break and they can be rancid. So this kind of answer to the food industry to just make it, so they make a trans fat. So what is the trans fat? It is actually banned in different other countries, and this trans fat is simply just changing the site of this oxidation site, and this changes this area and this peroxidation of the vegetable oil. So this is a vegetable oil, but this peroxidation changes it. So this fat chain becomes straight and it becomes undigestible. So this shelf life becomes increased, they become cheap, they become non-rancid. So life is more important, it is not the shelf life which is important. And these are actually unmetabolized by the body, because body's enzyme cannot digest it. And the trans fat are like the plastics in our body. When they enter, they are clogging the arteries, they are clogging the liver. All our systems are burdened. They cannot be just digested. So they are non-degradable. And all this arterial clogging and other diseases, inflammation, gut microbiota destruction is causing all these diseases like obesity, insulin resistance, diabetes, dyslipidemia, ischemic heart disease, colorectal cancers. But this bonaspati, margarine, they are actually sold in the market as the vegetable oils, but this cake, pastry, potato chips, chocolate, french fry, whatever you see, they are rich with this trans fat in our country. And all the countries have said that the trans fat should be zero, but the industry has made it, this trans fat should be zero, but industry has changed the definition of zero. This 500 milligram is actually their new zero. So anything less than 500, 499, so any biscuit containing 499, industry said the trans fat. So they tell that no saturated fat. Actually, it is worse than saturated fat. They sell it and no animal fat because they sell it as the vegetable fat. They actually zero cholesterol, everything. But behind this vegetable oil and other things, the cat is different. And if whatever is heart friendly, you can see the cat behind that it is actually worse than the saturated fat. Now this monosodium glutamate, it is the taste enhancer. All these things, people are actually eating because of this monosodium glutamate. It creates a business of 83,000 per year. This Ajinomoto, this marketed in Japan only, and it stimulates the hypothalamus, it causes leptin resistance and causes a food addiction. Yes, food addiction. You are actually hearing it right. And this system is actually clogged by this food addiction substance, MSG. This low fiber, it is very important. All these slow killers, because in the balanced diet, we all know that the fiber should be actually 30 gram. But now our children are eating this less than 12 gram. And this high carb diet, actually, if it is with less amount of fiber, that is a cause of this refined carbohydrate, etc. With less, grain, outer layers, fibers are less, and that is causing these benefits of this cholesterol, total cholesterol, risk of diabetes, colorectal cancer, all are being increased by this. They are actually carcinogenic if this fiber content. All these modern foods does not contain any fiber. So that is the enough problem, and that these, the epidemic of diabetes, dyslipidemia, gut microbiota changes, fatty liver, colon cancer, etc., constipation, these are the big changes. And this gut microbiota change, which is actually the ecosystem of our body, that is being changed by this modern food. And this gut microbiota, the most important organ, we do not think, and 90% of our body is actually by this gut microbiota, 10% of the human cells. So these are these, by democratic rules, these are actually the drivers of our body system. And this is the major problem, this energy extraction, bile acid modulation, neurotransmitter release. But change in this gut microbiota controls the signal of the brain, and the homeostatic appetite is actually overruled by this, hedonic appetite. So this biology is being controlled by the behavior, and whatever you see as a behavior change, that cannot be done because the biology or the behavior, whichever is controlling which one, cannot be set because the neurotransmitter release are all changed because of the gut microbiota change. And these kind of, lipopolysaccharide outer coat, which is the gram-negative things, in the organisms, they are behaved like these endotoxins, and whenever they are released, they are absorbed. They are absorbed like lipids. They go to almost all systems and cause widespread inflammation. And this widespread inflammation does not take into the physiological system, and this deranged gut microbiota cause type 2 diabetes and that obesity, and this deranged inflammation system cause a huge problem. And the bile acid metabolism, fat absorption, everything is mediated by these bile acids, and this breakage is done by the gut microbiota. Gut microbiota change is the biggest substance of the research in the world, and GMT or gut microbiota transplant is the talk of the day, and that is being destroyed by these industrial food emulsifiers, sugar substitutes, formula food, antibiotics, cesarean section, and these endocrine disrupting factors causing this whole array of the newer kind of diseases like diabetes, dyslipidemia, fatty liver disease. And the antibiotics, which he started using in 1947, within 60 years, whole array of these things has come from the communicable disease to the non-communicable disease side. And even the cesarean section, which is the rampant way of the gynecologist, is causing this problem. And all these kind of food emulsifiers, the fat and the water are actually being bounded by the surfactant-like material. They're destroying our gut microbiota. It is not only that, micronutrient imbalance is very important. All these modern foods are low in minerals, vitamins, antioxidants, etc., and it is rich with these endocrine disrupting chemicals. What is these endocrine disrupting chemicals? All these plastics containers, they contain bisphenols A and the phthalates. And these kind of things, when this bisphenol A came into the news in the scientific research that the BPA is very toxic to the body, they just bring in bisphenol B. So they thought that it is bisphenol A free. Now it is actually the bisphenol B is actually more toxic. This bisphenol A causes metabolic dysfunction, diabetes, obesity, neural disorders, but the bisphenol B is more harmful. They are not talking about it. and they are actually substituting it with the more harmful things. Now this modern food has become the agent of the disease by uncontrolled food industry. They are rich with calories, refined carbohydrate, high fructose, trans fat, monosodium glutamate, salt and the sugar substitute, additives, preservatives, and these kind of polyethylene phthalates, and these microplastics, and the endocrine disruptor factors. They are low in fiber, vitamin, minerals, and these essential fatty acid antioxidants. They are causing obesity, diabetes, dyslipidemia, hypertension, cardiovascular disease, fatty liver, PCOS, cancers. So to reverse this non-communicable disease epidemic by modern foods, we require a concerted effort by the whole society. All these health professionals, media, government, NGOs, food industries, community organizations, school employees, individuals, families, policymakers, all should change this pattern. Otherwise, it's a time to take a step back and think about the foods we are eating, because choices we make today will surely affect the next generation, current generation, and affect our future. So we must do something right now to stop this culprit agent of these non-communicable diseases. Otherwise, recent improvements in the achievements in the medical science, in the change in this longevity will be lost in a matter of years, and modern non-communicable diseases will turn into a cruel tsunami, will reverse the trend of the steady increase in the life expectancy. Civilization will be bankrupt because of these diseases are very costly. It is a lifelong disease, and our children will die before the parents. So this is important, and spare some thought over this food we are eating now. We are sending our children to the school with this kind of foods, and otherwise food will eat us. Food should not eat us. We should take a healthy food. We should go back to the time when the grandparents and the grandchildren, used to take and serve natural foods. So type 1 food should be there. Type 4 food should be abandoned. Thank you very much for your patient hearing and giving this opportunity to talk on from this August gathering. This credit goes to Professor Uttam Pal and Professor P.S. Karmakar for inviting me to talk on this very important issue in the world today. Thank you very much. And Dr. Kali Shankar Bhattacharya particularly for initiating this oration. Thank you, sir.
Thank you very much, sir. It's an excellent presentation, really eye-opening, and actually it's the burning topic these days. It's really a matter of concern. So since it was an oration, it's not, the house is not open, it's not open to the house for questions. Thank you very much, sir. Very well.
Okay.
If there are any questions, we can meet sir outside, but we have to proceed actually. Thank you, sir.
Yes, now, professors. As it is a oration, Pratima Bhattacharya Memorial Oration. Yes, sir. Yes, sir. Yes, sir.
Everyone should be aware of that.
Yes, sir.
And your lecture should be given to the parliament.
Yes, sir.
It is being changed, and
yes, sir.
You can see the Prime Minister is talking about it.
Sir, in the parliament, the burger and pizzas are subsidized.
Now, Professor Sumitra Ghosh is awarded by a medal, as this is a oration, Pratima Bhattacharya Memorial Oration. So now he is awarded by our Chairman Scientific Committee, none other than Professor P.S. Karmakar, sir.
It's my proud privilege. Professor.
Kali, some one picture. Hadley, you can join.
I cannot miss this opportunity.
Yeah, please come.
Yes.
If you don't invite me,
Yes, Dr. Shekhar Chakraborty, sir. Please. You are scientific convener of this conference.
Thank you.
Yes, again I am telling Dr. Shekhar Chakraborty, scientific convener of this conference, always support us with his great help. Always.
Thank you very much.
Thank you, sir.
Can we take out? ওয়ার্কটা দিয়ে দেবো পার্সোনালি, এখান থেকে বার করতে হচ্ছে, চলছেই না। Any copy taken?
No, sir. I will just. Sir, I will just.
Sure.
Thank you, sir.
Thank you for this enlightening oration. We extend our sincere gratitude to the chairperson as well as the faculty speaker.
We now move into another engaging and insightful scientific session titled Escalating Disease Trends. We kindly invite our distinguished chairperson for this session, Dr. Shekhar Chakrabarti sir, Consultant Senior Physician, Siliguri, Dr. B.K. Singh sir, Associate Professor, NMCH from Sasaram and ICP Chairman, Bihar Chapter, Dr. Kela N.V.S.S. Prabhu sir, Assistant Professor, Department of General Medicine from Mata Gujri Memorial Medical College, and Dr. Arif Alam sir, Assistant Professor, Department of TB and Chest from Mata Gujri Memorial Medical College, to please come forward to the dais and lead the proceedings.
All the faculty chairpersons, speakers, and distinguished guests are reminded to take the mementos from the registration desk.
মোবাইল চুরি হয়ে গেছে ডিপার্টমেন্টে। पहले सब होता था। हाँ बोलेंगे। हेलो
I also call Dr. P.S. Karmakar sir, Professor of General Medicine from Mata Gujri Memorial Medical College, for chairing this session.
Good afternoon, everybody. So, I call upon Dr. Ananya Chaudhary. Her topic is approach to anemia. He has completed his DM clinical hematology, consultant clinical hematologist, and attached to Anandalok Multi-Speciality and Manipal Hospital, Siliguri. So she has come all the way from Siliguri to Kishanganj, and we are thankful on behalf of organizing committee for coming over here to deliver on a very important topic, that is approach to anemia. Over to Dr. Ananya Chaudhary. Now the floor is yours.
Thank you, sir. Respected chairperson, respected delegates and other faculty members and students. So I'll be talking briefly about the clinical approach to anemia. So I will be heading under the following topics. Firstly, I will discuss definition, then followed by clinical features, relevant history taking and physical examination, basic steps of anemia evaluation, and conclusion. So how do we define anemia? Anemia is basically defined as reduced hemoglobin concentration as well as RBC concentration, which is characterized by reduced delivery of oxygen to the peripheral tissues. It is defined by WHO. So as per WHO, the relevant cutoffs in adult male is below 13, in female is below 12, in pregnant female it is below 11, and newborns it's below 14. So what are the common clinical features when patients present with anemia? Patients usually present with fatigue, palpitations, headache, shortness of breath, frequent infections, and dizziness with pale skin. So what are the common clinical signs we see? We see pallor in the lower palpebral conjunctiva, paleness of the fading of the palmar creases. In severe deficiency, we see the spooning of the nails, which is known as koilonychia, as well as angular cheilitis, as well as atrophic glossitis. And the common systemic findings, on CVS examination, we will usually get a systolic murmur or venous hum, usually on the cardiac apex area. On the neuromuscular system, we usually get headache, lack of concentration with neuromuscular weakness. Ophthalmological examination will reveal flame-shaped hemorrhages with severe papilloedema in severe cases. Dysphagia is also noted in iron deficiency anemia as a part of the Plummer-Vinson syndrome. And local GI blood loss is also noted in iron deficiency anemia. So the common history points we need to take. One is history, the bleeding history, the rate of bleeding. Second is family history of any hemoglobinopathies. Previous history of any jaundice, then gallstones, splenectomy. And travel history is also important because certain infections like malaria and certain other epidemic tropical infections, they also need to give the relevant travel history. Certain drugs like non-steroidal anti-inflammatory drugs, they cause local GI blood loss. Then dietary history, sometimes the vegetarians are prone for developing anemia. Presence of fever, there can be this source of some infections or malignancies. And in females, the most important, the menstrual history should be taken off. Next is, apart from this physical findings, we need also to check for the this lymphadenopathy, any palpable organomegaly, and thorough evaluation of the other systems. So when we get a CBC report, what is the most important parameters we should look for? Hemoglobin, followed by hematocrit, the RBC count, RBC indices, the RDW, that is the red cell distribution width, followed by the peripheral smear evolution. The important thing is when we see a patient of anemia, what is the next step, what is the most important investigation we order for? The next important step is retic count. Retic count comprises 4 important components. This retic count followed by corrected retic count, then absolute retic count, and reticulocyte maturation index or the production index. So based on this, and then we look on the MCV indices. So based on this, we divide into microcytic, normocytic, and macrocytic. So common causes for microcytic, we know it's iron deficiency, then hemoglobinopathies like thalassemia, and occasionally this sideroblastic or anemia of chronic inflammation. And normocytic, this aplastic anemia, anemia of chronic inflammation, MDS, and high, this macrocytic is commonly B12 deficiency, this MDS, as well as certain other malignancies and liver disease, as well as hypothyroidism. And if it's increased, the retic count is increased, that is the RPI, which we take the cutoff as 2.5. it usually differentiates whether it is hypoproliferative or hyperproliferative. So if the RPI is more than 2.5, we take it as high, and it suggests some ongoing hemolysis. So based on this RPI, the next step is we look for the MCV indices. Below 80 is microcytic, 80 to 100 is normocytic, and more than 100 is macrocytic anemia. So when there is reduced MCV, we need to check the iron profile. Then based on this, we can at least differentiate whether it is ID or at least ACD. And if there is high ferritin level and the other parameters are normal, we can think of this sideroblastic anemia. And if it's almost normal, then this thalassemia or hemoglobinopathies. Next is normocytic anemia. What is the key question? Whether the reticulocyte count is elevated or not. If it's elevated, there is ongoing hemolysis or active blood loss. And if it is low or normal, it signifies decreased production. And if it's normal, we also need to rule out the other parameters, lab parameters like increased LDH, indirect bilirubinemia, and reduced heptoglobin. Then other causes like bone marrow suppression or renal insufficiency. And also we need to evaluate the peripheral smear for any abnormal RBCs. So if the MCV is high more than this 100 femtoliter, we need to rule out the other common causes like vitamin B12 deficiency and polydeficiency. Apart from this liver disease, hypothyroidism, and if there is dysplastic changes, we need to rule out myelodysplastic syndrome. So in vitamin B12 deficiency, we'll get a elevated MMA level as well as elevated homocysteine, whereas in folate deficiency, we'll get a elevated homocysteine, and the other levels will be like low folate level and normal MMA level. Next important step is what is Menger index and what is RDW. So Menger index is this MCV by RBC. More than 14 is suggestive of this ratio is more than suggestive of iron deficiency, and below 12 is suggestive of thalassemia trait. And this RDW usually signifies the variation in the size of the RBCs. We usually take a cutoff as 11 to 15. In iron deficiency, extremely high, around 18.5. And in this hemoglobinopathies, the range is around 15. So when to consider bone marrow aspiration and biopsy? When the diagnosis after all this initial workup remains unclear, when there is suspected malignancy or infiltration, when there is myelosuppression or bone marrow suppression like aplastic anemia or MDS is suspected. And what is the systemic diagnostic algorithm? So we need to confirm anemia with CBC and hemoglobin. Then we need to check the retic count followed by the RBC indices. Then order the targeted test based on this classification. We need to give a very thorough review of the peripheral smear for the morphology, and need to consider the bone marrow step lastly when the diagnosis remains unclear. So what are the red flag signs which require urgent action? Hemoglobin when is below 7. There is signs of hemodynamic instability. When there is pancytopenia and the peripheral smear reveals blast cells and active ongoing bleeding is there. So the key takeaways is that anemia is a sign, not a diagnosis. It requires a systematic approach including retic as well as the RBC indices. We need to consider the common causes first, followed by the rare one. So I just want to share a brief case which I have recently encountered. There was a female of 63 years old. She presented with a history of low hemoglobin. Clinical examination revealed only pallor. Basic investigations revealed there's some sort of iron deficiency anemia. The other lab investigations was almost within normal limit. So we gave her parenteral iron. There was improvement in the iron profile, but however, there was no rise in hemoglobin. And subsequently, the serum protein electrophoresis and SFLC ratio was also normal. So ultimately, bone marrow study was done, which revealed 64% plasma cells and a diagnosis of non-secretory myeloma. And on IHC over the bone marrow biopsy block, it showed kappa light chain restriction with presence of the positivity for the clonal plasma cell markers. And then ultimately, she was started on this VRD with zoledronic acid regimen. Thank you. Thank you.
Thank you, Dr. Anuna Chaudhary, for your lucid deliberation on approach to anemia. So the session is open to the House. If there is any question from the PGTs or any expert comment from the faculties, I do invite that one or two. Yeah, please provide a mic over there.
Sir, in anemia of chronic inflammation, it plays an important role because hepcidin level will be this high.
Please use the mic. Madam, please use the mic.
Serum hepcidin levels are in anemia of chronic inflammation, it is important, not in other cases.
Is there any question?
Any role of this erythropoietin in anemia? Because as a rheumatologist, I come across many cases of this anemia of chronic disease.
Yes, sir. Erythropoietin.
In obstinate cases, we start with erythropoietin.
Yes, sir. 10,000 international units subcutaneously we can start.
That is helpful. Okay.
That is helpful. Thank you, sir.
One question from my end. RBC, RDW.
Yes.
In iron deficiency anemia and non-iron deficiency anemia. Just
Sir,
in one line.
RDW is like we see the variation in the size of the RBCs. That is the red cell distribution width. RDW will extremely be high in iron deficiency anemia. That is around the range comes around 18.4 to plus minus 1.5. Whereas in this hemoglobinopathies, like in thalassemias, like in non-iron deficiency, it will be elevated but not as high like in iron deficiency. At least it comes around 15.2 like that.
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Hello. I'm just inviting Dr. Abhinav Devnath, sir. Dr. Abhinav Devnath, sir. He is DM Nephrology, consultant nephrologist from Anandurag Hospital, Siliguri. The topic is kidney disease, diabetic kidney disease. Diabetic kidney disease. Topic is diabetic kidney disease.
Good afternoon, everyone, respected dignitaries, respected chairperson, and my dear students. So, my topic is diabetic kidney disease. This is the most common disease, but most concerning and most alarming in day-to-day OPD practice. I will try to cover each and every aspect within this short duration of time. This will be discussed under heading of definition, epidemiology, Indians aspect, pathogenesis, natural history and stages, and treatment in short. So if we go through the definition, is by convention, diabetic nephropathy is defined as appearance of persistent clinical albuminuria in an individual with at least more than 5-year declining GFR, concomitant retinopathy. There should not be any urinary tract infection and other renal disease or any kind of heart failure, and the process is mostly associated with increase in blood pressure. So diabetic nephropathy present with albuminuria, but there is existence of non-albuminuric diabetic kidney disease also. The presentation is in the absence of albuminuria, but there is reduced GFR. Some factors are responsible for this, for non-albuminuric presentation. There is a presentation of hypertension, smoking, dyslipidemia, and prevalence of retinopathy is lower in this case, and apart from microangiopathy, there is associated macroangiopathy in case of non-albuminuric diabetic kidney disease. And progression is relatively slower in comparison to albuminuric decading. Epidemiology in Indian scenario, this is a summary of some studies. In a meta-analysis is a national pooled estimate. In Indian adult type 2 DM prevalence is 44%, and in Indian seniors proportion of CKD due to diabetic kidney disease is approximately 46%. This data is quite alarming and concerning. If we have to understand the progression of diabetes and how to prevent the progression, we have to go to the pathogenesis. This is a simple picture of glomerulus. The first one is normal glomerulus, and second one is unhealthy glomerulus. So in unhealthy glomerulus, what is afferent arteriole is dilated and efferent arteriole is constricted. as a result, there is increased interglomerular pressure. This is also basic diagram. Tubuloglomerular feedback. We know the three component of juxtaglomerular apparatus. Three cell, one is macula densa cell. This is located in distal convoluted tubule. Then extraglomerular cell. Then juxtaglomerular cell, which is located on afferent arteriole. These three cells interact between them depending on volume overload or volume depleted scenario. I will explain this. This is a picture of diabetic nephron. I don't have actually any marker, otherwise it would be better. In this picture, there is a glomerulus. Starting from glomerulus, there is a proximal convoluted tubule. So in diabetes, there is number of sugar is increased in proximal convoluted tubule. In proximal convoluted tubule, there is sodium glucose co-transporter. As a result, there has been more absorption of sodium and glucose through this co-transporter. So in distal convoluted tubule that comes after proximal convoluted tubule, there is a less number of sodium available. As I discussed, there is macula densa located in distal convoluted cell. The macula densa will sense like that our body is volume depleted because less number of sodium is reaching in distal convoluted tubule to macula densa. So body will be signal like that. Our body is volume depleted. So what will be the reflex mechanism? They will send signal to the afferent arteriole. Afferent arteriole will be dilated as a result to increase the glomerular pressure. So there is the scenario in diabetic nephron. The arteriole, afferent arteriole is dilated, efferent is relatively constricted. As a result, the glomerular pressure is increased. That is known as interglomerular hypertension. Hyperglycemia, hyperaminoacidemia. These are also responsible for this hemodynamic instability in glomerulus. This is simple diagrams of pathophysiology. Renal hemodynamic changes are there, then ischemic and inflammatory changes, then overactivation of renal angiotensin system, ultimately all lead to renal fibrosis. Then some novel molecular mechanisms also there, genetic modification, then epigenetic regulation, then podocyte autophagy and mitochondrial dysfunction. All these mechanisms are responsible for progression of diabetic kidney disease. In natural history and structural changes, in this diagram there is actually 5 stages of diabetic nephropathy progression. First one is renal hypertrophy, then incipient diabetic nephropathy, then over diabetic nephropathy, then end stage renal disease. In first stage, there is increase in kidney size, only kidney size, glomerular size is also increased. GFR is increased by 20 to 50% in initial stages, but there is no albuminuria. Blood pressure is also normal. There is the scenario of initial 0 to 5 years. Then after renal hypertrophy, the structural changes started in the form of basement membrane thickening, then some mesangial expansion. Then after 5 years, this incipient diabetic nephropathy. They start with mesangial expansion, further glomerular basement membrane thickening, and starting of microalbuminuria. Then microalbuminuria to over diabetic nephropathy in the form of macroalbuminuria. In that scenario, glomerulosclerosis, tubulointerstitial fibrosis, inflammation, all these happen. And ultimately, end stage renal disease, GFR is less than 10. It takes over 25 years. This is actually clinical staging. It is given by Mogensen classification. This was actually based on type 1 diabetes mellitus, but in case of type 2, the exact sequence may not follow the sequence. This is the pathological classification. The class 1 to class 4 is there. Class 1 is glomerular basement membrane thickening, then class 2 based on mesangial expansion, then class 3 As we read in textbook, a classical nodular sclerosis, there is a KW nodule. This is seen in class 3. And in class 4, there is advanced diabetic glomerular sclerosis. There is a more than 50% glomeruli is involved. And this is in the form of tubulointerstitial lesion and arteriolar hyalinosis. Then I am coming to the treatment part. What is our treatment goal? To prevent the progression of macroalbuminuria, first thing, then slow the decline of renal function to reduce the cardiovascular event and delay the need for hemodialysis. In treatment, we all know the lifestyle modification. I am just coming to the pharmacological management. We have 4 pharmacological pillars. Other than controlling blood sugar, controlling blood pressure, in present scenario, we are focusing on SGLT2 inhibitor, GLP-1 receptor agonist, then ACE inhibitor ARBs, and then MRS, there is mineralocorticoid receptor antagonist. This is a picture of, this picture is a glomerulus with SGLT2 inhibition. We have several number of trials on SGLT2 inhibitor. This is EMPEREG outcome trial, then DECLARE TIMI trial, then CANVAS trial, DAPA-CKD, IMPA-Kidney. So all are showing significant benefit in respect to cardiology and in respect to nephrology. In nephrology, significant reduction of proteinuria to delay the progression of kidney function, delay the initiation of hemodialysis. SGLT2 basically acts in proximal tubule. It blocks the sodium glucose co-transporter. So ultimately, it changes the tubuloglomerular feedback mechanism and helps decreasing interglomerular pressure. The next is GLP-1 is another main pillar. In recent studies is established. GLP-1 analog, how it is beneficial for our kidney. In this picture, this is a picture of diabetes-related glomerular hypertension. So what is GLP-1 is doing? It prevents proximal sodium reabsorption, and as a result, it preventing vasodilation of afferent arteriole and helping to maintain the interglomerular pressure. Then last but not the least is a mineralocorticoid receptor antagonist. We all know the recent drug is a finerenone. Finerenone is very much beneficial in all different studies. The mechanism, what happens when there is mineralocorticoid receptor overactivation? There is increased salt and water retention, then induction of oxidative stress, stimulation of fibroblast proliferation, collagen synthesis, promoting kidney fibrosis, and then macrophage polarization towards pro-inflammatory phenotype and damage to renal structure. In this, this is a trial on finerenone. This is the Fidelio-Decade and combined fidelity trial. So all these trials, the main shows that the benefit of finerenone is mostly seen when albuminuria is more advanced level and GFR is on declining trend. In my OPD, there is few patients presented with very high ACR value. There's more than 4,000, 5,000, and they're doing very well on finerenone, and they are maintaining less than 1,000 ACR value. And last slide is a ADA standard care for CKD and risk management. For cardiovascular risk reduction in people with type 2 DM and CKD, consider SGLT2 inhibition if GFR is more than 20, or GLP-1 analog, or non-steroid mineralocorticoid receptor antagonist. GFR should be more than 25. And in people with CKD who have more than 300 ACR value, at least 30% reduction is beneficial and recommended to slow the CKD progression. Thank you.
Thank you for your lucid deliberation, and I am really astonished to know that, Dr. Abhinav, that finerenone is reducing 4,000, 5,000 ACR to below 1,000.
Yes, sir.
Is it that much
Yes.
effective. Okay, I'm really excited to know that thing. I didn't have the idea that
Actual
this much
benefit is
reduction
that
does occur.
if we start in very low SER value, we cannot assess the actual, what is the benefit actually. The mechanism of action of they are targeting actually fibrosis level. Till now we don't, we are using AC inhibitor ARBs. Their mechanism of action based on hemodynamic, but not on fibrosis.
Absolutely right.
So more fibrosis, there is a more proteinuria. So this is the.
Definitely, that's a good. So is there any question? Yeah, Dr. Partha Chattopadhyay.
Sir, actually duration is not defined actually. Few patients are using for more than a year and duration actually not defined. I think till then potassium is okay, no other issue, we can continue this medicine. If we go through the mechanism, there is no harm. হ্যাঁ স্যার ট্রায়ালে করেছিল
if the potassium level is okay.
Yeah. Thank you, Dr. Abhinav Devnath, for your very excellent and informative and lucid too in your lecture of diabetic kidney disease. So thank you. Now we come on to our next topic, that is insulin journey over 100 years. And it will be delivered by none other than Dr. Soikat Datta, who is professor and HOD of the Department of General Medicine, Bihar Medical College. You are most welcome, Dr. Soikat Datta, and the floor is yours.
তো করাই যাচ্ছে না, চেঞ্জ করা যাচ্ছে না এখানে, কাজ করছে না এখানে, পৌঁছচ্ছে না তো, ওটাই বলছি, স্কিপ করলাম তো। করা আছে মনে হয়, এক্সটেন্ড করে দিয়েছে। হ্যাঁ স্যার, এইটা আপনার
Good afternoon, everybody. At the onset, I would thank Professor P.S. Kormakar and the entire team of ICP-CON for inviting me to deliver this lecture. I don't have any disclosures to reveal, and I'll be discussing on the journey of insulin over 100 years. Firstly, about diabetes. It's not a new disease because ancient Egyptians, as far as back in 1552 BC, it had been described. And classical description was given in 129 to 199 CE, where is a condition as one, where is melting down of the flesh and bones into urine, so that kidneys and bladder emit urine as though the aqueducts were open wide, and in whom thirst is extreme, mouth parched, body dry, and wasting progressive. So you can see when the classical description of diabetes was done. Over the past 100 years, more than 10 different categories of medications have been developed. But the only medicine, the only agent which had fetched Nobel Prize is this insulin. This is what I will be discussing upon. But I'm sure everybody will agree that the discussion, this development and discussion of insulin on insulin is actually not a simple, not something simple. The invention of insulin, the discovery of insulin is actually, this history is something about brilliance, something about serendipity, something of strife, and something of controversy. So each and everything encompasses when the journey of insulin will be discussed. I'm sure you will agree that discovery of insulin is incomplete without discussing something about Langerhans cells. In 1969, a German medical student, Paul Langerhans, proposed that pancreas is having two different types of cells, acinous cells, and the second type of another cells, which expressed as islets or islets arranged as distinct clumps throughout the pancreas. And the French expert Laguerre subsequently named these cells as islet of Langerhans, suggesting that if the pancreas had a function other than its role in food digestion, these islets might have been involved. Then, in 1889, Minkowski and von Mering at University of Strasbourg ligated the pancreatic ducts of dogs, showed that this does not cause diabetes, wherein on pancreatectomy, the dog became diabetic. Amongst so many experiments, why am I highlighting this? Because actually, this is the basis of future development of future discovery of insulin. Then Hedden removed the majority but retained small amount of pancreas in dogs, which reduced the supply of pancreatic juice, but the dog did not develop diabetes. But when the entire pancreas was removed, the dog developed diabetes. And many other investigations ultimately proved what? That absence of pancreas caused diabetes. So this was the basis on which the subsequent experiments were done. Now let us come to this part, the fantastic 4+1 insulin discovery. But for this, I request the hall to please take part to identify the first person, the first photograph. Whose it might be? Yes, Frederick Banting. And he actually was the one who discovered, who actually conceptualized this. He was not an excellent student. He was a mediocre student. Initially, he joined an arts course. Subsequently, he couldn't continue, and then he shifted on to medicine. And while thinking about some class, he, at night of 2 a.m. on 30th October 1920, in a home, still now, this board is there where he actually thought about. He wrote something in the notes. These were his notes, and what was there in his notes? Diabetes, ligate pancreatic duct of the dog, keep the dog alive till acinate degenerate, leaving the islets, tries to isolate the internal secretion of those to relieve glycosuria. So this was what he thought on October 30, 1920 at 2 a.m. Then what he did? He went to the second person here. And who was the second person, please? This person, no, he was not best. He went to this person and he was, no sir, not Colip. Yes? Yes. So he went to MacLeod. MacLeod was in Toronto. Although he didn't actually believe on Banting, still he allowed Banting to use his lab, the dogs, and he also told that you can, I will give one of my students. So 2 students were there, Charles Best and Clark Noble. Amongst this, Charles Best was selected based upon anybody? A toss. You think, just a toss, and that's how Charles Best came into the picture, lived throughout the medical history, and unfortunately for Nobel, he went off into oblivion. So, MacLeod and Best started the plan to discover insulin, and this was what they did. They did the partially pancreatectomized dog was done, and then they grafted the atrophied pancreas into a dog who was already diabetic, and then the urine was tested for glycosuria. Next what? This isolation of this juice was difficult. So it was very difficult for them to isolate. So what they did, what MacLeod did? MacLeod gave one more biochemist, appointed one more biochemist to help them. And who was this biochemist? Colip, right sir. So J.B. Colip. Colip was the biochemist who was appointed by MacLeod to help them. So now the team started to produce insulin, to isolate insulin, and unfortunately, as in any team, there was some formation, and then there was some problems, there was difference of ideas, difference of opinions, and so that went on. But who is this person? Yes, exactly. Yes, exactly. Dr. J.P. Bose, what is his contribution? You remember? Yes, sir. He was the first person to use, and which year? 1923. 21, insulin was discovered. Just 2 years after that, Dr. J.P. Bose established the first diabetic clinic in India, and he was the first person to use use insulin in type 1 diabetes, and he classically described the entire clinical features. So, recorded. Yes. So, this is in a nutshell about the history. But what about, anybody knows about this person, Nicholas Constant Paulescu? No, sir. Anybody? Or Israel Kleiner? Paulescu was the person who actually discovered insulin even before this. In 1914 to 1916, he worked on this, and he applied for patent. Unfortunately, that patent was not granted. World War I came in, and before the patent was accepted, it was already this Banting, Best, Colip, their discovery was published. So that was an unfortunate person. Yes. And now about next person, Israel Kleiner. Who is he? He is a North American resident. In 1919, he demonstrated dramatic reductions of blood glucose concentrations of dog rendered diabetic by pancreatectomy when injected with solutions of freshly ground pancreas. But unfortunately, he couldn't separate or isolate this. So you see that the discovery of insulin itself is controversial. Where we know a few names, but we don't know so many names. So this continued, and then a few other names popped in: Joe Gilchrist, Leonard Thompson, and James Havens. Anybody knows about any of these persons? Leonard Thompson is the first boy. Is it? Okay. Is it that? Joe Gilchrist was the person who received the first insulin, but it was in oral form. So it was ineffective. And then Leonard Thompson was the person to receive it injectable form. And then the blood sugar responded. But James Havens was the person in USA who received the insulin first. USA. So as I told, insulin purification was optimized by Collip. And Toronto, the Nobel-winning scientist Auguste Crowe went to Toronto because his wife was recently been diagnosed with diabetes, and MacLeod invited him. There, insulin was administered, his wife improved, and Auguste Crowe secured exclusive permission to produce insulin in his native Denmark. And there the Novo Nordisk Insulin Laboratory started. He had access to a plentiful supply of pork pancreas from his famous Danish bacon processing plants. So now the crystallization stability, what the drawback was, we all know insulin preparation required several injections daily. So first crystallization was done by John Jacob Abel, demonstrating that insulin was stable, discrete compound, and a protein which in future mass production could be possible. Then Hagedron came and added protamine, prolongation, protamine zinc, and then isophane neutral protamine, IPH, isolated NPH. Those were the history which went on and on. But one more question to the audience. Which was the first protein to be sequenced? First protein to be sequenced. I think the postgraduates are also here. Which was the first protein to be sequenced? No, sir. It is again insulin. And who was the person who sequenced this? Sanger. Yes, that's Sanger. Yes. First amino acid sequence was on 1951, completed on 1953, and the entire chain was in 1955. So we see the development now up till goes on with a variety of insulin proliferates. Main advances was in the production. But subsequently, first therapeutic protein was done, recombinant technology was introduced in 1951, and E. coli insulin gene was incorporated in E. coli by Eli Lilly in 1982, and yeast by Novo Nordisk in 1987. Then we all know subcutaneous insulin, the problems with slower rise, later peak, and to combat these mismatches, basal, and then the analogs were produced initially Lispro by Eli Lilly, then Novolog started with Novorapid. Glulazine by Apidra, the long-acting came in 2004. Lantus started Glargine, Lantus was by Glargine, and then Detamir by Novo Nordisk, Degludec by Novo as Tresiba. So those were something there. Now let's come to the devices.
You have to wind up.
Okay. There are so many devices we all know. I won't be discussing, but a few things we all know. We are using this, but what about this? Anybody? Jet injectors, right? This is insulin pump, this is hybrid closed system, and this is artificial pancreas. So these are what we are now going on, and we look forward. We have non-injectable insulins now, like inhalation, oral, intranasal, intraperitoneal, pancreatic transplant, and future generations like Solica, it's already available, Icodec, Esfitora, once weekly subcut, and might be something to come up. So why do we need insulin? Because good glycemic control is the thing which matters, and insulin are the ones which offers maximum glycemic efficacy. But one more question, please, if please allow. Nobel Prize winners associated with insulin. Who are the Nobel Prize winners? Anybody? Apart from Banting breast, Frederick Sanger, sequence of human insulin, we told, and he also received a Nobel Prize. And Dorothy Hodgkin, she discovered the 3D crystalline structure and again got Nobel. might be some of us or some of our students might again get it. So, to conclude, I would present with only this slide. Anybody can understand this? Okay, please read it now. Please read the red letters and the blue individually. Insulin and science, they are actually intertangled. Insulin helped in development of science, and the science is helping in development of insulin in all aspects, whether it's discovery, modification, delivery, everything. So insulin and science are actually interchangeable. Thank you all.
Thank you, Dr. Saikat Datta. Excellent deliberation as usual by you. Okay, hats off to you. Please have your seat over there. I think there won't be any questions because so lucid the delivery was. Okay.
My hearty welcome to Dr. Krishnendu Roy, is the Department of General Medicine, Midnapur Medical College. And this topic is acute febrile illness in geriatric population.
May I start? I don't know how many times you will provide me because we are very 10 plus 2. Now it has decreased from 12 plus 3 to 10 plus 2. Okay. So I have to skip many more slides. Okay. My topic of discussion is acute febrile illness in the geriatric population. All of you know that what is fever. It is nothing but that elevation of body temperature that actually exceeds normal daily variation and occurs in conjunction with an increase in hypothalamic set point. When the hypothalamic set point is not increased, it is going to the separate things, it's not fever. All of you know that in geriatric population, there will be an age-related immunosenescence occurs. Because of that, there is a thymic involution occurs. There is reduction in the hematopoietic stem cells, and also there is impaired function of the antigen processing cells. So that their pathophysiology, their febrile response in comparison to the younger population, a little bit of different. That is blunted hypothalamic response, so that the patients are not presented with normal phenomenon of high-grade fever. They are presented with the low-grade fever and sometimes without any fever. They have reduced cytokine signaling, so that IL-1, IL-6, TNF-alpha, all are decreases. Impaired thermoregulation, so they are decreased fevering. And they have masked symptoms, that is most important, that is the geriatric giants. That means those patients can be presented with 4 eyes, that means either impaired intellect, instability, incontinence, or impaired function. They may have been presented, usually that called, that absence of fever does not mean there is an absence of infection. So that fever in the elderly is not just a thermometer reading, it's often a whisper of the immune system which is struggling to respond. So what are the acute febrile illness? It's most commonly are the infectious. Sometimes it can be a non-infectious, but also you have to consider that is acute undifferentiated febrile illness. So if you consider about the epidemiology, most of the fevers in the elderly presenting with that in Indian situations is infectious, that is 70 to 80%, and among them, urinary tract is the commonest. After urinary tract infections, there is a respiratory tract infection, followed by the tropical infections like dengue, malaria, scrub typhus. And in developed nations, it is reverse, that in those situations, respiratory systems comes first, followed by the urinary tract infections. There are also have some non-infectious causes like malignancy, connective tissue disease, and also the drug fever. Here is one study showing that there is a nosocomial febrile illness in the elderly, published in 1998 of Arch Internal Medicine. it has been documented among the 600 patients that documented that most of the patients presented with the infective causes and rest of them are non-infective causes. Among the infective causes, again, urinary tract infection is the commonest, followed by the respiratory tract infections. If we go to a Turkey study, they have documented that acute fever requiring hospitalization in geriatric patient, comparison versus the infectious versus non-infectious etiology, again documented that infectious comes to the most of the cases, followed by the non-infectious cases. And again here, there is a lower respiratory tract is more important than the urinary tract infections. So if we consider about the common infectious origin in the respiratory, we know all there is a pneumonia, influenza, COVID-19. But in those cases, in elderly, there is a delirium and tachypnea are much more common than the cough. In genitourinary, in younger patients, they are presented with the urinary tract symptoms like dysuria, hematuria, nocturia, and these things. But in clinical clues in the elderly, there is either in the weakness or patient may present it with falls, but no dysuria. Gastrointestinal questions, there may have an anorexia, mild pain, but confusion in elderly patient, you may have to be suspected that they may have a gastrointestinal infections. Yes, tropical cases like dengue, malaria, scrub typhus, and sometimes there is a combination of the both cases like scrub with malaria, scrub with dengue, scrub with leptospira can be presented. In a differential diagnosis, we have to think about some critical diagnosis, some emergent diagnosis. Critical diagnosis in respiratory cases, bacterial pneumonia with respiratory failure, but in emergence cases, we have to consider about that abscesses we have to be considered. Cardiovascular systems, GI system, appendicitis, cholecystitis, but in critical situations, we have to be think about the peritonitis. So what are the diagnostic challenges in the elderly? They have the atypical presentation, no fever, sometimes no leukocytosis. There may have been present with delirium, functional decline as a presenting symptoms. There may have the comorbid confounders, sometimes the COPD, CKD, with their diabetes, and they can alter the baseline vitals and lab reports. There are also the polypharmacy. That means the patients are most often taking the more than 5 drugs, and those patients may have a drug-induced fever, and sometimes they may have the masked inflammation. And also, the older age patients have a delayed care seeking, so there is high chances of sepsis and mortality. So how do we approach in infectious cases? Always we have to consider about the onset, duration, whether there is any associated symptoms, particularly the localized symptoms, whether there is a recently hospitalization, whether there is any invasive procedure, particularly the catheter use, what are the antibiotic exposure has been done, whether there has been travel history, particularly in case of the malaria, scrub typhus, dengue, and drug history always to be kept in mind. In infectious patient, temperature pattern may be absent or low grade in elderly patients. Respiratory focus, yes, crepitation, tachypnea may be present. Genitourinary present, suprapubic tenderness to be evaluated, and catheter discharge always to be looked for. Abdominal system, hepatosplenomegaly look for, and in CNS, delirium and altered mentation. So again, the diagnostic approach, if we consider about the investigations, always first start with the basic investigations like CBC with CRP and liver function test, renal function test, urine analysis, and chest X-ray. In case in elderly, you have to keep in mind there may have not a leukocytosis, but ESR is often elevated. Then we have to go for the focused investigations like respiratory systems, swab testing. There may have a sputum testing. There may have a blood and urine cultures. Blood culture, kept in mind, less than 40% cases of sepsis patient blood culture is positive. So 60% cases blood culture may be negative. Tropical workup, but in case of the tropical workup, always kept in mind, you have to think about the which date of the figure starts it. Because if you do a dengue test of IgM antibody against dengue in day 3, you may not have the positive results. In those situations, you have to do the NS1 test. So the day of fever starting is have to be kept in mind. Imaging, yes, chest X-ray, ultrasonography, and in some cases, the advanced stage like the CT. Decision making and pitfall avoidance, always high suspicion of sepsis when there is a more than equal to 2 search features with new mental change, kept in mind, new mental change with hypotension. We have always have to be think about there is a sepsis. If there is no focus after 48 hours, think about that whether there is any hidden abscess is present in the infective endocarditis, any device-related infections. Avoid premature antibiotic escalation and reassess daily because elderly deteriorate fast while subtle signs. So these are all the differential diagnoses. We all know there is a non-infectious causes like AMI, there may have a pulmonary embolism, there is a CNS lesions, there may be pulmonary edema, there is heart failure, there is pancreatitis, and also the drug fever. So in those cases of that non-infectious causes, diagnostic approach is that fever without localizing sign, which is persisted more than 1 week despite of antibiotic therapy and negative culture, we always have to be kept in mind whether there is a drug history and autoimmune background to be checked for that. Fever pattern sometimes gives some clue. If there is a quotidian, in cases of the non-infectious cases, we have to consider about the adult stage disease. If there is a relapsing fevers, we have to be considered about the lymphoma, and persistent low-grade fever, again in case those situations, drug fever to be considered. So again, infectious disease, non-infectious causes of investigations, more or less baselines investigations are same, but autoimmune screen has to be taken care of and always to be done the high ferritin. We all know that in high ferritin is usually in some cases of the Still's disease. In LDH, if it is very high, always to be considered about the lymphoma. Imaging gives you the sometimes a good results, and those situations sometimes the bone marrow test and the drug rechallenge test can be done. So infectious versus non-infectious cases, if there is an onset in acute or hours in days, it is usually infectious. If it is non-infectious, it is subacute to chronic. If it is fever grade is high with infectious, non-infectious is moderate. Associated localizing symptoms is mainly in cases of the infectious. Inflammatory markers, particularly the procal, is mostly in cases of the infections. But have to be kept in mind in non-infectious cases, ESR is mostly elevated in comparison to the CRP, and the steroid response sometimes in cases of the non-infectious cases. Third variety that is called an acute undifferentiated febrile illness in the elderly. This is a study done from the CMC Vellore, and they have shown that if the patients have a fever more than 14 days, if there is no antibiotic, there is a non-responsive, you have to be considered about other undifferentiated febrile illness. In those patients, in some patients of their undifferentiated febrile illness where there is no differentiation like respiratory, urinary or abdominal symptoms, always think about in our situations all of the tropical cases, and those situations the scrub, dengue, malaria to be kept in mind. So the understanding of the AUFI, that is definition, fever is less than 14 days duration without clear localizing features, commonest febrile symptoms in the tropics, usually suspected viral cases, some bacterial and some protozoal cases, and the geriatric twist is that atypical or mutated presentation. That means in cases of the dengue, there may not have any rash, there may have a mild leukopenia, there may have a high risk of dehydration, renal failure, and delirium. So in those cases of diagnostic approach, basic level investigations are the same, but the tropical investigations to be kept in mind. If 48 to 72 hours, go for a blood urine culture, ferritin and procal gives a good clue. And in 72 hours, more than 72 hours, and if the patient is deteriorating, always go for a CT and MRI. General therapeutic principles, we all know, only to be kept in mind, avoid the nephrotoxin, adjusting the doses, and stop broad-spectrum agents. We all know these things, we do not go that. Preventive measures we have to be kept in mind, particularly the vaccinations, vector control, personal hygiene, and nutrition to be kept in mind. Systemic and institutional prevention is also important because hospital level infection control protocols should be kept in mind. Community level elderly surveillance clinics can be done. Family and caregiver training, recognize early warning signs, and regular follow-up to be kept in mind. So in summary, in elderly patients, as the patients go older, there is immunosenescence lead to the atypical infections. Fever may be absent, functional decline that can lead to that there may have infections. Infectious cause is dominated, but non-infectious cause rises. Management, early empiric therapy, and outcome depends on timely recognition plus supportive care and preventive strategy. So thank you very much for your patience sharing.
Thank you, sir. Sir, my question is, which Which lab marker is reliable in bacterial infection? That is CRP or prolaxetin?
If you consider about the bacterial infection, definitely the Procal will give you the much more ages. But in sometimes, some situations, you may not get the Procal, may not be available. In those situations, you have to check for that, what is the clinical findings along with the leukocytosis, and in those situations, CRP gives you a good suggestion.
Thanks.
CRP actually little bit, I mean, non-specific, because it just indicates underlying
in those
inflammation.
situations, only if there is a no Procal is available.
Yeah. Thank you. Any other questions from the House? The topic is open to the House. Now, diagnostic value is little bit there because probably you are not being in position whether it's viral or bacterial, whether procalcitonin is increased or not. That way it could be differentiating to some extent. It cannot be 100% sensitive or specific, definitely. Okay, thank you. Thank you, Dr. Krishnandu Roy, for coming all the way from Midnapur and giving a very informative topic. Okay, your lecture has been very informative and lucid also. So I now, so far my information goes, just a minute, so far my information goes, my stomach is having griping pain, but most of the delegates and faculties have had their lunch. So just, that's why we will just allow 15 to 20 minutes for lunch, and after that we will come back. So we cannot offer you 45 minutes. Okay, so majority of us had their lunch. So those who didn't have, so please try to finish their lunch within 15 to 20 minutes and come back. So we will definitely come back. It's 2:10. We will start at 2:35. Thank you.
Madhu? Yes, sir. We now arrive at yet another distinguished and pivotal.
Good afternoon, everybody. We have started the post-lunch session, and we are starting our post-lunch session with a, very important person's lecture, that is our President's oration. So I would like to invite Dr. D.P. Singh, all the way from Darbhanga to here, Muzaffarpur to here. Then I call upon Dr. Shekhar Chakraborty, Bhagalpur. Sorry, from Bhagalpur, Dr. D.P. Singh, professor from Bhagalpur, all the way from there to here to attend our first ICP-CON. I call upon Professor D.P. Singh to be on the stage. I call upon consultant physician and one of the most revered physician in Siliguri, Dr. Shekhar Chakraborty, to come on the stage, please. And I also call upon ICP API Chairman, Bihar chapter, Dr. P.K. Agrawal, to be on the stage for chairing our President's oration. Over to the chairpersons for the proceeding. Thank you.
Hello. So good afternoon, everybody. This is the most important session, that is the presidential oration. And we welcome our revered, honorable, dynamic President of Association of Physicians of India, Dr. Professor Jyotirmay Paul. Please give him big hands. And when our President speaks, he speaks knowledge. When he speaks the guidelines. He speaks the directions. He gives direction to the API, and he has taken the ICP to a newer level. And Indian College of Physicians, now we are talking, go to the colleges And this Indian College of Physicians is becoming just a part of the colleges, and where we are concentrating more on the teaching of the postgraduates. And for last 2 to 3 years, we are having the PG classes, master classes, and so many things across the nation. And sir, you have galvanized ICP, Indian College of Physicians. Over to Dr. Professor Paul. Thank you, sir.
Thank you, Dr. D.P. Singh, Dr. Shekhar Chakraborty, Dr. P.K. Agarwal for your introduction. And I must congratulate to the scientific committee and organizing committee of first Bengal Bihar joint ICP-CON that is held at Kishanganj Medical College. So when the scientific chairman talked with me regarding the topic, then I chosen a topic that is less discussed, that is neglected, in other words. But Bengal or Bihar has a huge burden of that particular disease, that is neglected topical disease. Now CSI is going on. So another aspect of the burden of neglected topical disease on human health, there is a burden, or there is the involvement of the cardiovascular system. So neglected topical disease and its impact on cardiovascular system is that we are going to discuss in next 15 to 20 minutes. So what is neglected topical disease? These are the diverse group of infectious disease caused by different virus, bacteria, parasite, fungi, and affect the people of the low and middle income countries, particularly people having those who are underprivileged or poor economically. It is called neglected because these topical diseases has a huge burden on human health. But the attention not received so much from the health sector, from the clinician, from the policymaker, from the economist, and from the researcher, and even from the pharma industries. So in spite of having huge impact on the human health, it is quite neglected in every aspect. So NTD is affect almost 1 billion people worldwide, and they are mostly different vector bornes, have animal reservoirs, and associated with complex life cycles. So list of NTD differs from continent to continent. It is mostly confined in the Asia, Africa, and Latin America. Some diseases more prevalent in Latin America, such as Chagas disease, but some disease more in this subcontinent, Asia, particularly India, such as Kala Jar. So list of NTD differs from continent to continent. The most prevalent NTD prevalent in India. These are the most prevalent NTD that we get in India or this subtropical, this Indian subcontinent. So let us discuss what is the CV impact of these NTDs in India. Though there are some infectious disease, maybe comes under tropical or non-tropical. Some disease have well-known established CV involvement, such as rheumatic fever or Chagas disease. But apart from these well-established diseases that have a CV impact, other diseases that are less discussed or we are less aware, but they may be from virus such as dengue, Zika, chikungunya, from protozoal, malaria, leishmaniasis, from helminth, echinococcosis, schistosomiasis, cystisarcosis, or bacterial tuberculosis, though it is not come under the category of NTD, but no discussion complete unless we discuss the involvement of tuberculosis in cardiovascular system. So if we go through the literature, there is sporadic case reports of NTD that is involved the cardiovascular system, though in total incidence is not very high, NTD and CV involvement. These are the different literature, will come later on. The NTD basically affect the cardiovascular system in different way, either direct myocardial involvement or immune mediated damage. The NTDs causes the hyperimmune system, and this complement and immune system that damage the myocardium. Or in a chronic stage, there may be fibrosis of the myocardium, pericardium, and conduction system. or there may be secondary involvement due to hypoxia, hypovolemia, drug toxicity, and they can interact with the pre-existing CBD. So these are the different mechanisms by which the neglected tropical diseases that can affect the cardiovascular systems. So coming of the few cases that we often encounter. First, most common disease that nowadays, last at least 20 years, the physicians are facing, that is the dengue. Dengue is becoming like Durga Puja, it is a yearly event. So this is the one case report. This is the case series of the two cases. The first case we have coming, the 21 years female admitted with 4 days fever with precordial chest pain. Fever was associated with severe body ache, headache, rectoorbital pain and macular rash over body. Pulse was 106, BP was 110/76. This patient, we sent the dengue NS1, and this patient admitted in 2018 in RG Medical College. Dengue NS1 came positive, malaria was negative, platelets was 60,000, total count was 1,740, and troponin T was elevated. Chest X-ray normal, ECG sinus tachycardia. This patient echo was done because this patient, one thing is dengue is positive, another there is a troponin T elevated. So that is why the echo was done. The echo shows that the dilated LV, ejection fraction 35%, severe systolic dysfunction. There is a moderate tricuspid regurgitation with mitral regurgitation. So provisional diagnosis was this patient have a dengue fever with pancarditis, that is involvement of all the endocardium, myocardium and pancardial and pericardium, and there is a left ventricular systolic dysfunction. After 2 days of admission, patient suddenly developed palpitation and pulse rate was very high. BP was 90/60. ECG shows the non-sustained ventricular tachycardia, which was terminated by giving the bolus injection of the amiodarone. Anyhow, after 2 days of this conservative therapy and continuation of the maintenance dose of amiodarone, and patient gradually become afebrile, chest pain subsided, and no further episode of palpitation. The blood pressure settled, ECG become normal, but only during the discharge, systolic dysfunction persisted almost between 30 to 40%. So that means this patient is suffered from dengue associated myocarditis. So there is a systolic dysfunction, and it was complicated by ventricular arrhythmia. Case number 2, another patient almost same time was admitted with 3 days fever, headache, body ache, and next day patient developed the maculopapular rash over body. Malaria was negative, dengue NS1 was positive, and his hemoglobin was 13, total count 5,400, platelet 1.2 lakhs. So otherwise patient was stable, but suddenly patient developed 3 episodes of syncope. So an ECG shows the complete AV dissociation, because in dengue patients sinus bradycardia is very common, but we hardly see the complete AV dissociation. But complete AV dissociation, complete heart block also possible in a dengue, because dengue virus either directly or through the immune system can affect the SA node. And that is why there can be SA node, there can be sinus bradycardia, or it can involve the AV node. So there can be the complete AV dissociation. Anyhow, this patient was put on the temporary pacemaker. 9th day patient came back to the sinus rhythm, and temporary pacemaker was removed and patient discharged subsequently. This patient was admitted not in medicine department, cardiology department. So take home message from these 2 cases of dengue is, though we are not much aware of the CV of the cardiovascular involvement of the dengue, but the cardiovascular involvement possible. In a Sri Lanka series, 69% cardiac involvement was found. In our published data in the JIMA by Professor C.K. Jana from RG Medical College, he showed there is a 20% involvement of the cardiovascular system in dengue, though mostly in his Dr. Jana's series, mostly was asymptomatic. At commonest manifestation was myocarditis and dilated cardiomyopathy. So myocarditis, cardiomyopathy, reduced ejection fraction is a common abnormality that is found along with the sinus bradycardia, and occasional AV dissociation can be found in dengue infection. The importance of learning these 2 cases, CV involvement, is because in dengue, mainstay therapy is the fluid. We give a lot of fluid, and fluid is the mainstay of therapy. But if we are not aware of the CV involvement, his myocarditis, cardiomyopathy, or ejection fraction, there is a moderate to severe ejection fraction reduction. If we give a lot of fluid without knowledge of the CV involvement, there can be heart failure, frank heart failure, and patient can develop failure and pulmonary edema. So prognosis may be worst if you give ample of fluid without understanding the possible CV involvement, which is maybe up to 20% as per the series of the Dr. Jana. Next, we are coming to the chikungunya. Patient frequently, this post-rainy season come with fever, with headache, body ache, arthalgia. But we test usually for the dengue and malaria. We do not do so much for the chikungunya because mortality is very low. That is why, in spite of having severe body ache, headache, we hardly we send test for the chikungunya. But awareness is important because chikungunya, there is a case report that chikungunya, heart can be involved and there may be catastrophic presentation. This is the one case, 36 years male, and with emergency, with 5 days of the fever, SOB, and one episode of seizure. Patient has an intense body ache and headache. Patient treated conservatively, and what we do usually malaria, dengue tests found negative. Fever not subsided, so we have treated. Patient may have some sepsis, so blood culture shows the growth of the Klebsiella pneumonia, and patient was treated accordingly. But this patient suffered a cardiac arrest and succumbed to death. After death, autopsy was found. In autopsy, it was revealed that patient has a fluid myocarditis, hemorrhage in the heart, and thrombotic microangiopathy in different organs like kidney, lung, and liver. And also, there is a pulmonary arterial thrombi, pulmonary edema, and hemorrhage. And this patient, from the autopsy, the PCR was done, and PCR was positive for chikungunya virus. That means, in this case also, so usually do not test for the chikungunya because it is known there is a mortality. It is a more a dissembling arthritis or arthalgia may persist for a prolonged period. But due to less mortality, we do not do much tests. But testing or diagnosis of the chikungunya is important, and also we should keep in watch about the possible CV involvement because the catastrophic outcome from the from the chikungunya is possible. And there is also several case series that if the chikungunya involves the heart, initially they cause the myocarditis, but this can contribute to the transition from initial myocarditis to cardiomyopathy. Next, we are coming to the protozoal infection from malaria, usually primarily from the direct malaria invasion to the heart or immune-mediated damage, not very well known. Usually in malaria, the cardiac involvement due to the hypoxia, hypovolemia, or involvement of the other organ. There is one case report. This patient was admitted, gone from the Bihar, was admitted in the AIMS New Delhi with 10 days fever. Fever was associated with chill and rigor. Patient has having SOB, tachypnea, tachycardia. On examination, found hepatosplenomegaly jaundice, which is common in a severe malaria, but this patient we got the raised GBP, fine capitation at the base. And MP slide and MP antigen was positive for falciparum malaria. So chest X-ray shows the features of heart failure. In echo also ejection fraction 40% and cardiac enzyme was raised. That means this patient has a severe malaria. Usually severe malaria, renal, hepatic involvement or the cerebral malaria is more common. But here we got a cardiac involvement in the form of myocarditis. So malaria, basically CV involvement, if you go to the literature, very, very limited case report on the CV involvement from malaria. But severe malaria can cause the pulmonary edema, circulatory failure, heart failure in up to the 20% cases. And maybe due to the myocarditis, due to the increased pro-inflammatory cytokines that can damage the myocardium, or there may be more cytoadherence. Because in case of falciparum malaria, the adherence to the endothelium increases. So in the coronary artery, maybe due to increased adherence, there may be sequestration of RBC. So there may be occlusion in the coronary artery that can cause the ischemic episode. But important message is, these are the series from the malaria that involve the heart. In all series, the CV involvement is less in severe malaria. But if there is at all involvement, mortality is very, very high. So this is the take-home message from the malaria. If the patient suffers from malaria, we usually concentrate on the liver, kidney or brain, but at the same time we should be careful about the possible cardiac involvement, particularly in the form of myocarditis. Now we are coming to the few interesting cases on helminth infection, cardiac involvement in the helminth infection. First case we are coming, it is a case of echinococcosis. It is a 34 years female admitted with the chest pain. ECG was sinus tachycardia, and patient's tropi and NT-proBNP both was elevated. Echo shows the moderate hypokinesia, around 40% ejection fraction. And very interestingly, you see here you can see the one here in the apex, there is a cystic lesion in the mass in the infroseptal region, here, infroseptal region. So this patient undergone the EOSG testing as we got the cystic mass lesion. So here we got the multiple cystic lesion in the liver, you see. So as there is a multiple cystic lesion in the liver, the serology was sent for echinococcosis and serology was positive. So that means the cystic lesion that is found in the heart, in the introseptal region, possibly it was due to the echinococcosis. So echinococcosis involvement is more, we get the involvement in the liver, spleen, kidney, but the involvement in the heart is not very well known. So there is some sporadic case report of involvement of the heart by echinococcosis. Patient was put on the albendazole and was operated, and after 4 weeks when patient was discharged, the ejection fraction improved from 40 to 55%. So echinococcosis cystic lesion, apart from liver, can affect the myocardium, myocardium also, and can cause the occlusive lesion that causes the compressive symptom, that causes the heart failure. The importance is diagnosis and treatment, particularly the surgery, because sometimes it can rupture and it can cause the inflammation of the myocardium and embolic phenomena. Another case is coming through the cystic one case of cystic sarcosis. That is a 32 years male admitted with several episodes of the seizure. Patient was alcoholic and used to take beef and pork. Patient found the multiple cystic lesion in the bilateral arm. So patient have a seizure, has a bilateral cystic lesion in the arms, and CVS examination, we found the ejection systolic murmur at the aortic area. So, this patient undergone the echo, and you see there is a multiple cystic lesion that is occluding the LVOT. That is why you are getting the ejection systolic murmur. So you are getting the cystic lesion both arms and getting seizure, and there is a echo, there is a occlusion of the LVOT. So this is also the case of cystic sarcosis, and in autopsy, though the cardiac involvement clinically we do not get much, but in the autopsy study, 20% cases, we can got the cardiac involvement in different series, and cardiac disease is distributed in both the endocardium and myocardium and can cause the inflammatory reaction leading to myocarditis and subsequently cardiomyopathy. And in the chronic stage, that can do the fibrosis of the different conduction system, and different type of conduction abnormality may be found. But usually in cardiac involvement in cystic sarcosis is asymptomatic, though in this case presented with a AS like aortic stenosis like feature. The third case we are coming to, one case of schistosomiasis, is a 40 years male admitted with cough, SOB and hemoptysis. Patient have a abdominal distension and hematemesis melena. So your initial diagnosis of maybe portal hypertension. Patient has a history of swimming or taking bath in the local swimming pool. On abdominal examination, there is hepatosplenomegaly or dilated abdominal vein. So our provisional clinical diagnosis of patient probably suffering from portal hypertension, maybe with cirrhosis. In CVS examination, found the JVP raised, PT loud, and left parasternal impulse was present, and RVS3 was present. That means this patient have a possibly cirrhosis and portal hypertension along with right ventricular failure. Echo shows the severe pulmonary arterial hypertension with dilated right heart. And on further investigation shows that patient have a liver cirrhosis with portal hypertension. And positive cystosoma antibody testing was found. That means this patient has a cirrhosis with portal hypertension and has a pulmonary hypertension with right ventricular failure. How in schistosomiasis the pulmonary hypertension is possible? Because here the cystosoma they accumulate in the pulmonary artery and causes the local inflammatory reaction. As a result, there is a fibrosis or occlusion of the pulmonary artery that can cause the pulmonary hypertension and subsequent dilatation and overloading of the right heart and right heart failure. So this is the way cystosoma, though we get more common presentation from the liver, the pulmonary hypertension due to occlusion of the pulmonary circulation by its aches or inflammation also possible to present as a right ventricular failure. Lastly, I told no discussion in this in this part of the world is complete unless we discuss tuberculosis, though it does not come under category of NTD. So tuberculosis is done with the mycobacterium tuberculosis, and pulmonary involvement and heart involvement not very high, maybe up to 2 to 5%, and mostly is aware about the pericarditis, pericardial effusion, constrictive pericarditis. But myocarditis, endocarditis is not common, but rarely less than 1% cases is possible. But mostly tuberculosis affect the pericardium. This is one interesting cases, the tuberculosis affection of the myocardium, though it is not very common. These cases, the 25 years female came to emergency with features of left ventricular failure. She has a SOB and saturation 82% at the room air. She has a low-grade fever for 1 month, weight loss and cough for the 2 months. On investigation, sputum found positive. LV, echo LV was dilated and global hypokinesia, ejection fraction 30%. He put on anti-failure anti-tubercular treatment. After 3 months of the patient improved symptomatically and LV size returned to normal with ejection fraction 52%. Myocardium involved. In myocardium, in tuberculosis, mostly it is the pericardium that is involved, but in myocardium can be involved either as a nodular tuberculosis, miliary tuberculosis, or diffuse infiltration of the granuloma. So this is a case of tubercular myocarditis that lead to the development of the cardiomyopathy. So in conclusion, CV involvement of NTD not very high, but there is enough case report and case series on cardiac involvement of the tropical diseases. These diseases do not get much attention from the clinician, from the researcher, from industry and government, particularly not only NTD, again, the cardiac involvement of the NTD not got enough attention from the clinician. So actual burden of NTD is till not properly estimated, it is to be determined. So thank you, scientific committee, for not neglecting the neglected tropical diseases. Thank you.
Thank you, Professor Pal, for your wonderful lecture. And Dr. Pal has elaborated and fantastically touched each and every point of the tropical disease leading to cardiac disease. So as this is a presidential oration, there is customary not to ask any question. So thank you, Dr. Pal, for your, over to Dr. Agarwal, please.
It's my proud privilege to chair the presidential address. A general proverb, eyes do not see what mind doesn't know. And Dr. Pal presented this case. You must keep in mind that tropical diseases may lead to cardiac involvement. And very beautifully, case selections are given to you, and you have to keep in mind that tropical diseases may produce as a cardiac involvement. Thank you, Dr. Pal. Thank you.
Just one suggestion, please give standing ovation to our
Thank you. One thing is clear from your talk, that every patient should have an echo done. all degree, all chicken, there should be an echo done. Unless you do an echo, you cannot identify. So that he has established. All degree patients should do an echo.
Good afternoon, everyone. On behalf of the organizing committee of ICP-CON 2025, we, Dr. Gurjot Singhil,
and Dr. Vibleen Kaur,
extend a most respectful and heartfelt welcome to our esteemed faculty members, distinguished speakers, honored guests, delegates, residents, and students.
It is indeed a privilege to gather in the company of such esteemed clinicians and scholars.
With these words, we take the honor of initiating the 6th session for the day.
Without further ado, we move on to our next session, the Spectrum session. We extend a warm and respectful welcome to the following esteemed medicine dignitaries. For chairing the session, Dr. Dipanjan Bandopade, Professor and HOD, Department of General Medicine, North Bengal Medical College, Siliguri.
Dr. Pranab Kumar Saha, HOD and Professor, Dermatology, MJ Medical College and Hospital. Dr. Kali Sankar Bhattacharya, Consultant Surgeon, Raiganj.
Dr. Jamaluddin, Consultant Physician and Associate Professor of MJ Medical College.
Dr. Shankarlal Ramdas, Consultant Physician, Kishanganj.
To kindly come forward and take their seats on the dais. Your presence truly elevates the stature of this session.
Good afternoon, everybody. After the presidential oration, we have a couple of speakers, 4 speakers, I believe, for this session. And it's a pleasure to invite on the dais my friend, Dr. Piyush Kanti Mondol, who is professor at Malda Medical College. And apart from being an academic person, Piyush has been a wonderful organizer. He is a prime mover of the Malda city branch of the Association of Physicians of India. And we have had the good fortune of being Piyush's guest at many points of time. Let us hear the management of Snakebite from Piyush.
Thank you, sir. Thank you, respected chairpersons. It's an honor to talk after a oration by the president, when, especially when it is being delivered by Professor Jyotirmoy Pal on a topic which is not very much discussed, that is neglected tropical disease. And I'll be highlighting a specific disease of that spectrum, another neglected tropical disease, that is snake bite. To introduce my topic, snake bite is an acute, life-threatening, time-limiting medical emergency considered among top 10 neglected tropical disease of priority. This snake bite has been prioritized by WHO in 2010, and it has been put on top 10 neglected tropical disease. It is a preventable public health hazard, as you all know, and it is mostly faced by the rural population in tropical and subtropical countries where there is heavy rainfall and where there is humid climate. If you go through the epidemiology, where the reported deaths by snake bite, the most important complication of snake bite, only is it is 7.23%. However, the incidence, if you go through the incidence, worldwide incidence, it is almost 5.5 million total bites. May not be a venomous bite, but total bite, it is almost 5.5 million worldwide. And death with this bite is almost 1.138 thousand deaths. And in India, it is almost 45,000 deaths that are occurring due to snake bites and its complication in a year. This is the impact of the disease, of this snake bite. In West Bengal, one of the states of India reporting high snake bite incidences. Even in Bihar, we are seeing many snake bite cases, however, being underreported, but most of the incidences of snake bites are occurring in the Tamil Nadu, Maharashtra, Uttar Pradesh, Kerala, and the fifth one is Bihar. Over the year, there is an increasing trend of both cases and deaths in Bihar as well as in West Bengal. You will be wondering to know that there is almost 250 species of snakes which is found in India particularly, around which 60 species are venomous, and out of 60 venomous species, about 50 are sea snakes. So only 10 to 15 variants of the snakes are can be found in this part of the world. These are the geographical distribution of the snake bites and the death due to snake bite. And in India, you can see the largest number of deaths and cases of snake bites can be seen in southern part of the India, as well as it has been found in southern part of West Bengal, particularly in the Sundarban areas. These are seasonality of snake bites, which is most commonly found, can be seen in rainfall season, rainy seasons. In India, there are 4 species which are responsible for 99% of venomous bites. So there are venomous bites and non-venomous bites. And only the 4 species are there which can cause venomous bite. These are called big fours. One is spectacle cobra, Russell viper, common crate, and saw-scaled viper. These are the 4 important, most important snakes that are being found in this part of the world. If you classify the snake bite, one is venomous, another is non-venomous bites. Most bites are non-venomous bite. This should be very clear to all. And venomous bites are mainly of 3 types: neurotoxic, hemotoxic, and myotoxics. Myotoxic are usually myotoxic snakes are usually found in sea. However, neurotoxic and hemotoxic bites are most commonly we are encountering in our daily clinical practice. The neurotoxic bites are commonly due to cobras and kraits are the most important snake that are being manifested as neurotoxic bites. And hemotoxic bites are Russell viper, and pure hemotoxic are other vipers. This hump-nose pit, saw-scaled viper, etc. The neurotoxic manifestations are being produced by the cobras, Indian monoclate cobra and king cobra, which is commonly known in Bengal as Sankhachur, and the keute and gokhro are the others, that is spectacle cobra and Indian monoclate cobra, which are responsible for most of the neurotoxic bites. The kraits are the most important snakes which can produce neurotoxic manifestations. This Shankhamuti, that is branded kate, is more common in West Bengal. Black kraits, wall sin kraits, etc. are the other kraits that are also important in terms of producing manifestation of neurotoxic manifestation actually. These are the snapshots of different types of snakes. First one is gokhro, then keute, Sankhachur and Kalach. The hemotoxic origin of the hemotoxic type of snakes are Russell vipers. This is most common, and it is being called in Bengali as Chandrabora, which is very much commonly found in western West Bengal. This is hemotoxic, with some of it can produce neurotoxic manifestation. Saw-scaled viper, this is a pure hemotoxic snake, and it is very rare in West Bengal as well as in this part of the Bihar. The pit vipers, hump-nose pit viper, green pit vipers, mountain pit vipers, these are the other snakes that are epidemiologically important. Pathophysiologically, venomous snakes have 2 venom glands. If you go through the pathophysiology of snake bite, this has got 2 venom glands. Fatal doses are 42, 15, and 1 milligram for viper, cobra, and krait respectively. More than 90% venom is different biologically active proteins. So most of the venoms are made up of proteins, enzymes, and certain other low molecular weight compounds. The venom enzymes are procoagulant, having phospholipase A2 activity, hyaluronidase, neurotoxin, and nephrotoxic. So these are the basic pathophysiology, basic physiology through which a venomous bite can do harm to a human. Going to the first aid treatment, this is not actually the treatment. The first aid treatment, in view of limitation of both tourniquets and pressure immobilization methods, these are rejected for use. We are popularly seeing many, most of the patients, especially from the rural background, comes with some tourniquets and pressure immobilization when they come to the wards. But these are, considering its hazardous effect, this method is being rejected. But the first aid recommendation is based around the mnemonic that is called RIGHT, which consists of reassurance. The reassurance is very important because it can reduce the anxiety to the patient, and when the patient is anxious, having panics, this snake venom can spread more rapidly, and that can lead to a devastating manifestation or devastating endpoint. And we need to reassure the patient, and we need to ask the patient, we need to say the patient that almost 70 to 75% snake bites are non-venomous, so that the patient gets relieved, that and his anxiety can be reduced. Only 50% bites by the venomous bites are actually envenomate the patient. So among 100 patients, if you come across with snake bites, 70 are non-venomous. Out of 100, the 30 are venomous bites. But envenomation occurs only in 15 cases. So only 15 cases we can see manifestations and complications of snake bites. Then is immobilization. Like in fractured limb, we need to immobilize the limb. If the bite is on the trunk, carry the patient in supine position on a stretcher or country cot. And third one is go to the hospital immediately. There is no alternative. That message should be loud and clear, that there is no alternative other than going to the hospital and taking the care of a medical person. Because most of the time when the patients spare their valuable times in doing Ojha, Jharpuk and other clinics, that is the important time which are not being, when the patient is not being attended by any clinicians or a medical person, which can produce complications. So these things should be kept in mind. And last one is tell the doctor about everything. How are you feeling? How your symptoms are going on? What is right now? What is your complaint, etc. Everything should be clearly mentioned to the doctor. So this is how we can immobilize like a fractured limb, and this is what the complication of doing or tourniqueting the limb. You can see here the production of gangrene due to tight tourniquet in the viper bite. Now coming to the diagnosis of snake bite and envenomation, bite marks to determine whether the biting species are venomous or non-venomous are of no use, because I'm saying that doing this, searching for bite marks only wastes time. It is a waste of time, because most of the crate bites are not producing any bite marks. So this should be rejected, discarded rather. These are the bite marks. Sometimes we found 2 bite marks, but these are of less clinical relevance. Envenomation, how to know whether the patient has got venom or what are the manifestation of envenomation. When the patient is having hemotoxic bites, there will be swelling and local pain, tender enlargement of the local lymph nodes through which the large molecular or high molecular weight viper venoms can enter into the lymphatics. Bleeding from the gums and other orifices like epistaxis. Pain abdomen, vomiting are the other important symptoms of hemotoxic snake bite. We often see hypotension, petechial bleeds, purpura and ecchymosis when the patient has been bitten by a poisonous bite with certain vipers. The passing of reddish or dark urine or declining or no urine output is an important marker of hemotoxic bite. However, conjunctival edema, subconjunctival bleeds are other important features that can be found in patients who are bitten by a hemotoxic snakes. So these are the manifestation. These are the snapshots of complications or manifestation that may patient present with when they are being bitten by a hemotoxic bites. When there is neurotoxic envenomation, that is most importantly we need to mind that descending paralysis may set in. Descending paralysis right from loss of furrowing, then coming to the ptosis, inability to maintain upper gaze. Subsequently, the patient may complain of diplopia and ophthalmoplegia may be there. And the patient may complain of subsequently, may complain of focusing and eyelids are feel heavy. Subsequently, the patient may have dysphagia, subsequently dysphonia, etc. And after a successful treatment, the symptoms will go off in a reverse direction. Progressive swelling and local pain will be there, neurotoxic sometimes when it is bitten by the cobra. Local necrosis and blistering is also very much commonly found when it is bitten by the cobra. So chronologically, patient will be losing its furrowing. There will be ptosis, diplopia, subsequently dysarthria, dysphonia, and subsequently dyspnea and dysphagia may set in when the patient was bitten by a neurotoxic bite. Crate bites are often present in the early morning and paralysis that can be mistaken for a stroke. We get certain patients who presents to us with Gujri symptoms cannot be explained by any other neurological manifestation or neurological disease, along with typical history of open defecation or this sort of things when the patient is lying down in a floor during the night. These are the typical history the patient may present with, along with the symptoms which cannot be explained by any particular neurological disease. Think of crate bites, because crate bites are often painless, mostly the painless, and there will be no bite marks. Early morning pain abdomen is important thing which may present with when the patient is bitten by a crate. Neuroparalytic snake bite patients presents with typical symptoms within 30 to 2 hours in case of cobra bite, and sometimes it is stretched up to 24 hours when it is bitten by a cobra. However, ptosis in crate bite have been recorded as late as 42 hours. So first manifestation, as we can see in our day-to-day practice, that is when we are seeing, when we are suspecting a case of neurotoxic bite, we are looking for ptosis. So ptosis can develop even after 42 hours, up to 42 hours of the bite. So this should be kept into their mind. Locked-in syndrome, we all know about it. It can also be found in patients with this neurotoxic bites. We call in Bengali the Sibonetro, that is ptosis, and these are the other snapshots. And the symptoms can be remembered as 5Ds and 2Ps, symptoms of neurotoxic bite like dyspnea, dysphonia, dysarthria, diplopia, and dysphagia. And the ptosis and paralysis can also be found, and this can be remembered in this way. Clinical features of compartmental syndrome also can be there with the, we can remember it with 5 Ps like pain, pallor, paresthesia, pulseness, and paralysis. So if you compare the manifestations of different types of snake bites, you can see here cobra can produce local progressive pain along with tissue damage. However, crates cannot, most of the crates do not produce local complication, local manifestation. Russell viper can do local cellulitis can be present in Russell viper bites. And these are the other things. I'll be skipping this. Diagnosis of testing, including history, is important. Physical examination with local swelling, painful, tender limb nodes are important marker that the patient may be bitten by a venomous snake. Monitoring of the patient should be done every 1 to 2 hours if possible, and the patient should be admitted for at least 24 hours when there is a definite history of snake bite. Check for check and monitor the other things like pulse, respiratory rate, and most importantly, we need to know the 20 minutes whole blood clotting test, that is 20 WBCT we commonly call it. Every hour for first 4 hours when the patient is showing negative results, and if once the patient shows positive result, we need to infuse anti-snake venom serum. And subsequently, if we monitor the monitor with WBCT, we need to do it for 6 hours interval. So WBCT is a simple thing. We all know about it. We need to have 2 to 3 ml of blood, and we need to put it in a new dry glass test tube for at least 20 minutes. If it is clotted before 20 minutes, it's negative. And if it is still after the 20 minutes, if it is not being clotted, then we need to say that the patient is bitten by a venomous blood. So this is a venomous bite, sorry. So management of snake bite is most importantly dependent on the time. We need to intervene in time. We need not to waste any time doing other things, but to come to a hospital for treatment. So these are the management things. We need to know ABCs, airway, breathing, circulation. We need to closely observe. These are the things that should be discarded, like washing, antiseptic, incision, suction. These are the things should not be done. Do not tourniquet. Patient assessment is important. Exact time of bite should be evaluated. Management of pain should be done by paracetamol only. If it is very much painful, only the patients who are hospitalized and only the patients who are having where there is ICU facilities can be treated with tramadol injections if it is very much important, very much needed. So tourniquet should not be given, but most of the time we get patients having a tourniquet in his limbs. Never remove tourniquet in emergency room. So at the first visit, we should not be removing tourniquet instantly, but we need to do it gradually so that the gush of this venom cannot produce major manifestation and cannot enter into the systemic circulation. So swelling management should be done by managing magnesium sulfate compression, changed to 2 to 3 times a day for 5 to 7 days if there is important major cellulitis. Anti-snake venom serum with 10 vials of AVS is the important thing that should be transfused when we are confirmed that the patient is having venomous bite. We can transfuse 10 ml of 10 vials of AVS. So this is the common practice, and we need to start at a rate of 25 to 50 ml per hour for 10 minutes. Pregnant women and children should also be given with the same dose of AVS. There is no confusion about it. Criteria for administration: when the WBCT or signs of spontaneous bleeding in viper bite is there, or by visual recognition of neurological impairment of like ptosis is there, we should transfuse AVS. Initial dose of 10 vials, both adults and children should be given. We need to keep adrenaline ready while transfusing AVS when there is any anaphylactic reaction. However, this can be prevented by pre-administering adrenaline at a dose of 0.25 ml before transfusing AVS. This should be administered over an hour, 10 vials of AVS to be transfused over an hour with a 400 ml of normal saline. The patient should be closely monitored. How to assess whether the patient is recovering or not? There will be stoppage of bleeding within 15 to 30 minutes after initiation of the AVS. The coagulability is usually restored in 6 hours. We do not have any other way of doing this but to wait for 6 hours after giving AVS. When there is post-synaptic neurotoxic envenoming, like in patients who are having cobra, 30 minutes after AVS, the patient will start improving. And pre-synaptic neurotoxin envenomation as being done by crate bite, it usually takes considerable time to improve. Even 5 to 7 days time can be spared when the patient is in respiratory paralysis and the patient is in ventilator. At least 5 to 7 days time can be needed before recovery. So in shocked patient, blood pressure may increase up to after 30 minutes. So after giving AVS, which is the most definite treatment and only way of treating a patient of snake bite, 30 minutes time is important to reverse the symptoms. So repeat dose can be given after 6 hours if the WBCT is still not clotted. Maximum 30 vials may be infused when the patient has been bitten by vipers. Management of neurotoxicity by neostigmine and atropine, we all know about it. Atropine neostigmine dosage schedule is always in the words. The following measures are useful objective methods to assess response of AN frail. Single breath count test, which is very important, bedside test that can be done, how to assess the recovery from neurotoxic bites by when we are treating the patient with atropine stigmine. So I'll be skipping these things. Remember, antivenom treatment alone cannot be relied upon to save life of a patient with bulbar and respiratory paralysis. So these things should be kept in mind. And patients who are even failed to recover, even after giving atropine of 3 doses, calcium gluconate, especially in patients who are being bitten by crates, calcium gluconate is another drug that can be given. I'll be skipping the dosage schedule. Forced alkaline diuresis is another method when the patient is oliguric, and to avoid acute tubular necrosis.
Between dermatology pain or not, because sometimes the patient don't confess pain or not, because sometimes the patient don't confess, they think it is a separate disease, they go to separate doctor, so it is our duty. And certain infection can lead to both skin and joint, like reactive arthritis, previously was named as Ritter's disease, Lyme's borreliosis, and AIDS. So this is my first case, 43-year-old female, acute erythematous eruption on the face, forearms, and V area of the neck, on photo-distributed area. And close inspection tells her that she had also reddish patch around eyelids, a little puffiness. So this is heliotrope erythema for last 6 months. And she also had proximal myopathy for 1 month, last 1 month. So this is another important caveat, that such patient, if we deal clinically, we should ask the patient that whether she has any complaint of combing hairs or climbing from the bed or chairs or climbing stairs. This sometimes patient miss or won't tell you, and you can miss the myopathy. So ultimately you can't have the diagnosis. This patient also have that erythematous papules on knuckles of hands, that is called Gorton papules. But Gorton signs are different, that is flat erythematous patch in this dorsum of the hand. And where is the difference? From this you can, I think all of you can diagnose the case. It is dermatomyositis. But why not systemic lupus? By seeing hand, we can differentiate systemic lupus from dermatomyositis, because knuckles are usually spared in systemic lupus, and knuckles are involved in dermatomyositis. Very important clinical clue. The patient also have this V sign, this poikilodermatous changes on the V area of the chest. What is poikiloderma? It is telangiectasia. What is telangiectasia? It is the dilated superficial vessels of the skin. What is the difference with erythema and telangiectasia? Erythema is blanchable. If we use a diascopy by simple just glass slide, it will be blanched, but poikiloderma, that telangiectasia won't blanch. It is a permanent. And the patient also have hyper and hyperpigmentation and atrophy. And also the sol shine, that is a dermatomyositis in the upper back, that is start with erythematous, we can give especially facial, if it is a fair skin, but later on it can turn into again poikilodermatous area. So this is another interesting case, that is mechanic sand. Dermatomyositis sometimes present with this mechanic sand that can clinically tell us that it could be anti-synthetase antibody positive. So this is more chance of interstitial lung disease. Sometimes this patient may not have that myositis. The another Holster sign, that is eruption on the lateral side of the thigh, this dermatomyositis can present. Very important in this autoimmune connective tissue disease, the nail changes is very, very important diagnostically. So capillary loops at the proximal nail folds, cuticular overgrowth, periungual erythema, all you can get if you closely inspect such patient. But definitely you will be more confident what we are doing nowadays by dermoscopy. Dermoscopy you can diagnose This previously it was by ophthalmoscope in our student life, we did it, but now dermoscopy is more important. Armamentarium, with that you can diagnose. And again you will get proximal nail fold dilated capillary. In case of scleroderma and other connective tissue also you can similar change, but there you will get nail fold capillary drop. This is my second case, 54-year-old female with malar flush, photosensitivity, photodistributed skin, there is skin eruption. And also oral ulceration, fever and arthalgia for last 1 year. So you are very obvious the diagnosis is definitely for ARK criteria you can tell it is systemic lupus erythematosus. But where this meet facial erythema, we get plenty of cases. Not all cases are SLE. So what is the difference? Here nasolabial fold is spared. That's very important diagnostic clue for systemic lupus. But in case of dermatomyositis, you can get that mixed facial erythema, but there the nasolabial furrow is involved. And also this is a basic difference of the facial rash of dermatomyositis and systemic lupus. And certain other skin disease, we can get this mid-facial eruption like rosacea, but here nasolabial furrow affected. Seborrheic dermatitis, nasolabial furrow affected. Only systemic lupus, it is not affected. Now what is discoid lupus? All you know, this is a limited variety of lupus erythematosus, but what is the basic difference? Here it is a limited, localized, and there is scarring and there is atrophy, which is not present in case of systemic lupus. But discoid lupus, in 5 to 10% cases can turn into systemic lupus in course of time. So you should be watchful if we deal today a case of DLE. And opposite also true, SLE patient may have 10% cases have this DLE type of lesions. This is another case of systemic lupus from my book, that is 200 skin disease. That is you see the malar flash, the oral ulcer, and the photodistributed area skin eruption. Now, oral ulceration is common in systemic lupus, but it is usually painless. That's important. But in case of discoid lupus, in case of lichen planus or traumatic ulcer, it is usually painful. That is a basic difference. Alopecia is very common in systemic lupus, but it is non-scarring. Non-scarring alopecia, that is actually, it is called lupus hair. But DLE, discoid lupus, we can get also alopecia, but that is scarring alopecia. And atrophy scarring will get in the scalp, and also this can happen in lichen planus. Now, systemic lupus may sometimes present with this palpable purpura, that is small vessel vasculitis. What's the significance? These are actually non-specific lesion of systemic lupus. From the specific lesion like malar erythema or this type of rashes, we can diagnose it. This is called specific criteria for systemic lupus as ARA criteria. But non-specific lesions are equally important. Why important? Because it can denote the activity of the disease. And if you get such case of systemic lupus under treatment, and she or he is having this recurrent, this palpable purpura, you can know that the treatment is not adequate. So non-specific lesion we should also take care in case of dealing with systemic lupus. This is atrophy Blancy type of lesion. What is atrophy Blancy? It is actually scarring, healed ulcer, we can see, and along with this lipodermosclerosis type of lesion. If we get such cases in a case of systemic lupus, we can think that there could be underlying APLA syndrome. APLA syndrome, you know, antiphospholipid antibody syndrome, and actually 30% of SLE patients have APLA syndrome. And opposite is also to 10 to 30% of APLA usually start at the setting of SLE. So this is very close connection. We know that we can diagnose by anticardiolipin antibodies or lupus anticoagulant. This can tell us this APLA syndrome. Sometimes deep vasculitis like medium vessel vasculitis could be presenting picture of systemic lupus. Sometimes it could be ANA negative. Very rarely SLE could be ANA negative, and these cases ANCA positive you can get. Now this is my third case, that 41-year-old female having telangiectasia, already I told is a matte telangiectasia we called, and there is bluish appearance of the toes and fingers on exposure of cold, and particularly on the finger and toes for last 10 years. So I think you can diagnose, already I told the history. So tightening and sclerosis of the facial and acral skin for last 3 years. So diagnosis is obvious. She cannot open her mouth properly due to the sclerosis of the perioral skin. And this is Raynaud's phenomenon. All you know, I'm not going details. And this typical sclerodactyly, the loss of terminal tissues of the fingers, bulbous swelling, early stage there could be edema. And this is very important diagnostic skin sign of systemic sclerosis, salt and pepper skin, the tiny dots, the white dots and these black dots. This is another case of systemic sclerosis from my book. If you just see the anemia, each and every patient pallor, if you see each and every patient, you won't miss systemic sclerosis. Because sometimes systemic sclerosis is missed. Patient have no complaint much, except some Raynaud's. But if you routinely practice, this is in our student life, our teachers used to teach us that we must palpate and see. But all patients cannot be seen by virtually, by just mobile, you can't see, you have to palpate. So here you can diagnose the sclerosis. And systemic sclerosis, you know, may present with lot of different vascular malformation, especially vascular ulcer you can get, and very difficult to treat this vascular ulcer in case of systemic sclerosis. And this is localized scleroderma that is called morphia. Again, you have to palpate. Only by seeing you see a dark plaque or whitish plaque, you can't diagnose. You have to palpate. Each and every patient of dermatology, for everybody, every physician, you should palpate. Never take the request by, I'm saying, sending a picture by mobile and you diagnose. It will miss. You will definitely miss a case of morphia. This is linear morphia. It's localized scleroderma. So this type of case usually have no systemic involvement, but some generalized morphia we also get, and we should do a basic ANA test. If ANA is positive, you should be careful. There could be some systemic involvement. This is my fourth case, 53-year-old male having recurrent oral and genital ulceration. And he had also joint pain. Any clue, any diagnostic clue? Yes, very good. So Bessett's, and we know some diagnostic criteria. Criteria 1 is the oral ulceration, and any 2 of the 3 normal, this clinical criteria. So we confirm this by pathology test. Very simple test. Any resident should know this, how to do. It's a very simple test. I'm not discussing, but you should know each and every patient. Recurrent oral ulceration or genital ulcer, we should do simple pathology test, and if it's positive, this could be almost a diagnostic for Behcet syndrome. So now this is the last case, the well-defined lesion with micaceous scale, mostly extensor surface, and also nail pitting there, and also usually aggravating in winter, nail pittings, very diagnostic, and also tactylitis, this patient have, and terminal interphalangeal joint involvement, distal interphalangeal joint usually involvement, but there could be other type of arthropathy in these cases. So definitely it is a case of psoriatic arthritis. Each and every case of psoriasis, we should ask for any joint. This sometime we miss, we won't ask, patient don't tell us. So this is our, actually if it is a psoriatic arthritis, the early stage, if we do our best effort in treatment, the patient definitely, we can avoid the complications and others, or deformity. So this is definitely psoriatic arthritis. So if you are interested, you can see this 201 skin cases, diagnosis, treatment. We have given a lot of example of this type of cases there. So thank you for patient hearing.
I think that was a very good clinical overview, and as we said, we can take some comments from the house at the end of the 4 speakers. Thank you very much, sir.
Welcome.
For giving us this beautiful clinical insight. And it's time now to call upon the dais a person whom we all know very well, who has been a very prominent face in the arena of API and medical conferences in India. I request Professor P.K. Agarwal, the head of the Department of Medicine at Katihar Medical College, to please come up, sir. And sir will be speaking on acute severe hypertension.
Good evening, Kishanganj. At the very outset, I must congratulate Dr. Ghosh, Dr. Bed, Dr. Kramakar, and his team for organizing such a meaningful conference and a successful conference. I have been assigned a very tedious topic, that is acute severe hypertension with a rational approach. This is not possible in 15 minutes lecture. And I'm here not to teach the stalwart of the medicine sitting in front row, but I am here to give an outlook for the rational approach of acute severe hypertension, particularly for the postgraduate students. You all know hypertension remains a public health problem throughout the world. You will be surprised to know 30 to 40% adult population. It varies from literature to literature, but 30 to 40% of adult population is suffering from hypertension. And if you add the masked hypertension to this actual hypertension, it goes up to 60 to 70%. Such a huge number of blood pressure prevailing in the society, particularly in the adult population, as the age grows, the incidence and prevalence of the hypertension increases. And of course, the acute severe hypertension, we level a case of acute severe hypertension when the blood pressure goes above the 180 by 120 millimeter of mercury, and it poses the serious complications like a stroke, myocardial infarction, acute kidney injury, etc. And this hypertensive crisis, each patient is different. It needs different target, drugs, and the time frame to treat. For PG students, 1 or 2 lines you must remember for acute severe hypertension. This acute severe hypertension इलाज की दौर नहीं, but decision की प्योरिटी की परीक्षा है. ये डिसीजन की प्योरिटी की परीक्षा है. एंड एक्यूट सीवियर हाइपरटेंशन तब खतरनाक हो जाता है जब आप जल्दीबाजी में सही कदम उठाना भूल जाते हैं. With this background, we should proceed for the discussion of acute severe, rational approach of the acute severe hypertension. Broadly, it has been divided in 2 groups. One is the hypertensive urgency, and another is the hypertensive emergency. 180 by 120 with target organ damage and without target organ damage. With target organ damage, this is referred as an emergency, and without target organ damage, this is a case of urgency. Another nomenclature, like previous one, the malignant hypertension and the accelerated hypertension, if this blood pressure is associated with papilloedema, previously we classify it as a case of malignant hypertension. And other forms of the retinopathy less than the papilloedema, we classified this is a case of accelerated hypertension. What actually happens in acute severe hypertension? There will be inappropriate discharge of the sympathetic outflow from the brain, and it affects on the various systems. It can increase the arterial stiffness and thereby increasing systemic resistance. This sympathetic outflow may lead to increase in cardiac output. This may lead to vasoconstriction and activation of and the release of renin and thereby activation of renin-angiotensin aldosterone axis. And you all know this activation ultimately leads to rise in blood pressure. If you look for the pathophysiology, this is the flow chart of the pathophysiology, the vessels are in balance, remains in balance between the vasoconstrictor and the vasodilators. When there is sudden increase in the blood pressure, that damage the endothelium, and that leads to the imbalance between the vasoconstrictor and the vasodilator. And there is predominant vasoconstriction. Up to this stage, the patient is in hypertensive urgency. If this hypertensive urgency continues, this may lead to damage to the endothelium, and in turn will lead to activation of the coagulation cascade, and use of platelets. This activation of the coagulation cascade may lead to formation of the thrombus inside the vessels and ultimately lead to decrease in blood supply to that organ. Side by side, use of the platelets may ultimately lead to DIC, disseminated intravascular coagulation. At the same time, there will be the increased permeability of the vessel wall, and the fluid will come out of the vessels, and this results in edema. Depends on which system affects. The sign and symptoms depends on the system affected by this acute severe hypertension. The very common, this may lead to cerebral infarction. Less common, the pulmonary edema, hypertensive encephalopathy, acute coronary syndrome, intracerebral subarachnoid hemorrhage, eclampsia, and aortic dissection. These are the important parameter situations where you may get the acute severe hypertension. You have to evaluate each and every patient very meticulously. Ask about the drug use. Ask about whether the patient is on cocaine, or is there any beta blocker withdrawal. Sudden beta blocker or withdrawal may lead to a patient in acute severe hypertension. Ask about the pregnancy. Late pregnancy may present with the eclampsia and the preeclampsia. Head trauma, of course, leads to acute severe hypertension. Neurological symptoms, agitation, delirium, visual deficit, you see, chest pain. That may be case of acute coronary syndrome, and that may be case of, keep in mind, chest pain with backache, that may be a case of aortic dissection. Never forget aortic dissection. Dyspnea may be representation of pulmonary edema. Dyspnea may be representation of pulmonary edema. Each and every case of acute severe hypertension, rather, each and every case of the hypertension, you must go for the fundoscopic examination and look for the papillary edema and other retinal findings. Signs for the intracranial pressure, you may get like nausea, vomiting. Depends on the case to case, you go for the investigation. The routine investigations like ECG, like echocardiography, urinalysis, RFT, renal function test, liver function test, and if needed, echo, CT, you may go for that investigation. If you look for the management overview, divided in two parts, one is the urgency, another is the emergency. Each and every case is different. I told you, each and every case is different. You have to decide when to start treatment, how quickly the blood pressure should be reduced, what is the target of the BP to be reduced, and what is the drug to be used. These four important questions you must ask yourself before going in detailed treatment of acute severe hypertension. Hypertensive crisis management is very tactful. Too rapid reduction in the BP may land up the patient in shock, and too slow reduction of the BP may land up the patient in ACS, acute coronary syndrome, or pulmonary edema. You have to balance to say both. Do not suddenly lower the BP and do not take too long to lower the BP. If you consider the urgency management, ideally, any case of the urgency or emergency, you must admit the patient in the ICU, and each and every case of urgency, ideally you should admit the patient, but guidelines says you can treat those patients in home too. But for the strict BP monitoring, you should admit those patients too. And the target is over 24 hours. You have to remember the target, dose, time frame, and the drug. In the hypertensive urgency, the target is over 24 hours. Target is 160 by 100 millimeter of mercury, and should not be more than 25%, 25 to 30% of the base level. In next 2 to 3 days, try to reach your target that is less than 140 by 90 millimeter of mercury. Oral drug can suffice to address the hypertensive urgency, like labetalol, clonidine, or you may give hydralazine. But please beware of sublingual nifedipine. Do not try to use sublingual nifedipine. It will drastically reduce the blood pressure. And try to avoid the diuretics. There is already a vasoconstrictor effect, and diuretics may deteriorate the condition. That usually used in the periphery, particularly in the periphery. If you go for the hypertensive emergency, this emergency broadly divided in two parts. One is the special situation, another is the general situation. 4 important special situations like a stroke, preeclampsia, eclampsia, aortic dissection, and pheochromocytoma. These are the 4 situations where the management protocol differs, and others are the general protocol. Whether it is a case of retinopathy, other retinopathy, or it is a case of pulmonary edema, whatever it is, the drug differs, but there must be a general approach. The general treatment of hypertensive emergency, the target, what is the target? Start the IV drugs. Parenteral drugs means parenteral drugs. Oral drugs usually do not suffice for the treatment of hypertensive emergency because there is an emergency. You have to use parenteral drugs. Reduce the BP by 25% within first hour. In urgency, this is 24 hours. In emergency, this is first hour. Try to reach by 160 by 100 in next 2 to 6 hours if the patient is stable. And in next 24 to 48 hours, try to reduce the blood pressure below 140 by 90 millimeter of mercury. The target is different in urgency and emergency. In urgency, this is 24 hours to 160 by 100. In emergency, this is 1 hour to 160 by 100. And in 24 hours, in 24 to 48 hours, try to reach below the 140 to 190 millimeter of mercury. Different situation that may lead to hypertensive emergency, different drugs are used. As for the acute coronary syndromes, you may use diuretics, and the vasodilators are the best drug for acute coronary syndrome. This is labetalol and the vasodilators, and if the patient is in pulmonary edema, diuretics and the vasodilators should be the first choice. In the retinopathy, it could be nicardipine, phentodopan, nitroprusside, labetalol, clevidipine. Which drug is available to your institution or your nearby? Labetalol usually available in the parenteral form too. One important situation, that is the stroke. The stroke is a peculiar hypertensive emergency. It presents in 3 different ways. One could be ischemic stroke, one could be hemorrhagic stroke, another is hypertensive encephalopathy. These are the 3 patterns of the stroke. You must keep in mind 2-3 important points. The cerebral autoregulation is well maintained in a wide range of mean arterial pressure from 50 millimeter of mercury to 120 millimeter of mercury. Number 1 point, auto-regulation is well maintained. Why this auto-regulation? This auto-regulation is because of to provide adequate cerebral perfusion. Why this cerebral perfusion is required? To salvage the zone of penumbra. Have you any concept of the zone of penumbra? This is the zone where there is relative ischemia. One central point is the zone of the necrosis. Outer side, this is the adequate blood supply, and in between this necrotic and the normal blood supply, there is some region that is called zone of penumbra that is going to die. And you have to salvage this zone of penumbra. And cerebral perfusion is well maintained by the difference between the systemic blood pressure and the difference between the systemic blood pressure and the intracranial pressure. You all know any insult to the intracranial insult will lead to rise in the intracranial pressure. To combat that, systemic pressure rises. So each and every rise in the blood pressure, you must not touch up to the 48 to 72 hours. Any drop in the blood pressure may lead to a catastrophe. If the blood pressure is less than 220 by 110 millimeter of mercury, you please don't touch the blood pressure. Stroke management, the different drugs, the target, if you try to give thrombolysis, the target is reduce blood pressure nearly to less than 185 by 105 millimeter of mercury. Otherwise, maintain that blood pressure if it is not more than 220 by 110 millimeter of mercury. In intracerebral hemorrhage, if it is acute, less than 6 hours, systolic blood pressure 150 by 220 millimeter of mercury, lower to 140 millimeter of mercury. And if systolic blood pressure more than 220, lower gradually to 180 by 15 millimeter of mercury with the mean arterial pressure less than 130 millimeter of mercury. Hypertensive encephalopathy. The catastrophe is due to cerebral edema, and reduction of the blood pressure in hypertensive encephalopathy may improve the patient dramatically. Please try to reduce in this such situation blood pressure reduction lower by 10 to 25% in first hour. Another important is aortic dissection. An aortic dissection.
Sir, 2 more minutes.
2 minutes. A rapid reduction of the blood pressure and with the target of 120 millimeter of mercury with heart rate less than 60 millimeter of mercury is required in first hour with the addition of nitroprusside and labetalol. In pheochromocytoma, target is less than 140 by 90 millimeter of mercury in first hour. In preeclampsia or eclampsia, again, the starting blood pressure is 160 by 110 millimeter of mercury. Target is 140, less than 140 by 90 millimeter of mercury in 1 hour. And the preferred drug is labetalol. You may use short-acting nifedipine, not the buccal, sublingual, but short-acting nifedipine. Of course, definitive control is by delivery. You may give magnesium sulfate, perioperative hypertension. When the blood pressure rises more than 20%, this is perioperative hypertension. Take-home message. The hypertensive crisis management, check for the urgency or emergency. If this is emergency, admit to ICU. If urgency, you may treat at home. Prevention is the proper control of chronic hypertension, prevents acute crisis, offers long-term benefit. सही पहचान, सही प्राथमिकता और सही कार्रवाई, यही है acute severe hypertension का actual treatment. Invest your health, take control of your blood pressure. Thank you for your presence here.
I think that was as expected from the prolific Professor Agarwal. Thank you, sir. We move to the last speaker of the session, no less than a person than Professor R.N. Sharkar, a person who needs no introduction to an API audience, and presently the chairman of the ICP wing of the West Bengal state. And sir will be speaking on
লাগিয়ে দাও
topic to sir.
পয়েন্টারটা দেখিয়ে দাও Okay, at the outset I must thank Professor Kormokar and his team for giving me this opportunity to deliver in front of this August gathering, and I will be talking on on subject which is very important in our day-to-day practice, that is pharmacological strategy. Pharmacological strategies in nociplastic pain, the third chronic pain. Now we know that pain is the most important feature in our day-to-day practice, and many of our patients, particularly in my practice, that is in rheumatological practice, and most of the internists, they face with a problem. The patient will come that I have, in my Bengali they say that ব্যথাটা চলে গেছে ডাক্তারবাবু কিন্তু যন্ত্রণা যাচ্ছে না. That is something else is there which is irritating the patient, that is deep inside her, all over the body, that is not going. So that is known as the third pain. Now these are, এটাকে ফুল স্ক্রিন করতে হবে, এই ফুল স্ক্রিন হবে না, ও আমার এখানে হবে না, ওকে ঠিক আছে, হ্যাঁ. Now these are the references, you can just note down and you can find this. Now I will, due to lack of time, I will skip these important two clinical cases. The one was the case of a female seropositive rheumatoid treated by DMRDs for the last 7 years. Now she is now in low disease activity as per these clinical parameters. The laboratory reports are also within normal limits, but the DAS28 and SDI, that is simplified disease activity, this is the jargon, that is also normal. Patient is in low disease activity, but the patient has this multiple tender points. Whenever it was tried to touch the patient, patient will say that don't touch me. And these are also, mapping is done on 18 points, which you can see there, in 18 points, and patient had 16 by 18. Similarly, this case too is a young bank executive who was diagnosed 7 years back with HLA-B27 spondyloarthritis, predominantly axial, with some large joint involvement like hip, knee, and ankle. And he has a very stressful corporate responsibility. That is one of the background of this disease, third pain syndrome. And I will just skip this slide. This patient also have no evidence of peripheral joint synovitis. Tenderness was there in the SI joint, and fever test was automatically will be falsely positive. Mobility tests were all normal. Chest expansion was, however, slightly lower, because he had all along 7 years long ankylosing spondylitis. He has also this multiple tender points, 15 out of this 18. Lab investigation. Now see this pain. Now we all know the pain is an adaptive trait and has cervical value against real or threatened. I will not go into the detail of this IASP, that is International Association for Study of Pain definition, I will go away to this chronic pain, which is defined as a pain persisting for more than 3 months and which can significantly impair the quality of life and daily functioning. We all know that previously we used to describe the pain into 2 categories, that is the broad categories. One is the neuropathic pain from only neurological injury, and one was the nociceptive, which may be due to somatic or visceral any injury or inflammation. Now you have now this third quality pain, that is the nociplastic pain. What is this? It can be considered as an altered nociceptive function caused by dysfunction of the nociceptive processing. The clinical characteristics are there is no discernible injury or pathology in any tissue, and the pain is always multifocal, so you can get multiple tender points, and the pain is not localized but is widespread, and it is out of proportion of whatever inflammation or injury was there in the patient. And there are some CNS-derived symptoms like fatigue, sleep, memory and mood problem. Some patients have irritable bowel syndrome, irritable bladder symptom, and a brain fog. That is a new term, that is a brain fog. That is cognitive functions are not appropriate, like when you take some antihistaminic, you feel like that, brain fog. Now this in 2016, the IASP proposed this third category, and there are several subcategories like fibromyalgia, chronic musculoskeletal pain, which may be called non-specific back pain, then complex regional pain syndrome, chronic primary headache, orofacial pain, myofascial pain, like that. Now, it has been found that about 75% patients of this nociplastic pain, they evolve from previous nociceptive, any inflammatory that is in our practice, that is in, say, rheumatological practice. And about 25% of the neuropathic pain, which the neurologist get, they also convert into this nociplastic pain. Now, in small fiber neuropathy only. Now, so these are known as secondary fibromyalgia, which occur in about 20% patient of inflammatory arthritis, that is rheumatoid, then SLE, spondyloarthritis, and in 25% cases of osteoarthritis. The mechanistically, what happens, there is hyper-responsiveness of the brain regions involved in the pain perception, that is insula and the hippocampus. And also there is hyper-reactive connectivity in and between these brain regions. It has been also found that there is decreased activity of the descending inhibitory pathways, that is the GABA, and raised level of substance P and the glutamate in the CSF. So actually there seems to be an imprint of the past pain which the patient had previously from, say, any arthritis or any injury in the brain. This is an imprint in the brain, the image of which keeps on flashing in the mind, causing pain without any discernible pathology in the somatosensory system. So this cartoon, it explains that this brain in the nociplastic, that the brain, there is neuroplasticity of the brain. So the management. Now, it's very important to explain because these patients come to you after visiting multiple doctors, and there actually some doctors, they just tell that your disease is incurable. So it is very important that you give a diagnosis, don't disorient the patient, explain that your symptoms are real. It is not a purely psychological disorder, is not imaginary. And avoid using complex jargons like a product of abnormal neural signaling with psychosocial dimensions like that. You just explain in a simple word that your brain is hypersensitized or the brain is flared up. And you should expect with treatment, or you can say that your brain is nociplastic. With treatment, it will be relieved. Now coming to the protocol, pharmacotherapy, actually it's a pharmacotherapy for all the chronic pain, like simple analgesic, paracetamol, NSAIDs, opioids should be avoided. And then the main drugs are the CNS acting drug. These are the international guidelines you can all get in the Google University. Now, this is also the WHO chronic non-pain protocol, that is analgesic ladder. I will not go. This is mainly for the nociceptive and neuropathic pain. I will straight away go to the, this is the same thing, that is a practice guideline of the USA. That is, I will go to the next nociplastic pain guideline.
Sir,
now,
can we wind up in
one more just minute? 1 minute, 1 or 2 minutes.
Thank you, sir.
Because my previous speaker has told a lot of things. To date, there are no definite guidelines for this nociplastic pain. But if we consider the pathogenetic mechanism, the cyclic antidepressant and the other CNS acting drug like pregabalin and gabalin can be used. NSAID, however, can be used when there are some evidence of any inflammation. Now, opioids are to be avoided because these patients, it has been seen that the endogenous opioid is high in the brain. So, and this patient, if we get these opioid drugs, they will worsen the hyperalgesia and they modify the sleep architecture. So to reduce this, we can give initially a low dose naltrexone, either 25 or you can give 12.5 milligram also. It is an opioid antagonist. What it does, it increases the density of the opioid receptor by, so the improves the response to endogenous opioids with an improvement in the clinical symptoms. This actually, this similar activity could be obtained by using methadone, a potent MOPR agonist, and a weak NMDA receptor antagonist, which seems able to reduce opioid-induced hyperalgesia. And this MOPR are responsible for both analgesic and euphoric effects of many opioid drugs. And before giving this naltrexone, we must stop the opioid, that is tramadol or methadone, 14 days before. Now coming to the other important, muscle relaxant also should be avoided because it can cause habit forming, respiratory depression, seizures. Topical agents are okay, like 8% capsaicin, 5% lidocaine, or pump spray for particularly post-herpetic neuralgia, or 0.1% clonidine. Now, alpha lipoic acid is very helpful. Another important is this PEA and acetyl carnitine. These are available. And main drug is the tricyclic antidepressant, that is amitriptyline or nortriptyline. We should start with a very low dose. Then we can add SNRI, duloxetine. It's better to give an SNRI in the morning time and a tricyclic antidepressant in the night time because these patients have problem with sleep also. Now, we know this pregabalin and gabapentin, and combination of TCA and pregabalin and gabapentin is better. Cannabinoids are being now used, not approved in India. The main products are labeled as psychoactive is this THC, and non-psychoactive is the cannabidiol. Cannabidiol is not actually now available in India, but I think. No, that is not medicated. You can have a charas, but not that. Now, coming to the other modalities, neuromodulation, I will not go into the detail. This is the domain of the physiatrist. So it's the combined effect of the rheumatologist, psychologist, psychotherapist, psychiatrist and psychologist, and also physiatrist. And there are some interventional treatment, radio frequency, acupuncture, and diamagnetic. I will just skip, and I will thank you for your patient hearing.
Thank you, sir. Sir, just one point. So, do we have a proper pain clinic anywhere at Kolkata? Or institution for pain management?
No institution. In ESI hospital, one doctor was doing it, but he has succumbed to.
Oh, acha, Dr. Shubroto da. Dr. Shubroto Oshan.
Otherwise, comprehensive pain management clinic is not there.
Because that is something we have been hearing of from our student life, that we
it's
have
very
a
important.
comprehensive pain management.
These are actually in New Town they have formed. এটা নিউ টাউনে একটা আছে, শোনো নিউ টাউনে আছে, there is in New Town, but it is run by homeopaths, and because I have got patient from there, Daradia.
Yes, but then, now, for the patient perspective, do we have a center or a institute?
We should start.
We should, sir. We should have a.
We should, sir. Okay.
Anyway, I think we should thank all our speakers. We really had very senior people on the podium. And thank you, everybody. Thank you, organizers.
Thank you so much, sir. We extend our sincere appreciation to the distinguished speakers of the Spectrum session for their valuable contributions, and to our honorable chairpersons for their guidance and for conducting the session with such an academic fine ease. We are grateful to each one of you for enriching our scientific discourse. And we would like to inform for the future sessions, we will stick with the time limit 10 plus 2 minutes, since the time is less. This decision has been taken by the organizing committee. For the future sessions, the time limit will be 10 plus 2. So please stick with the time limit.
We now arrive at yet another distinguished and pivotal session of today's scientific program. I would like to call upon Dr. Reena Ghosh, Consultant Senior Pediatrician, Institute of Child Health, Calcutta.
Dr. Hiranoy Bhattacharya, sir, Professor, Department of Surgery, MGM.
Dr. Partha Chattopadhyay, Professor of General Medicine, Mednapur Medical College.
Dr. Nipedita Haldar, ma'am, Professor, Microbiology, MGM Medical College.
Dr. Deepmala Das, ma'am, HOD of Microbiology of MGM Medical College.
For conducting the session, Disease Trends and Breakthrough, your presence really enriches the academic gathering with your knowledge and inspiration, so please join the stage, our chairpersons.
First speaker कौन है?
DP sir. I would request Dr. Uttam Paul, sir, to kindly join the session as the chair of the coming session.
So now our next session on disease trends and breakthrough is now start. And our first speaker is Dr. D.P. Singh, Professor, Department of General Medicine, Bhagalpur Medical College. His topic of discussion will be on, what is this? He will deliver a talk on pollution and non-communicable diseases. Dr. D.P. Singh, please.
Honorable chairpersons and distinguished colleagues in the hall, and just in this afternoon, we have been assigned to talk about this pollution and NCD. I'm thankful to organizer, especially my friend, Dr. Karmakar, organizing chairman, Atul Vaidya, organizing secretary, and all the friends who have organized this beautiful session, first ever ICP Bihar Bengal session, joint venture. And my topic is the pollution. As you know, pollution is the contamination of natural environment by substances or energy that makes it dirty or unsafe. And pollutants are harmful material causing pollution, maybe solid, maybe liquid, maybe gas, maybe energy. And this pollution could be of the air pollution, water pollution, but chiefly we are more concerned about the air pollution, which is causing in the dangerous proportion. There is a global crisis. It is responsible for 9 million premature deaths annually, 1 in 6 of all deaths worldwide. So it's a great serious disease. Nearly 99% of people breathe air that exceeds WHO air quality guidelines. So all those persons present in the hall are breathing this air quality is not perfect, not ideal. Maybe 99% is safe. And it is a major health risk factor. Air pollution is now among the top global risk factors for health and disease. WHO estimates 7.4 million premature deaths per year. That is attributable to outdoor and indoor pollution. 4.2 outdoor and 3.2 is indoor, including the more than 2 lakhs deaths in children less than 5. India's burden is very severe. Alarmingly, it may be 1.67 million pollution-related deaths in 2019, 18% of all deaths in India. And do you know, 6 of the world top 10 polluted cities are in India. And everybody know about Delhi. Daily newspaper saying that Delhi is one of the most polluted town, maybe in the world that is in a high grade. But do you think that we are aware that how this pollution is creating havoc on our health? How this pollution is causing each and every system of our body? Maybe a heart, maybe respiratory, maybe all parts of the body that can be affected by air pollution. And see this, outdoor air pollution death rates. China #1, per lakh population, 100 death. India, second. 91 death per lakh of population is caused by air pollution. So कहते हैं, मौत का जहर है फिजाओं में. मौत का जहर है फिजाओं में, अब कहाँ जाके सांस ली जाए? Where to go? Which planet? And we are not aware of it. We are not paying attention to it, that how much dangerous proportion, even Bhagalpur, to which I belong to, air quality index goes to 300, 400. We must pay attention. We are practitioners, we are doctors. We have to take care of yourself and also of the people that are around us. And see this. Whenever we talk about the risk factors of cardiovascular disease, we talk about smoking. We talk about this, we are taking low fruits. We are talking about alcohol. we are talking about this high sodium diet. But do we talk about air pollution? That is second to smoking. And in that air pollution, your second-hand smoke is also there. Do you think that we said that our house is the safe area? How much pollution is there in your house? If somebody is smoking cigarettes, how much pollution that is causing? How much passive smoking there by the wives and spouses and children? So we have to be aware that this air pollution is not only in indoor, not only in outdoor, so everywhere there is pollution. It is second to smoking. And see this. If air quality is cutting our life short, and if you compare France, it's a beautiful town. If you compare India, if the air quality index is improved up to the guideline, we can add more than 5 years of quality life. More than 5 years. Everybody is entitled to live 100 years of life. And what we say as a physician, Satayu Swasth Bhava. Aap 100 saal swasth raho. Aisa we just pray, bless to the people, bless to the patients. But the situation is just very adverse. And what are these pollutants? It is air pollutants, maybe primary, that is liberated from the different sources, maybe different gases, maybe solids. And the PM is not Prime Minister. It is particulate matters. That is very, very dangerous. We are going to talk about that. Then secondary pollutants may be ozone. Not the ozone in the upper layer, but ozone in the layer where we are breathing. Acid rain, this sulfuric acid, this nitric acid, that is being liberated by different, this fossils, coal burning, and even the petrol burning, that is causing this acid rain in our atmosphere. Outdoor air, this indoor air pollution. Outdoor pollution generated by vehicles, industries, power plants, agriculture burning. We normally see in this Delhi areas. Construction dust, every town, lot of development, lot of construction work is going on, and that is causing very much this pollution of the air. Natural sources. So this key outdoor pollutants include the fine particulate matter, nitrogen dioxide, ozone, and sulfur dioxide. And all these lead to visual smoke in cities, especially more common in this winter season, and penetrates deep into lungs, causing stroke, causing heart disease, causing cancer, causing acute and chronic respiratory diseases. And see these risk factors of NCD. Indoor air pollution, whether it is library, whether it is kitchen, whether it is bedroom, whether it is living room, whether it is bathroom, whether it is garage, everywhere these pollutions are being liberated. All sorts of pollution, particulate matter, gases, and other things. And see this outdoor air pollution. Even this transports, cars, that is abundant on the roads. Every year we are getting the increased number of cars. Everybody wants to buy a car, and every family has got one or more and 2 cars. How is you are going to decrease the air pollution in your city? And what is this smog? Smog is a smoke fog, a type of intense air pollution. And that is the combination of smoke and fog. That is also causing havoc, especially in the winter season. And this PM, particulate matter, also known as particulate pollution, include all airborne substances that are not gas. It is a mix-up of microscopic solid particles or droplets suspended in a gas. And the smaller the sizes, especially the smaller size, less than 2.5, is much more dangerous than the larger sizes because they are screened off. And see this situation. Coarse PM, that is less dangerous, but PM less than 2.5, all sorts of this dangerous effect on the body, each part of the body, this is smaller particles. When it is, especially if you see the diameter of a hair, that is around 10 mu. So less than that, 2.5, it is percolating to the blood vessels, to the every system and causing damage to the all systems of the body. Indoor household pollution results from burning solid fuels like woods, crop waste, dung, coal, kerosene in open fires, or insufficient stove inside home, as well as indoor smoke in unventilated space are reaching extremely high pollutant level, up to 100 into higher than PM 2.5 concentration that is accepted. Around 2.1 billion people still cook using polluted fuels, causing harmful household air pollution. So this indoor air pollution is also causing havoc. And in indoor air pollution, the women and children are very high risk. Disproportionately affects women and young children. Passive smoke in home is also a significant indoor hazard according to WHO. Second-hand smoke exposure causes estimated 1.3 million deaths per year globally from heart disease, cancers, and respiratory disease. So my dear friends, request will be to make your home smoke-free. Clean cooking practices is vital to protect these vulnerable groups, especially women and children. What is the pathogenesis? How do you think that? And see that air pollutants that are inhaled through the lungs, respiratory physicians, this is our source of entry. And that will cause the reduced lung function. That will cause aggravated allergy. That will cause COPD. That is one. But because it also penetrates the blood vessels, and that will cause the local and systemic inflammation, oxidative stress, leading to cytokine secretion, leukocyte platelet activation, increased acute phase reactants, and going to the heart, giving rise to cardiovascular disease. Going to the vessels, causing all sorts of endothelial dysfunction, atherosclerosis. It also affects the blood vessels, leading to increased coagulability. It can cause cancer by direct genotoxicity, mutation, defect in DNA air, and also affects the brain. I have already told you, any system can be affected, including it can cause increased diabetes mellitus, increased kidney disease, and so on and so forth. So strokes and heart attacks, chronic inhalation of fine particulate, especially the PM 2.5, triggers systemic inflammation, oxidative state, blood vessel dysfunction, which contributes to the increased attacks of atherosclerosis, increased coronary attacks, increased hypertension, and 68% of all air polluted related premature deaths are due to cardiovascular disease. So tiny PM2 particles can penetrate the lung barrier into the bloodstream, causing endothelial inflammations, coagulation, and arrhythmia, and this exacerbates CAD. Air pollution has got very high impact upon the cardiovascular, even in the household air pollution. 32% of the death from household air pollution are due to strokes and heart disease. 12% from ischemic heart disease, 12% of all stroke deaths in certain regions. 2
minutes left, sir.
Yes?
2 minutes.
Oh, okay. So, respiratory disease against COPD and asthma, that is also increased, and 19% of COPD deaths in adults in low and middle income group countries are attributable to indoor air pollution. And many non-smoking women exposed to kitchen smoke develop COPD in rural India. Asthma exacerbation also occurs because of this high level of PM2, PM2.5 and ozone. Evidence in children, that is the pulmonary health, this air pollution is as damaging and as smoking, and chronic inflammation of airways fuels in asthma epidemics by both provoking attacks and possibly increasing new cases. Physicians, especially the pulmonologists, should routinely counsel patients on minimizing pollution exposure to prevent COPD exacerbation. Cancer, again, outdoor air pollution, especially PM2.5, officially classified as carcinogens. The lung cancers, globally 6% of lung cancer deaths in adults are attributable to household air pollution. Clean air, so public health message is clean air is essential to cancer prevention. As smoking rate falls, air pollution may become the leading cause of lung cancer worldwide, especially in urban, non-smoker. So how to prevent it? Monitor air quality and plan this travel. Use protective masks whenever the air pollution is very high, especially the N95. You can use the air purifier, and if you are not able to buy it, keep your window closed when the outdoor air is visibly dirty. Use exhaust fan while cooking and ventilate when air is cleaner. House plants, especially the snake plant, spider plant, or pothos, are suggested to be in the indoor, these plants to be kept. Clean cooking and heating is very important. Good ventilation, no smoking, especially those people who are smoking. No smoking, create a smoke-free home. Do not allow smoking inside homes or cars for patients who smoke. Municipal policies must target open burning of waste. Construction dust control rules should be discovered, obeyed. And in agriculture, crop residue burning should be prevented. And this Clean National Plan program are there, but not effective measures have been taken. So these plans should take boosting the public transport, controlling industrial emission, promoting cleaner fuels, and public awareness campaign. Sir, all our doctors, you are advised we should take efforts to highlight the health benefit of achieving these pollution reducing targets. Conclusion is air pollution is a pervasive threat to public health, a major driver of lifestyle disease like coronary artery disease, stroke, COPD, lung cancer, and even diabetes. It is also inflicts irreversible harm to children and women. Breathing clean air is fundamental to health as safe drinking water or proper nutrition. For physicians, acknowledge air pollution as a modifiable risk factor is important in both clinical practice and broader advocacy. We should routinely consider environmental history, patient exposure at home or work in managing disease like asthma, chronic artery disease, and lung cancer, as this is one of the reversible risk factors. Thank you very much, sir.
How it affects various organs, and even it is a leading cause of lung cancer.
Yes.
So and it is a very important matter of concern nowadays, and how we should preventive measures also you have explained.
But
Thank
it
you
is
very much.
invisible.
It's invisible.
It is
no
an
doubt.
invisible killer.
Thank you, sir, for your excellent presentation. We can have question and answer after the session.
Thank you.
Our next speaker will be erudite speaker, Dr. Dipanjan Bandyopadhyay. Dr. Bandyopadhyay is HOD, General Medicine of North Bengal Medical College. He is well known among all of us. Dr. Dipanjan Bandyopadhyay, please. He will be talking on zoonosis, one health, one world.
May I have the slides? কোথায় যাব কোথায় যাব বন্ধ করে এটা টুলস Good evening, respected chairpersons and seniors and juniors in the audience. I believe it's late and we really need to move fast, and I promise that we will not read through the slides. But then after air pollution, we come to something which is almost as environmental as the previous topic. And we essentially know that there are a lot of important diseases in man which affects both animals and mankind. And historically, going back in time, there have been epidemics and pandemics in the world which have centered around these diseases. The term was coined by the legendary Virchow, the zoonosis term, and there has been significant impact on global economy, trade, and health from the zoonotic diseases. Many of them have been identified. Most of them we know. There are some which are as Jyotirmoy was pointing out, neglected and under-reported. But then zoonotic diseases can range from viral, bacterial, protozoal, helminthic, fungal, and parasitic. We will, as I said, not read through the slides for want of time, but then there can be direct transmission from animal to man when we call them direct zoonosis, or they can be through another intermediate host, in which case we call it a cyclozoonosis, so where they require more than one vertebrate host. Metazoonoses are those which are transmitted biologically by invertebrate vectors, and saprozoonosis need a non-living environmental media for development before they infect man. We will not get into the theoretical part of this because we are all clinicians, but then again, zoonosis can be classified according to the reservoir host of whether the infection is transmitted to man from a lower vertebrate or from a lower vertebrate to man. And if it is bidirectional, then it becomes amphizoonosis. Why are zoonoses becoming so common and so important in today's world? Because of urbanization, deforestation, construction of dams. The picture of the dam is from North Bengal, and many of us have been through the road across. And we all know that the ecology, the ecosystem, the environment, these are all being hampered in a very, very, very big way. Apart from the environmental changes, there is a huge spurt in the animal husbandry industry. And today, we have mechanized animal husbandry processes. We have huge quantity of antibiotics being used in poultry, in dairy, in animal husbandry, and this is contributing to antimicrobial resistance. And most importantly, perhaps, apart from industrialization, international travel has made these zoonotic diseases not restricted to pockets or areas where they were traditionally located, but now the zoonotic diseases are finding a place in the global field. The European Union for One Health is one very active agency which understands or tries to understand the spread of these diseases. And I just gave two examples of two parts of the annual report of the European Union. And you can see all these zoonotic diseases are tracked across the nations of Europe, and the annual report is generated. Like the 2023 report suggests that Campylobacter was the most common reported foodborne GI infection. And similarly, Salmonella was the agent associated with the largest number of hospitalizations and deaths among foodborne infections. So very detailed reporting comes out from the One Health reporting system. So this is the European Union One Health zonal report. And you can see all these diseases must be reported by the agency. So essentially, ladies and gentlemen, what is the One Health concept? The One Health concept can be defined as a collaborative and interdisciplinary approach that recognizes three things: interdependence of human, animal, and environmental health. I think these are basic fundamentals we should remember. Maybe the postgraduates should remember more than us because these are emerging issues. And historically, this human health, animal health, and ecological health has been operational, but they were operational in isolation. And today, we want to bridge the gap, make more interdisciplinary collaboration so that we can be prepared for epidemics, we can be prepared for pandemics, our responses to epidemics can be more structured and more timely. So that is the essential philosophy of the One Health concept. So there are benefits of the One Health approach, which we shall not get into details, but it's beneficial for prevention, for addressing antimicrobial resistance, for developing environmental sustainability, as my previous speaker was pointing out, and most important perhaps, interdisciplinary research and pandemic preparedness. So pandemic preparedness is something which we really must be taking things more seriously, especially after the COVID. This is the Government of India initiative initiated in 2020. So, and there are three pillars of this concept: prevention, preparedness, and response. And we will go through this PPR concept time and again. Who is the target audience? Very, very important slide, although it looks so simple. It's not only medical persons, it's the Department of Animal Husbandry, it is the political will of the nation, it is the administrative people in the administration. So all these people contribute to make the One Health concept successful. We know that India attained the presidency of the G20 Global Summit, and then this was the theme that the government of India proposed during its presidency. And the theme was the world is one family. And the world is one family theme basically centers around the One Health concept. So there are One Health initiatives in India, and essentially the National Program on Containment of Antimicrobial Resistance and the National One Health Program for Prevention and Control of Zoonosis are two of the national health programs which are entwined in the One Health concept. And if you look at the first part of the slide, there are similar national programs in the animal husbandry department. So there are national programs which are overlapping and collaborating and coordinating with each other. This slide is conceptually important because what is basically the way a zoonosis becomes a zoonosis. Initially, the infection is segregated in the animal population. Then it spills over into small pockets of human population. And then man-to-man transmission becomes the rule, and the epidemic or pandemic, whatever occurs. And you can see the cost of containing an epidemic or a pandemic is huge. This slide is important. Jyoti Mada was showing us the slide of neglected tropical diseases. This is the prioritized diseases, zoonotic diseases in India. And you can see there are only 10 diseases which are mentioned here. But then each state is at liberty to add or subtract. Like I keep on telling people that we have heard of Ojana Jor in North Bengal, but we still don't know whether it was actually Nipah. But then Kerala identified that it was Nipah. And so Kerala, or similarly Karnataka for Casanova forest disease, the states can add or subtract the diseases from their list. The most important issue is, ladies and gentlemen, cross-reporting. So if the poultry industry finds an infection coming up in the poultry population, it has to notify the authorities so that the medical section also becomes aware. This is how bird flu spreads, swine flu spread. So it's cross-reporting between the animal husbandry department, the forestry departments, and the health sector, or the director of health services. As I said, PPR are the three pillars. So prevention, preparedness, and response. We want to strengthen these three pillars through the One Health concept. And what are the strategies? Number one, you understand how the infection spreads, you understand the dynamics, you address the drivers of disease emergence. What are the drivers? Like, as we shall show you, leptospirosis means the monsoon is a driver of leptospirosis. Risk reduction activities, prevention of coming into contact with animals, coming into contact with forests, etc., and multi-sectoral coordination. So these are typical situations where leptospira spreads, as we all know. This is not a photograph from a geography textbook. This comes from the guidelines, national guidelines of leptospira control. So these are the scenarios where your rodent populations is likely to increase. When we were MBBS students, this was 1994, when Gujarat had the earthquake, and people thought it was an earthquake. But the earthquake resulted in the plague epidemic, because the earthquake actually shattered the homes of the rodents, and the rodents had no place to live. So they entered the human households. And people entered their households after the earthquakes to rebuild their homes, but they were attacked with plague. So these are the situations where human and animal contacts can come in. So we have mechanisms of reporting and recording, etc., etc. These are some of the drivers of disease, like crowded living conditions, environmental factors, as I said, urbanization. Slaughtering standards are very poor in India. We don't have guidelines, and we don't monitor the way our animals are slaughtered. We don't address human and wild animal conflicts. So even in North Bengal, we find elephants coming on the road and crushing people, and then tigers coming out in the Sundarbans, human habitats. So these are all human-wild animal conflicts. We need to promote better water, sanitation, and hygiene, and we need to address the antimicrobial resistance. This is again the photograph of Nipah virus, and Kerala has done a wonderful job of Nipah virus preparedness. We need to reduce the risks. We need to understand that there are some diseases which are essentially extremely important. I don't remember seeing Japanese encephalitis cases in my almost 15 years of teaching in South Bengal. But the day I landed in North Bengal, Devashish took me for a vaccination. I thought I'd come to Africa for my job. তো দেবাশিস said, চলো চলো তোমাকে ভ্যাকসিন নিতে হবে। So that was the day of I joined NBMC. And that time the piloting was going on for Japanese bee encephalitis vaccine. So I got the Japanese bee encephalitis vaccine. And believe me, the next year as a HOD of medicine, I was shattered with the Japanese bee encephalitis epidemic in North Bengal. I have never seen so Jab bee in Kolkata. So this was the story of Japanese bee encephalitis. And today we know that it is a common disease in North Bengal. It's a vaccine preventable disease. This comes from one of our cases. You see the very classical bilateral thalamic hyperintensities. And we also know that there is a very effective vaccine. And today, any patient with JAB or acute encephalitis syndrome, our PGTs must take the history of JAB vaccination as a rule. Similarly, we have the guidelines for leptospirosis. We know how it spreads, waterlogging, urbanization, poor sanitation, dog urine, animal urine, rodent urine, etc., etc., etc. There are some rickettsial diseases which are important in India, but possibly the most important is scrub typhus. We were asking one of the PG students who was presenting lepto, which is more common in North Bihar, whether it's scrub or lepto. But then this is the Susugumushi triangle, which is the geographical domain of leptospira. If you can look at the India map, then West Bengal is pretty well infected with scrub typhus. And this is the size of the mite. You can see on the fingertip. It's such a small mite that you actually cannot see the mite. And it is often very difficult to find the eschar because it is often hidden inside. Just 2 more minutes, maximum 2. And this is one of the last diseases I will be talking about. But the avian influenza is something which we really, really should be cautious about, because avian influenza is likely to come back again and come back with a vengeance, because that is what the public health experts are forecasting. And there is a lot of migratory bird activities. Again, we have places in North Bengal where people go to photo shoot migratory birds. I just know of one place which is Gajuldoba. But then avian influenza is something which is on the anvil as predicted by the public health people. Fever after sexual intercourse. This was such an interesting case. This lady came with fever and arthralgia basically, but then she basically had sex with her boyfriend, and the boyfriend had been to the Middle East, and in the Middle East they had taken unpasteurized milk products. So basically, ultimately we landed up with the diagnosis of brucellosis, and Brucella abortus is more virulent and more mortality causing, but Brucella melitensis is the more usual infection that we face. And there are so many avenues of infection of brucellosis. So again, we will not go into brucellosis, but it can present with arthralgia, spondyloarthralgia, it can present with orchitis, hepatomegaly, splenomegaly, etc., etc., etc. And this is one investigation possibly the juniors might remember, because brucellosis actually requires a culture for diagnosis. But this is an internationally accepted test which is done in the School of Tropical Medicine at Kolkata, which is a pretty sensitive and specific test for the diagnosis of brucellosis. We don't have time to get into treatment of the drugs, but then it's important to mention that brucellosis is not treatable by a single antibiotic. Your scrub might respond very well to doxy, but for brucellosis you need a combination with doxy. And it is important to remember that brucellosis is one of the agents of bioterrorism. So bioterrorism again is a postgraduate question. So bioterrorism and brucella and anthrax, these are 2 diseases which can serve as an agent of bioterrorism. And this is the last slide. This is just for the sake of the PGs. In fact, my PG downloaded this article preparing for me. So this is also important that paragomoniasis in India is an emerging zoonotic disease. All said and done, we are basically talking of multi-sectoral coordination between 3 people. One is the health department, the animal department, and the environmental department. These are the list of nodal centers or the sentinel surveillance centers in India. And if you look at the bottom part, there are 3 in West Bengal: Diamond Harbour Government Medical College, NBMC Darjeeling, and SSIPGMER. So we are one of the sentinel surveillance centers for zoonotic diseases. All our PGs, all our wards have these 2-page forms, and we need to fill up the forms. And this is basically the system by which our medical college works. These are the tests on the left-hand side. All these investigations are available at NBMC. The right-hand tests are going to be available in a very short time: Congo, Crimean hemorrhagic fever, and Lyme disease. And basically, even the journals like the NEJM and the Lancet, they have recognized the importance of the One Health concept. And to end the story, there are 4 international organizations, the Food and Agriculture, the FAO, the United Nations, the WHO, and the World Organization for Animal Health. These 4 form the quadripartite. So these quadripartite are the 4 organizations which are looking into the affairs of One Health, but One Health is something which is emerging, which is important, and which will keep on coming back in our conferences and maybe in our question papers in the near future. Thank you.
Thank you, Dipanjan. As usual, Dipanjan was very lucid and very helpful. Thank you, Dipanjan, for your nice presentation. Our next speaker will be our teacher, Professor Supriyo Sarkar, Head of the Department, Pulmonary Medicine from College of Medicine and Sagar Datta Hospital. He has taught many postgraduate students, even he is a teacher of me also. So I will ask Professor Supriyo Sarkar to elaborate on problems in EPTB management.
Respected chairpersons, respected delegates, I am thankful to the Parthoda Uttamda for inviting me to talk on, and I have selected this topic, the problem in the management of extrapulmonary tuberculosis. Now, extrapulmonary tuberculosis is defined as tuberculosis of any organ other than lungs. And what is tuberculosis? Tuberculosis is the disease caused by Mycobacterium tuberculosis complex, not by Mycobacterium tuberculosis only. And for extrapulmonary tuberculosis, the bacilli enters through lung. So in all cases of suspected extrapulmonary tuberculosis, chest X-ray is a must. And also, if sputum is available, sputum must be examined for expert, preferably the gene expert, and as the extrapulmonary tuberculosis affect any organ of the body, so in the differential diagnosis of any disease of any organ, we should consider extrapulmonary tuberculosis. And for the diagnosis, the first important thing is that the sampling of the clinical sample. Clinical sample must be examined, and how to collect the samples, the aspirates or the biopsy material, and the aspirate and biopsy material must be sent in normal saline, not in formalin. And in the normal saline, how much saline has to be given? It is to be given just to dip the sample, not more than that, as if it is diluted, then there is a possibility of false negativity. Then to confirm that, the clinical material should be examined for smear, culture, and the molecular test. Now the problem is that sometimes clinical material are not easily available, like deep-seated lesions, the carry spine. But here also, we should try to collect clinical material. In some cases, the clinical material is beyond our scope, like tuberculoma of the brain, in which the clinical sample may not be available. And diagnosis must be done. Always we have to try, because to avoid further complications during the management. Now, the assessment of the patients are very difficult, because the tubercle bacilli are killed by anti-tubercular drug, but the structural changes that already has been occurred will not be reversed by anti-tubercular drug. And there are some other problems like delayed paradoxical response. Paradoxical lymph node may increases during the treatment, or there is a possibility of drug-resistant tuberculosis that is very difficult to identify in extrapulmonary tuberculosis. In the management, the main problem in the management, the usual regime is used, that is 2-HRZE followed by 4-HRE. But sometimes corticosteroids has to be added, and the indications of the corticosteroids are to prevent the drug resistance if there is a drug reactions or iris phenomena, or in some serous tuberculosis to prevent the fibrosis and structural damages. Now, the drug-resistant extrapulmonary tuberculosis was once thought to be very rare, but Kolkata, West Bengal, INH monoresistance or INH resistance has been found more than 5% cases of extrapulmonary tuberculosis. Now, if patient is not responding, we should think of other diagnoses like fungal infection, myelorrhosis, sarcoidosis, lymphoma. Delayed response may occur or residual lesion may persist. Another is that iris phenomena and paradoxical reaction. Now, dual pathology may happen. I have one elderly lady and with cervical lymphadenopathy, and the FNSC shows AB. So anti-tubercular drug was started, but patient was not responding. After taking biopsy, there is a dual pathology of non-Hodgkin lymphoma along with the tuberculosis. And drug-resistant extrapulmonary tuberculosis is another problem. Now going for specific diseases, now lymph node tuberculosis. Lymph node tuberculosis, the peripheral easily accessible, so we can take the clinical material, and USG should be done because for follow-up whether the lymph node size are decreased or not. And lymph node may increase in size, or this is very important, lymph node may increase in size, or there may be appearance of new lymph node during treatment in tubercular lymphadenopathy. So it is very difficult to assess. But in case of deep-seated lymphadenopathy, we can have the imaging techniques. And the imaging, what we get is the central, it is the rim sign, the central lucency, and peripheral, the hyperlucent areas. The central lucency is due to necrosis, and the peripheral is due to inflammatory cell. But it is not specific of tuberculosis, and MRI is better because in MRI we can get the periadenitis of TB lymphadenopathy. Now, as for example, in this case, there is a rim sign, but the FNSC from the lymph node shows it is histoplasmosis, not tuberculosis, with same clinical picture. Now, lymph node management, the duration is usually 6. Sometimes we have to increase the time, and sometimes because the gland may persist, and in those cases, if the size of the gland is less than 1 centimeter, no further treatment is required. If it is more than 1 centimeter, then extension for another 3 months is sometimes necessary, and TB sinus must be surgically excised. Now, pleural effusion. The usual tuberculosis we diagnose by the exudative pleural effusion, then the exudative lymphocytic, and ADA. ADA is more than 70 units per liter. And below that, it is doubtful cases, and even with this criteria, lymphocytic, exudative, high ADA, another important factor that we have to look is that the absence of other clinical diseases responsible for that. As important that in case of empyema, the ADA may be very high. In case of malignancy also, ADAM may be very high. If there is any doubt, then the fluoroscopy or thoracoscopy should be done. Now, pleural fluid CBNAT, that is important. It is sensitive, less than 50% cases. One day, one young executive come to my chamber agitating. Why? Because he has that all the picture of tubercular tubercular pleural effusion, but ADA was negative. And that's why he told me that I have no bacilli, even a trace of bacilli, yet my doctor has given me a drug. And I told him that less than, it may not be positive in more than 50% cases. Then he asked me why the test has been done. So the test has been done for some commission business. So in that situation, what advice you have to give? The patient is very irritated because I have no stress of bacilli in my body. And what a specialist should do at this stage, because the physician is not only our colleague, but also we should guide them and we should protect them. So I told him, you have any children? Yes, I have a 2-year girl, baby girl. So I told him that CBNAT is negative, now we can play with your girl. And that satisfied him. So I have to justify why CBNAT. Before prescribing CBNAT or any test, you must know if it is negative and if it is positive, what is the implication of that. Now, management of pleural effusion, another patient, and in NRS, patient has hemorrhagic. Second time it is a traumatic, probably, and the fluid is rapidly increasing. Fluid is rapidly increasing, so some specialist has told him that probably you have malignancy and you should have investigated the case. And so he was very anxious and came to me. The Professor Arup Kundu has referred this case to me, and I take detailed history. Detailed history taking is very important, and after that I assured him that you have tuberculosis, that is nothing else, you continue it and come to me after 1 month. Because what is very important, clinically, the pleuritic chest pain. If pleuritic chest pain is there, it is practically the possibility of malignant pleural effusion is very less, because pleuritic chest pain means inflammation of the pleura. But on the same time, you should remember the commonest cause of pleuritic chest pain is not tuberculosis, it is the viral pleurisy. So this is another case. What happens in this patient? In this patient, normally our diaphragm, dome of the diaphragm is convex upwards. And when fluid accumulates, it becomes concave upwards. Within this convexity and concavity, 1 liter of fluid may be accumulated. So after aspirating 1 liter of fluid, the fluid again remains the same, and that's why patient the treating doctor is confused. So I have 1 minute. So I know that I cannot complete the subject, and now this is very important. I will show you. This is a massive pleural effusion, and everybody suspected it is malignancy. Then the second thing, after aspiration, you can see, and the concave upwards. Then third X-ray, after aspiration, air enters, so it becomes hydropneumothorax. And in the fourth X-ray, it becomes concave upwards. Same patient, it is encystment is occurring. So this patient, the 4 stages of tubercular pleural effusion, I have seen. But here, the X-ray, if you carefully see the X-ray, there is a deformity of the vertebra. So the patient has cardiac spine also. Okay. Now these type of changes that already has been occurred will not be reverted by giving antitubercular therapy. So other surgery is required. What are the types of surgery? Drainage of cold abscess, debridement, decompression of the spinal cord, and stabilization of the vertebra. These are the types of surgery done. Another point I have to highlight regarding the tuberculoma, we can easily diagnose by MR with MR spectrometry. If we combine MR with MR spectrometry, then the sensitivity and the specificity of the diagnosis of tuberculoma is very, very high, more than 95%. But the problem here is the management. And we must know that the rifampicin has the penetrability is 5 to 25%. And we know that the streptomycin, ethambutol will not penetrate, particularly uninflamed meninges, but also rifampicin penetration is very low in the process, very less in the blood-brain barrier. So the treatment may be prolonged. With this, I conclude because Madam is upset with me. Thank you.
Thank you, Supriya sir, for a nice deliberation. I will hand over the mic to my co-chairperson for the next session.
Now I would like to request Dr. Nandini Chatterjee Madam to come to the stage and deliver her talk on travel-associated febrile illness. Welcome, ma'am. She is currently working as Professor, Department of General Medicine, IPG-MER, Kolkata. Thank you, ma'am.
Thank you, Chairperson. I do not know whether the audience has the strength to bear another 15 minutes of Gyan, but I have traveled for 12 hours for this talk at the behest of our sir, Professor Kormokar. So I'll be talking on travel-associated illnesses. So fever has been reported in 43 to 79% of travelers who have returned from developing countries, of which 36% of cases are tropical infections and rest may be non-infectious causes or non-tropical infections. Now, why is it important to know about travel-associated febrile illnesses? Because it has been found that with extensive migration and long-distance travel, spread of endemic diseases is happening to non-endemic areas. So you can find the news of malaria being detected in Iceland. A few days ago, I read about it. Also, travelers to South and Southeast Asia are at high risk of acquiring multi-drug resistant infections. So it is important that physicians are aware. A small case, a 50-year-old male who went on a vacation to the Himalayan foothills. 10 days after return, he developed fever, chills, body ache, headache, and vomiting. There was no cough, shortness of breath, dysuria, abdominal pain, or drowsiness. So he consulted his family physician on the second day of fever. There was no rash in his body, urine output, vitals were normal. So he was prescribed some antipyretics and rest. So far, so good. When we want to diagnose acute febrile illness, we know that we have to properly obtain the history, get a clue from clinical examination, and then perform some focused laboratory investigation. The operative word here is focused, which means you will not write down a battery of investigations. You will find out the relevant clues and then prescribe the tests. However, in history, we need to study the pattern of fever, also learn about details of the travel history, whether there has been any recent outbreak in that area. It is also important that we take note of the associated symptoms and signs. Is the patient having abdominal pain, jaundice, headache, confusion, seizures, diminished urine output, rashes, bleeding, joint pains, conjunctivitis, etc. If we get such associated symptoms, then we can categorize those patients into certain syndromes. So, travel-associated febrile illness history should be divided under 4 headings: who, what, where, and when. First, about the patient himself or herself. Is the patient having some comorbidity? What is the occupation of the patient? What is the chronic drug history? Does he or she suffer from immune suppression? Has the patient been visiting friends and relatives? This is important because when people visit their relatives, they are less cautious about taking prophylaxis or vaccines. What is the vaccination up to date of the patient? Has the vaccination or prophylaxis for the country at risk been taken before travel? This is very important. Then where is the person going? Is it a rural area or an urban area? Has the person gone to camping in a mountain or a lake or a beach? Is he staying in a proper hotel or some small hostel? Is there a resource of outbreaks in that area? What is the endemicity of disease in that area where the person has gone? All this history is to be asked in detail. Also, you must take into account the countries via which the person has reached the destination. What was the patient doing while he was abroad? Is it a work-related travel? Or the person has gone for leisure? Was there some kind of sexual exposure? Was there hospital admission or history of insect bites, if he remembers? Lastly, timeline. When? Because date of travel and exposure are key to establishing a timeline for the onset of symptoms. Because we know that all infectious diseases have some probable ranges of incubation period. So if you know how many days after visit to that country the patient developed fever, then you can have some idea that what type of infection he or she may be harboring. Like these are examples: less than 10 days, some viral infections; intermediate infections like malaria, enteric fever, leptospira. There are infections who have long incubation periods. We also need to keep them in mind. We may have to assess whether there was exposure or contact with different vectors. Was there history of ingestion of unsafe water or roadside food? What was the pattern of fever? And all of this will help you to categorize the fever into certain syndromes. This slide itself tells you what are the syndromes that we have in undifferentiated fever. So we can have AES, fever with jaundice, hepatosplenomegaly, renal failure, lymphadenopathy, rash, joint pains, ARDS, bleeding, abdominal pain. What I want to say is that each and every syndrome will tell the physician about a group of infective organisms. But we have to remember that there may be overlapping features between various types of organisms causing fever. So Atypical overlapping features are common. Use of antipyretics can change the pattern of fever, and absence of classical pattern should not rule out a particular infection. You are all aware that malaria is changing like a chameleon. So we are having every day atypical presentations of malaria. So you may get a patient who is coughing or having diarrhea and yet having malaria. So clinical signs are not very specific, but they can give you an idea. Examination head to toe. Any part of the human body can hide a clue. So let's back to our case, 4th day. So if you remember, patient went home with antipyretics, but he comes back on the 4th day with maculopapular rashes all over his body. There is conjunctival hemorrhage, and after the 7th day, he develops icterus, decreased urine output, and hepatosplenomegaly. So this patient has fever, no localizing features, but after 4th day, he develops certain complications. So when we have such a patient, we have to categorize them into syndromes. This patient has fever with renal failure, fever with jaundice, so in totality, fever with hepatorenal syndrome. What are the investigations at emergency? When we have undifferentiated fever, we mandatorily go for malaria, dengue test, CBC, and blood smear. Blood smear for malaria should be repeated 3 times in the first 72 hours, as sometimes the first report may come out to be negative. Other serological tests, this is a list of all the investigations that need to be done. Do not forget that some non-infectious causes can also suddenly come up first after travel. That may be a coincidence. We must not that way forget about them. Imaging, CSF analysis. As I was saying, we must not forget non-infectious causes. Quickly, I do not know how much time I have left. This is an algorithm, how you treat or manage a case of acute undifferentiated febrile illness, whether the person has traveled or not. How to assess the health needs in travelers before departure. So the case was a person who has come back from travel and has caused a lot of worries to the physician. But now let us discuss in brief what we should do before a person is traveling. So we have to assess the destination, personal details, date of trip, purpose of visit, and personal medical history, including pregnancy and comorbidities. Also about vaccination status. We have to advise the patient to use good quality insect repellents if they are going to some tropical areas to avoid insect bites, to wear proper clothing. We have to advise them about vaccines, specific vaccines depending on the destination, which varies from country to country, and also chemoprophylaxis if the patient is staying for a prolonged period in endemic areas. If your patient has already fever, we know that we have to treat the most likely diagnosis after stabilization. This is more or less in a nutshell what I want to say today, because time is over. There's another little case who also traveled to Madhya Pradesh, developed cervical lymphadenopathy, fever, and hepatosplenomegaly, and when a proper examination was done, revealed a little eschar on the abdomen. So we know that person was suffering from scrub. So what is the take-home message? There are challenges in diagnosis of illness after travel because of overlap of clinical presentation and cross-reactivity. Viral infections, there are no drugs for most of them. There is a lack of proper guidelines or algorithms for therapy, and also there is a problem with drug resistance. Therefore, prevention is the key. Specialized travel clinics need to be set up, and it is there in some of the foreign countries where information, counseling, and prophylaxis among common infections may be provided. Thank you.
Thank you, Nandini, for a very excellent deliberation on a difficult topic, as usual, ending in time. Thank you very much. I hand over the mic to the organizers for the next session, and thank all the co-chairs.
Thank you so much, ma'am and sir, for your valuable session. Sorry, session 8, Dean ICP's address by Dr. Kamlesh Tiwari will not be going to held since sir could not make it to the conference. Continuing the program forward, let's move on to the next segment, Dr. Sanat Kumar Mandal sir oration, which would be led by the people who are well known for their skills and professionalism. Dr. Uttam Kumar Paul sir, Professor and HOD of General Medicine at MGM Medical College, Dr. Tapan Mukhopadhyay sir, Professor and HOD, Department of Biochemistry, MGM Medical College, Dr. M.M. Heather sir, HOD and Professor, Department of Surgery, MGM Medical College. Let's welcome them on the stage.
Yes, now Dr. Sanat Kumar Mandal Memorial Oration. Dr. Sanat Kumar Mandal is my teacher. This oration will be given by Dr. Soumik Datto. He is professor and head of Bardwan Medical College, Department of Medicine. So, Professor Soumik Datto, please. His topic is thyroid perplexed, neurons puzzled. So he is MD and DM endocrinology.
Hello. Good evening, everyone. My respected Chairperson, Dr. Pal, and Dr. Mukherjee on chair, my respected teachers, and my dear colleagues on the floor, and I can see few boys and girls murmuring on the back rows. Actually, I have come here today as a pilgrim to pay my tribute to Dr. Sanat Kumar Mandal, who has spent several years in Bardhaman Medical College to save the medical education in the department as well as the institute. And so far I can understand his legacy is still alive across the state through his students like Dr. Pal and others who had been sanitized, I think, who had been sanitized by the treatment they have received from his teachers, Dr. Shonat Kumar Mondol. With his blessings on the house, I think we can have a look on the topic, the interface in between the gland and the nerves. As you know, the integrity of the axis, the thyroid axis, is very much important and essential for the development of the nervous system. And in case of congenital hypothyroidism, we are very much familiar with the cases. If they are undetected and if they are not adequately treated, they will certainly develop mental retardation. It may not be same with the hypothyroidism in adults, but the metabolic imaging had proved over the years that even in case of adult hypothyroidism, if it is not detected in time, if it is not adequately treated, the people can develop regional, particularly the cerebral hypoxia because of the reduction in the cerebral blood flow, as well as a reduction in the cerebral glucose metabolism. So let me start with a case. It's a story of 5-year-old girl. Actually, she was investigated because of long-standing constipation, and she was found to have primary hypothyroidism. As you see here, the parents took her to the family physician, and she was placed on LT4 replacement with an advice of 75 microgram per day at morning at empty stomach. Within a week, the baby, the girl, developed some degree of headache, photophobia. She was found to have ataxia. The parents took her to our OPD at endocrine OPD at IPGMR, and we found that she is having some degree of behavioral disorder. She was febrile. At OPD we found she is having papilledema. So on assumption of raised ICT in the background of LT4 initiation, she was admitted immediately. LT4 was stopped, mannitol was started, acetozolamide was added. However, imaging was non-conclusive. To exclude some CNS infection, lumbar puncture was done on guarded way, and the release pressure was on the higher side. However, after few days, she started improving, and after 2 weeks, the baby was discharged with advice for regular follow-up at our OPD. And on further follow-up on OPD basis, she was again initiated LT4 at very minimum dose. The dose was up-titrated and it was well tolerated. So the landscape of neurological manifestation in the background of thyroid disorder is very much wide. Definitely, the canvas is also very much different when we are shifting from hypothyroidism to hypothyroidism. And we are very much familiar with this type of presentation in the context of thyrotoxicosis. The patient, they are very much restless. They are not comfortable at any position, always shifting his places, very much difficult to get the history, as well as very much difficult to examine. So in case of kids, drops in the school performance is very much also common. We are very much familiar with the tremor, which is very much distal, postural, and this tremor definitely we also find in the tongue as well as in the lids. Deep tender reflexes, always very much brisk, and in few rare cases, I have got clonus. Look is always steering in the background of thyrotoxicosis because of overactive adrenergic drive. The levator muscles are in the contractile phase. Emotional lability. Before we are going to emotional lability, thyrotoxic periodic paralysis must be discussed. It is very much common in Asian young male, and they may come without other manifestation of thyrotoxicosis. It had been seen that 2% of thyrotoxicosis or Graves' disease may present with thyrotoxic periodic paralysis, and some genetic variation in the sodium potassium ATPase enzyme may play a significant role for this disorder. Emotional lability is not common, and rather we should say it is common, and the people are moving from door to door of psychiatrists to have the diagnosis of either MDP or paranoid and getting antipsychotic drug every day. After they are being diagnosed to have Graves' disease, it is being treated and they are improving. Here, the fatigability is very important point to differentiate from psychiatric disorder in the background of thyrotoxicosis from primary bipolar disorder. This is very much common in the elderly population, and because of this apathy and lethargy, they are mostly diagnosed to have dementia. Truly speaking, it is pseudo-dementia. Once the disease is diagnosed and the parameters are improving, they are very much responding. In the background of hypothyroidism, CTS we are very much familiar with. It is because of glycoprotein deposition in the carpal tunnel in and around the nerves. Apart from CTS, yes, definitely there is ataxia, though it is rare, and it is of cerebral type. And if we are very much religiously examining the patient, we can find intention tremor. Hung up reflex, it is because of the delayed contraction of the muscles definitely. Hearing loss may be sometimes due to collection of the fluid in the middle ear. Speech may be slurred, voice may be hoarse because of the same deposition in the concerned tissue like tongue and vocal cords. We should never forget about the association of myasthenia gravis and Graves' disease. We are very much familiar with this, and here, as we have seen that 3 to 4% of myasthenia gravis can present with Graves' disease. On the other hand, 1 to 2% of Graves' disease can present with myasthenia gravis. And it had also been observed that with improvement in the parameters of the Graves' disease, the myasthenia gravis parameters, the clinical parameters are improving, though it is very difficult to predict who will improve and who will not. In case of weakness or association in between myasthenia gravis and Graves' disease, it is a female preponderance mostly found. If the house is allowing me to go beyond the neuromuscular junction, I will say few words on muscles. Mostly the proximal muscles are involved, and very rarely distal muscles, even the trunk and facial muscles may be involved. But to be noted, the weakness is very much disproportionate to overall loss of the weight or overall wasting. And as soon as the parameters, biochemical parameters are improving, as soon as the BMR is coming down, the muscle strength is coming back, and it occurs much earlier than the improvement of the muscle mass. So, let's fly into another horizon. This study was done years back by my student, Dr. Saurabh Bhakto at Calcutta National Medical College under my guidance. And the purpose was to check the influence of the thyroid axis on protection sense in the background of type 2 diabetes mellitus. And we had excluded all these type 1 diabetes, uncontrolled or poorly controlled type 2 diabetes, HIV, gross hypothyroidism, CKD, malignancy, history of heavy metal exposure. As you see here, mean HbA1c was 7.03, and almost 60% of patients had their HbA1c level at the level of less than 7. You can see here the creatine level is also around 0.9 plus minus 0.21. What we got there, the mean TSH was 3.11 plus minus 1.8, and TSH showed a significant association with vibration perception threshold more than 25. Those persons having higher TSH level are at 2 times more risk of having VPT more than 25. We also observed that TSH more than 3, they are at more risk of having abnormal VPT, absent ankle jerk, absent vibration test, absent pinprick test, and absent 10 GMFT. So finally, it came to be that these people having TSH more than 3 are at 15 times more risk of having loss of protection sense compared to those with TSH less than 3. So to summarize it, patient having LOPS shows higher TSH level even it is within normal range, and it had significant correlation. Finally, this study found its place in JIMA in 2021 with the question whether we should screen the thyroid function test in every type 2 diabetes patients and initiate LT4 replacement, at least in subclinical hypothyroid cases, to protect protection sense. Definitely, to get this answer, we need a multi-center study, including several ethnic groups. And till that, I'm going to concluding here with that unanswered question, again remembering Dr. Shanath Kumar Mondol, the waves he had generated is still vibrating across the state. Thank you.
It was a vast delivery of a vast field, which gets me thinking that if one system of our body is affected, we also need to think about other systems. And to actually guide the patients in the general OPD, it was a practice a few years back to refer them to specific clinics. People coming with general complications or complaints had been referred by junior doctors. Oh, okay, you have fever, you go to fever clinic. You have high cholesterol, you go to the general medicine. You have hearing disabilities, you go to the ENT clinic. Like that, it is not so simple. It seems like that. So every organ is linked with the other organ. As you have just said, that thyroid should be evaluated in type 2 DM, as also thyroid should also be evaluated in kidney patients. So
Right,
they are often unmasked, and they will be masked only after screening. So these things are very common in clinical practice and academic practices also. The students need to know this because they do not have experience. So they have to follow their teacher's advice blindly, and then they can be able to be safe in their clinical decision making. So I am from biochemistry department. I worked in Bardhaman Medical College also for 3 years. I am a resident of Bardhaman itself. And I am very fond of the place, Bardhaman. Whenever I heard you are there, so I need to thank you because you have come so long a distance to give your expertise and share it with people. So thank you from my behalf.
Thank you, sir.
Thank you, sir. I am requesting Dr. Shekhar Chakraborty, scientific convener of ICP-CON 25, to present the speaker, orator, with a medal of Sanat Mondol Memorial Oration.
Thank you.
Yes.
Hello, hello.
Yes. Hand over the mic to next. What program?
Thank you so much, sir. We extend our sincere appreciation to our distinguished speaker for the memorial oration and our honorable chairpersons for their guidance and conducting this session with such academic finesse. Now, with the same enthusiasm, we would like to continue to move to our next session, which is sponsorship program by ABOT, which will be conducted in 2 parts.
So I would like to welcome Dr. Shiv Kumar Sir, HOD Chest and TB Department, MGM Medical College.
Dr. Barun Bhattacharya, sir, HOD and Professor, Department of ENT, MGM Medical College.
Dr. Paromitra Patra ma'am, Associate Professor of ENT Department, MGM Medical College, to kindly come on the stage and chair this session. I would like to call Dr. Atut Bail Sir, Professor General Medicine, MGM Medical College.
Good evening, everybody. So may I now request Dr. Shekhar Chakravarti, who will be speaking on influenza shots.
Good evening, respected chairpersons, my dear colleagues. So though the topic is basically influenza shot, I would quickly cover the adult immunization because this was the initial topic, which is a sponsored talk from Abbott. Now, I'll restrict myself within 10 minutes to discuss about the burden of the vaccine of the preventable disease, the economic burden of the vaccine recommended in adults as well as high-risk group and the barrier. Now, you know that the burden is immense because of many reasons. the most important reasons is the suboptimal vaccination coverage. At the end of the day, we should know that it's not coming. Okay. Okay. So we have got many infectious disease talk, but to navigate through the ocean of the infection, we need vaccination. So first of all, despite the advancement of the treatment of the different infectious disease, suboptimal vaccination coverage is there, and in a suboptimal coverage is there, and inadequate health policies are the most important part. Why the infectious disease, the patient needs vaccination? Because the age-related decline in the immune response. The universal program primarily focuses on children. There is no program for the adults. 25% of the adult mortality are directly attributed to the disease process. Burden of the vaccine preventable disease, it has been observed that it is projected that to 2050, number of the adults more than 65 will be more than almost double of the younger population. And the adults are directly affected by the outbreaks of the vaccine preventable disease. Unvaccinated persons are risky because they are unknowingly spreading the disease to the community, directly or indirectly through the family members. There is an immense economic burden because of the health costs, lost productivity, and decrease in the quality of life. So therefore, those diseases are preventable that should be vaccinated. And also there is a vaccine preventable disease cost also incurred in the Indian community, that the influenza vaccination significantly lowers the risk of the hospitalization related to influenza. Nearly 50% of the vulnerable populations, including adults. So what are the vaccines recommended? This is the host list of vaccines. I think it is available in the net. Everywhere you can get it. I'll inform the specific important issues. The most important issues is the influenza vaccine, which is now available as a quadrivalent vaccine. Quadrivalent vaccine means this is actually inactivated vaccine having two type, in type A and type B influenza virus of the two strains. 4 strains are included in this. Trivalent vaccine is available but not very much in use. Latest strains are recommended for the adults for the risk of more than 65 years, particularly the workers, pregnant women, and 65 years, less than 65 years with the specific disease. Most important thing I would highlight to mention that in the winter season in the North India, the usual months where it has to be vaccinated is the November, December. And in South India, it is in the rainy season in the June and July. So these are the certain groups of people, particularly elderly, the chronic medical conditions, the obese persons, healthcare workers, those who have got a poor immune system, nursing homes and long-term facilities, pregnant women and children, they are to be vaccinated very precisely. Now the vaccines, initially in 1945, it was the whole virus. Subsequently in 1964, it is the split virus vaccine has been generated. Then third generation is the subunit vaccine. Here is only the HA and NA, neuraminidase, and these are the components which are actually used for vaccination. So subunit vaccines presents the better tolerability and reactogenicity compared to the other vaccine types. Now subunit vaccinations has been shown compared to other vaccines that it has got a low muscle pain, it has got a low swelling at the site, and the muscle pain and swelling both are reduced in case of subunit vaccines. So subunit vaccines is now the choice of, and fever reactions are also the less frequent of the subunit vaccines. What are the important issue for the safety in the pregnancy? Mind that in pregnancy, the influenza vaccine is absolutely safe. In all trimesters of pregnancy, it has not involving the outcome of the mother and the child. Influenza vaccine recommendations, mostly recommended is those who have got more than 65 years and those has got age less than 65 years having the comorbidities. Other vaccines, I am not going to detail because tomorrow we have got a program. Dr. Reena Ghosh will discuss about this in the panel discussion, the varicella zoster vaccine, the double and triple antigen vaccine, hepatitis A vaccine, hepatitis B vaccine, HPV, HIV vaccine and meningococcal vaccines. Pneumococcal vaccine also to be mentioned here because usually what is being recommended that PCV13 is to be given first, followed by PPSV after 1 year. MMR vaccines and herpes zoster vaccines are on board. Particularly, I would like to mention in the high-risk population, these are the studies have been published in JAPI. So, this is the guideline of the adult immunization from the JAPI, where influenza, pneumococcal vaccine, Tdap vaccine and hepatitis B vaccines. Okay. So, this is an elderly, and in diabetes, these other vaccinations is also there. I am not highlighting because there is a, following this lecture, there is a discussion on adult immunization. In cardiovascular disease, in ESRD, as well as in the COVID, these all vaccines are recommended also in the HIV patients. So, what is the barrier? Barrier is the adult vaccination is not prioritized particularly by the public policymakers and public health initiatives. The misconceptions about the vaccines is that safety and efficacy is a questionable both healthcare providers and in the public. They feel that vaccinating may cause problem. And a survey indicated that around 62% of the adults cited back on the awareness of the major reason for not getting vaccinated. So, it has been observed that the large population in our country are not vaccinated who are running the risk of developing this disease, because it has been observed that if they are vaccinated properly, then it actually reduces the 60% of the hospitalization and 80% of the reductions of the death. So, 1.5% of the adults received influenza vaccine and pneumococcal vaccine is 0.6%, typhoid is 1.9% and hepatitis B is 1.9%. So, low uptake can be attributed to the several factors. Number one is lack of awareness. There is absence of national guidelines, insufficient recommendations for the healthcare providers, and healthcare providers exhibit a significant influence on vaccination rates through their recommendations, which underscores the need for improving training focused on adult vaccination. So, thank you very much for your patient hearing.
Thank you very much, sir, for the elaborate presentation. There is one question that I would like to ask. So, since not about the influenza shots, but about the COVID vaccination, because that is also a part of adult vaccination. Is there any, because there is a whole bunch of anti-vaxxers on social media, we are all aware of. Is there any association between COVID vaccination and sudden cardiac death? SCD, sudden cardiac death.
Sudden cardiac death.
Yeah.
So, I have got no data regarding that the COVID vaccination with a sudden cardiac death. Because the COVID vaccinations, you see, when it has been used, there is different groups of people has been vaccinated, comorbid people and the, so there are some cases reported that after vaccination there is death, but those cases are by definition are not the sudden cardiac death.
So no studies?
No studies for that.
Thank you.
Thank you for your good elaborations. And one thing is more than, I am including that, you have delivered all these things, the comorbidities factors and all these things would have to be given. But in the case of the post-tuberculosis bronchiectasis and bronchial asthma and the post-OAD, tuberculosis OAD should have to be also given, the vaccination should have to be given.
Yes.
Yes.
Also.
Yeah.
So
Yeah.
any structural lung disease.
Yeah. Any structural lung.
Should be given.
Yes. Certainly should have to be given.
Yes. Certainly.
Yeah. Thank you.
So that is the awareness which is lacking in our country and everywhere, na? Because
everywhere this is lacking. So many illiteration is the more common cause of there, and poverty. Two things is more. Thank you.
Thank you very much.
I think we can conclude, sir. This one. Dr. Harsimar, please come back on the stage. I think we can conclude this session because we have running short of time. I think, all right. Thank you.
हेलो
पेनड्राइव में दिया था जो पेनड्राइव में 2-3 है ना पेनड्राइव तो सर के पास ही है सर हम वो ऑप्शन देखते हैं सर ये तो था ये गौरव है ये नहीं है कि स्पेशल स्पेशल में जीआरडी का इसमें 3-4 है इसी में है सर
Thank you so much, sir, for such a valuable session.
Now we will move forward to the second part of the session, for which we would like to invite Dr. Jyotimar Paul sir, Professor in HOD Department of General Medicine, College of Medicine and Sagar Datta Hospital.
Dr. Shekhar Chakrabarti, sir, Consultant Physician and Diabetologist, Director of KINS Hospital, Siliguri.
Dr. P.S. Karmakar sir, Professor, Department of General Medicine, MGM Medical College, to kindly come on the stage and chair the session.
Good evening, everybody. Now, this is a sponsored session by Abbott India. So, one case-based diagnosis, that is atypical chest pain. So, I would like to invite Dr. Gaurav Chauhan, second year PGT of MGM Medical College, Kolkata. Please start, Dr. Gaurav. Floor is yours.
Good evening, everyone, to the esteemed faculty, seniors, juniors, and co-PGTs. Today, we are going to discuss a case-based discussion on chest pain. This is a case of 45-year-old male who presented to our medicine OPD with primary complaint of chest discomfort for past 2 years, which has markedly worsened over last 10 days. After visiting several doctors and undergoing numerous inconclusive tests, even CAG, this patient presented to our OPD with chief complaint of intermittent episode of burning sensation for almost last 2 years, causing chest discomfort, describing as a heat rising up from the upper abdomen towards the chest. After discussing the case with our unit head, Professor Karmakar sir, we went for detailed history in which patient tell these episodes would typically occur within 30 to 60 minutes after meal, especially after consuming samosa, that is oily food. The intensity used to be mild to moderate and would subside with over-the-counter antacids. However, 10 days prior to presentation, he consumed a large quantity of alcohol, binge drinking episode during a social gathering. Following this, he noticed a significant exacerbation in the burning sensation, both in frequency and severity. Since then, he has been experiencing daily symptoms occasionally, even at rest, and has been difficulty tolerating fatty foods. He gave a history of dysphagia, regurgitation of food bolus, and water brush. There is no history of chronic NSAID use, no history of corrosive ingestion, and no similar symptoms in the family. The patient had no known comorbidities. He is not on any chronic medications. Regarding personal habits, he consumed a mixed diet and admit that symptoms are significantly worsened after heavy oily meat. He is not a routine alcoholic consumer, but had a single binge episode 10 days back, temporarily related to symptoms worsening. He denies smoking cigarette. His sleeping is normal. On journal examination, the patient was comfortable at rest, well-oriented and cooperative, with weight 60 kg with BMI of around 21 kg. His vital was stable. The most notable journal finding was the discolored dentation consistent with chronic acid exposure and poor hygiene. Systemic examination was within normal limits. Baseline investigation include CBC, LFT, RFT, fasting, lipid profile were within normal limits. ECG show no ischemic changes. Chest X-ray was unremarkable. Given the chronic nature of symptoms with recent exacerbation and in accordance with an upper GI endoscopy was performed, which revealed acute erosive esophagitis. There was erythematous mucosal patches, superficial erosion, and friable in the distal esophagus, consistent with LA grade A-B erosive esophagitis. There is no strictures, no ulceration, no varices, and no Barrett mucosa appreciated during this examination. It is likely secondary to long-standing GERD with acute exacerbation triggered by binge alcohol consumption and high food dietary load, where fatty food and alcohol both markedly reduce lower esophageal sphincter tone, increase transient LES relaxation, and impaired mucosal defense, predisposing to erosive disease. For the management, the patient has been counseled extensively on lifestyle modification, including complete alcohol cessation, avoid oily and spicy food, early dinner, and head and elevation during sleep. Pharmacologically, we have initiated a proton pump inhibitor, pantoprazole, once daily before breakfast with a planned course of 8 weeks as a recommendation for healing of erosive esophagitis. He has also been advised dental evaluation due to enamel erosion and concern. The patient has been asked to follow up after 8 weeks or earlier if he develops alarm features such as progressive dysphagia, weight loss, emesis, persistent symptoms. Repeat endoscopy will be considered if symptoms fail to resolve or if Barrett esophagus is suspected. Thus, this is a case of long-standing GERD presenting as acute erosive esophagitis precipitated by binge alcohol intake with classical clinical history, normal baseline investigation, and confirmatory endoscopic findings. Thank you.
Thank you, Gaurav, for your nice and crisp presentation. Now, please tell me, what are the risk factors this patient is having?
For risk factors
for GERD.
Risk factors.
Your diagnosis is GERD
yes,
for this
sir.
patient.
Sir, H. pylori infection, genetic factors, smoking factor, NSA, its use, alcohol, and coffee, more coffee intake. This obesity and all. These
Any stress in life?
Yes. Sir.
Mental and stress
also. Yes.
So, is the patient is having H. pylori test has been done for this patient?
No, not.
Is it indicated?
Yes, definitely. So to identify the underlying cause, maybe H. pylori, maybe one of the.
If the patient is not responding to pantoprazole for say 8 weeks,
Then-
continued, do you think that this patient needs a prokinetic drug?
Yeah, definitely, sir. And other further evaluation for underlying cause.
What will do? Will you escalate the dose, or will prolong the dose, or will stop it and go to surgery, whatever be?
So initially for the GERD management, lifestyle, first we go for lifestyle, then pharmacological, at last we go for surgical funding.
Yes, Gaurav. Thank you for good presentation. The only one thing I like to make a comment over here. Just a few days back, 4 or 5 days back, one patient was referred by Chandni ma'am, who is sitting over there. So some PGT, that is probably she is also sitting over there, took a patient that was a lady patient. No, you took the patient with that, the upper abdominal pain and mid chest pain. Okay. So this thing, upper abdominal pain and mid chest pain, something does happen in cardiac problem also. And in your case, it was really little bit, there was dilemma because patient was 45 years of age, smokers, and he was little bit obese, something like that. In that case, if we don't maintain our diet properly, definitely there could be a likely possibility of GERD, that is gastroesophageal reflux disorder, giving rise to chest pain, and that may mimic like that of coronary angiography. That's why in that patient, as the patient little bit gave the history of having chest pain on climbing stairs, so probably the clinician outside, because we saw this patient just 7 days back outside, was thinking of some coronary artery disease. That's why that patient, your patient, was subjected to coronary angiography, TMT, to evaluate all sorts of, whether there is any possibility of coronary artery disease or not. And patient was probably put on anti-ischemic drug, no?
Yes.
Yeah. Patient was taking anti-ischemic drug. So patient is taking aspirin, which will aggravate GERD. So we have to bank upon to our junior budding gynecologists or physicians or surgeons that we have to remember this thing, that clinical history sometimes is a very, very important thing to cleanse the diagnosis, not the investigation. And that day also when patient came, I told that young lady that probably we are dealing with a case of that patient was gastritis. Okay. So within 2 days, he underwent upper GI endoscopy, and that was proved to be gastritis. So that way, if we young generations are really going away from the clinical history, I would definitely give one suggestion only: first bank upon history, and through history you try to go to the diagnosis, make some DDs after history, then go for the DD history guided investigations. So your acumen, clinical acumen will increase if you be guided by history. Okay, thank you, Gaurav.
Thank you.
Thank you so much, sir and ma'am, for your valuable session. Respected dignitaries and honored guests, as we now prepare to embark on a conversation of profound importance, adult immunization, a pillar of preventative health and shield of healthier tomorrow, with great respect, I request Dr. Animesh Dev, sir, Professor, Department of General Medicine, MGM Medical College. Dr. Arnab Bhattacharya, sir, Consultant Physician, Barasat Medical College. Dr. Shiv Kumar, sir, Professor of Department of Chest TB, MGM Medical College. Dr. Chandni Sehgal, ma'am, Associate Professor, Department of Gynecology, MGM Medical College. Dr. Debashish Bhattacharya, sir, Consultant Gynecologist, Raiganj Hospital. Dr. Alappan Bandyopadhyay, sir, Assistant Professor, Department of Community Medicine, MGM Medical College. And Dr. Srinjini Ghosh, ma'am, Associate Professor, Department of Community Medicine, WPMES, Kolkata. Let's welcome all of them on stage.
I would like to welcome Dr. Reena Ghosh, ma'am. She's a clinical tutor and at the Institute of Child Health, Kolkata. Where is she? Oh, she's there.
Hello.
Good evening, everybody. So we have come to the fag end of today's program, and everybody is very tired also. So I will be very brief, and I am really thankful to the organizer to give me this opportunity to present this as myself as a moderator on a very important subject on adult immunization, this subject actually is till now, especially in our country, is underestimated one. So, and I will be very, I have prepared lot of questions, but I don't think that I will be able to go through all the questions. Once more, I want to be acquainted with the panelists, please. Please.
Good evening. I am Dr. Alappan Bandyopadhyay. I am an assistant professor in the Department of Community Medicine of MGM Medical College, Kishanganj.
I am Dr. Debashish Bhattacharya, consultant gynecologist at Raniganj.
I am Dr. Shiv Kumar, professor and HOD in the chest department.
Myself, Dr. Shinjini Ghosh, Assistant Professor, Rampurhat Government Medical College, Department of Community Medicine.
I am Dr. Arnab Bhattacharya, Senior Consultant, Barasat Government Medical College and Hospital.
Good evening, everyone. I am Dr. Chandni Sehgal. I am an Associate Professor in the Department of Obstetrics and Gynecology in MGM Medical College, Kishanganj.
Thank you, panelists. So let us directly go to the program. I will go to Dr. Arnab Bhattacharya. It is being underestimated, that adult immunization. What are the most, we have just learned about why this is underutilized actually. So what are the most common misconceptions and concerns regarding adult vaccination among Indian population?
There are misconceptions and there are obstacles because of the fact that there is a common notion in adult population that if we can keep a good health, good physique, then we can avoid disease. Yes, it's partially true, but not always. Because we'll have to remember also the waning immunity of the geriatric population, which has been very much underestimated compared to the immature, the campaign regarding the immature immunity of the infants or neonates. It has well on, but the campaign regarding the immunosenescence, it's very much difficult to understand for common people what is immunosenescence, what is waning immunity of the geriatric population. And so they have got a notion that only adult people, when they want to go abroad or anywhere where which is more disease prone something, so they need vaccination. So these are the misconceptions. But of late, I should say that the COVID vaccination campaign has given some amount of momentum to the campaign for the adult immunization. So that much I can say.
Actually, there is some data which was, there is a survey conducted among 2002 adults across 6 cities. So outcome is that 42% of the adults, they believe that good physical health only obtained from eating healthy and keeping active and not smoking, and primarily priority in lifestyle. Around 34% believe vaccination required only for travel purposes. 38% believe vaccinations are only for children and for babies. And 26% believe vaccinations are not required if one is fit and healthy. So these are some of the common misconceptions which has been evidence-based in our country. So I will skip that. So now I will come to Dr. Sheep, please. Which vaccines are most commonly recommended for adults in India? What are the vaccines which are recommended in adults over the age of 19 years? Commonly, routinely recommended, and what are the vaccines which are recommended in high-risk groups?
Yeah, recommended things is the tetanus and diphtheria should have to be given. Again, the influenza vaccination is given. Pneumococcal vaccination should have to be given. Even the HPV vaccine should have to be given. And the coming era, the hepatitis B and hepatitis A, the meningococcals, and all in the pipelines would have to be given, all these things, adults.
So routinely we should go for the tetanus containing vaccines,
Yeah.
MMR, influenza, pneumococcal, HPV, and herpes zoster vaccines. These are routinely to be administered to adults. So now I will go to Dr. Shinjini Ghosh. A 20-weeker primary reached immunization clinic whose husband is HBsAg positive for hepatitis B. Your suggestion regarding hepatitis B vaccination for pregnant lady, for her husband, and for her newly born baby who is going to be born. What will be your suggestion?
For this, I would say that first we have to see the status of hepatitis B for the pregnant lady. And if she is negative, then we have to continue for the hepatitis B vaccination. And for her husband, there is no need of any vaccination as he is already hepatitis B positive because the antigen is positive. And for newborn baby, as early as possible, both the vaccine as well as the immunoglobulin to be given, which is 0.06 international unit per kg body weight for the infants.
So why immunoglobulin has to be given to the newborn?
Because
we give always the birth dose of hepatitis B to the newborn. But in this case, as you suggested that there is a history of HBs positive status in husband, so why should we go for the immunoglobulin in this case? What is the justification? If mother is negative, there is no need to give the immunoglobulin. In case mother is positive. Only in those cases we have to give the immunoglobulin. Okay, thank you so much. Now again I will go to Dr. Chandni, please. A third-year nursing student received 2 doses of hepatitis B 2 years back. No, this is for the Shinjini again. Third-year nursing student received 2 doses of hepatitis B 2 years back. Now she has stepped into immunization clinic for pending 3rd dose. Does she need to restart vaccine schedule? And all the 3 doses will have to be given now. Your suggestion?
I think she will take all the 3 doses, but there is no need of restarting the vaccination again. Because
what I will do, she has already taken the 2 doses earlier. Now what I will
3rd dose she will take.
Only she needs the 3rd vaccination. Yeah. So there is no need to restart the schedule as because she has come late. Yeah. Because as soon as we will administer the 3rd dose, there will be immunological, the antibody titer will reach the adequate level. So it will protect, because already as she has taken the 2 doses, already there is a T-cell memory is there. Yeah. There is a bone marrow memory is there.
Exactly.
So as soon as we give the 3rd dose, there will be adequate immunogenicity. So it will take up the protection level. So there is no need for repeat the whole lots of the schedule. Yes. No, actually, it is so. That is why we have kept a schedule for adults 0, 1, and 6. Because if there is a gap between 1 and 2nd and 3rd dose, at least more than it should be 8 weeks. I will show you what should be the minimum gap between the 1st and 2nd dose, 2nd and 3rd dose, and 1st to 3rd dose. I will show you that. So that is the minimum gap is allowed, and there is no limit for the maximum gap. Yes, that can be given there. There is no need to reschedule the doses. Dr. Bhattacharya, Dr. Arnab Bhattacharya, would you brief about the dosage schedule for hepatitis B for adults?
0.5 ml at 0, 1, and 6 months the usual dose. But for immunocompromised persons and for the persons who are on chemotherapy or dialysis, the doses should be doubled.
Please repeat. What should be the doses actually? The amount of the...
0.5 ml.
No, it is 1 ml. For adults, it is 1 ml above the age of 18 years.
Sorry, 1 ml for 0, 1, and 6.
Is for the
immunocompromised persons, it should be doubled.
Yes. And in case of those who are on dialysis, that is very important. Those who are on dialysis, like the thalassemia patient, you should always give the double dose. That is 1 ml and 1 ml. 2 ml should be given, as you are mentioning. For dose is 1 ml in adults over 10 years, or in some brands it is 18 years. 3 doses, day 0, then 1 month and 6 months. Minimum interval between the 2nd and 3rd dose should be 8 weeks. Minimum interval between 1st and 3rd dose should be 16 weeks. and high risk group on dialysis, frequent blood transfusion, they should get the double doses, as you mentioned. Now, with this, now we'll move on some questions on anti-rabies vaccine to Dr. Alapan Bandopadhyay. Mishti, 3-year-old girl child, was brought to rabies clinic with history of bite on right hand 3 days back by unvaccinated pet dog. The pet dog is only 2 months old. Mother gave history of only little blood oozing out from area. Immediate washing of the area was not undertaken because the child was crying a lot. So your suggestion regarding post-exposure prophylaxis to the child and tetanus vaccine, she has already taken the primary vaccination, 3 doses, and booster at 1.5 years. Whether we'll observe the dog for 10 days. Dr. Bandopadhyay, please.
So, if we look at the history of the case, it's evident that it's a category 3 bite. The recommended PEP for category 3 bites is start the anti-rabies vaccine and give immunoglobulin at 20 IU per kg body weight. The dosage schedule as per we follow right now, the standard dosage is ID regimen, the intradermal regimen, 0, 3, 14, 21 or 28. And as for the tetanus vaccine, this is a pretty tricky one because the child, she is a 3-year-old child, so she should have received her tetanus doses with pentavalents and boosters. But if her mother cannot provide any history of tetanus vaccine, then she should be administered a tetanus vaccine as well as the routine tetanus vaccine that she is scheduled to get.
No, she is already vaccinated and the documentation has been provided.
In that case, there is no need for a tetanus vaccination in this particular case.
Yes.
Interestingly, as for whether we will observe the dog for 10 days or not, this is a very common question that has been asked to us. You can observe the dog for 10 days, but it does not lead to the decision making. It is just for information whether the dog is infected by rabies or not. So it should not have any influence on your decision. There is a dog bite, there is a category 3 bite, start the ARV. Observe the dog to see whether it is showing symptoms. If it is not showing symptoms, then it's fine and all. But the child should receive the vaccine. That is what the suggestion is.
So the main thing is that whether a pet dog, very small puppy, so many parents, they said, oh, very small, only 2 months old, only last month I bought it, so it is so small, so there should not be any question of anti-rabies vaccine. They are very reluctant to give these full post-exposure prophylaxis to the child. This is, we face the real problem, and sometimes they are not actually brought to the clinic.
Exactly. So we should always, there doesn't matter the age, doesn't matter the status, animal bite, unvaccinated, give ARV. Thumb rule.
Thank you, Dr. Bandopadhyay. We usually follow that after 3 months we should repeat the post-exposure prophylaxis. What do you follow in your clinic?
The rule is also said, if there is within 3 months, no need for any ARV again. But if it is post 3 months, there is a gap of 3 months or more than that, restart the dose.
Yes.
Better be safe than sorry.
Yes, yes.
Rabies is
we'll
100% mortality.
We'll not go for 6 months. So it is 3 months. It is 3 months. We should go for another course for ARV. So 100% fatal disease, we should not take any risk. Okay. So another. Yes, now sometimes it happens, pet dog in the house getting regularly bitten. Very common scenario.
Only one of the very few vaccines where over-vaccination is not a problem.
Yes.
Give vaccination, but stay alive. That is the rule.
And another question for you, Dr. Bandyopadhyay. A farmer, 35-year-old, while working in field, got bitten by a big rat on his left leg. There was profuse bleeding from the side. Your suggestion regarding the management of the case?
Again, this is a mammalian bite. Mammalian bite, the rule is any mammal can transmit rabies. So start with the rabies prophylaxis. Tetanus, always. And in this particular case, because it is a rat, rats are known harbors of any and every types of disease known to us. So we should also start him on an antibiotic course. As per as the local rule, generally a full course of amoxiclav will do fine. But the primary thing that we should be keeping in mind that this is an animal bite, this is a category 3 bite, there is a profuse bleeding. Wash the wound for 15 minutes at least. Do not suture it unless it is exceptionally necessary. And start on an ARV dose as well as anti-rabies immunoglobulin as per the body weight, so that there is no question of any query of any vaccine.
You should note that, yes. Yes. Na metro যেগুলোকে না actually then I am not meaning the Nengti idur which are actually found in the house. So in the Nengti idur bite we do not give the anti-rabies prophylaxis, but as because it is a big rat and in the outside it is farmer, it is in the outside, so we will give this. And we will not, here the main thing we should note that even if there is a profuse bleeding, we should not give any switcher. That is the main, I want to highlight this. That is, was bitten. Yes. Now actually I got a similar case, not only one case. 2 years back, actually few people from a remote village visited me that the cow was bitten by a rabid dog, and the whole of the villager, they have consumed the milk from that particular cow. So what to do? So actually they are consuming the milk. It is going to the GI tract. So it is, and we know that it is a neurotoxic virus, rabies. So if we consume milk and if it has the rabies virus, it will be destroyed. So there is no harm taking the milk, and that is why I said that you do not have to worry, and after follow-up, all are keeping well. This is a practical experience from my side. Now, actually, in the rabies guideline, it is being recommended like that. Yes. Yes. If the cow milk is consumed and the cow was bitten by rabid dog, there is no need to give the full course of ARV. But we should always take the opportunity to start the pre-exposure prophylaxis. I always take the opportunity to take the pre-exposure if there is 1 or 2 person coming. But for the entire village, I cannot go there. So I have said that you need not do at this moment nothing to do that. And what is your opinion?
The same.
Okay. So now I will come to Dr. Chandni. A 27-year-old lady, weaker primary, she received vaccination till 5 years from government health facility. How will you plan immunization? What are the vaccines we strongly discourage during pregnancy? Is there any new vaccines in the pipeline for the maternal immunization?
Okay. She's a 27-year-old, 12-week pregnant, and she's a primary patient, and presumably she's taken 5 years of, still 5 years she's taken vaccination from the government health facility. So we assume that she's taken all the necessary childhood vaccines. And in pregnancy, we strongly discourage, and it's contraindicated to give any live vaccines. So the vaccines which we give during pregnancy is tetanus, TT, or Tdap. In our practice, if the patient is not affordable, we give 2 doses of tetanus. It's advisable to start the first dose at when the pregnancy is detected, and 4 weeks later the second dose. And if the patient is affordable, we skip giving TT. We give Tdap, that has to be given between 27 to 36 weeks. And in our practice, we give it at around 28 weeks, and after 4 weeks, we give 1 dose of TT to the pregnant patient. And next vaccine that we give during pregnancy is the influenza vaccine, but we need to make sure that's the killed or inactivated seasonal influenza vaccine, because live vaccines are contraindicated in pregnancy, and it can be given any time during pregnancy. And in our practice, we give it at around 24 weeks of pregnancy. And other vaccines like MMR, varicella, it's contraindicated because they are live vaccines. And if we need to give rubella vaccine to any female patient, it's ideally to be given either 1 month before she's planning to try to conceive, or postpone it after delivery. Same goes for the varicella as well. And is there any new vaccines? I would say there's this one new vaccine that the US regulatory authority has launched for RSV, that is a respiratory syncytial virus vaccine. It's called, I think, Abrysvo, and it has to be given between 32 to 36 weeks of pregnancy to prevent RSV infection in the newborns until 6 months. And it's not available in India as of now, but it will be if it's available, it will be another one, added newborn protection for the baby. And yeah, it's not available. So the vaccine name is Abrysvo. It is a vaccine against RSV, respiratory syncytial virus, and it's only available in the US at the moment, to be given between 32 to 36 weeks.
For pregnant lady, it is not available in India, but for newborn, for infant, it is now available. RSV vaccine
not for the pregnant lady, as
not
for us.
For the pregnant lady, it is not yet come out in Indian market, but for this infant, the vaccine has already come into the private market. Very, very costly. And that is true. Now I will come to Dr. Debashish Bhattacharya. What is HPV? Is there any antiviral drug for HPV infection?
HPV is human papilloma virus. There is no antiviral drug for it as such at present, but there is a 100% protection for it by vaccination. The HPV vaccination, the pentavalent, the bivalent vaccinations can be very well used. No antiviral drug for therapeutic purpose as such for it.
So at present there is no antiviral drug, but there is a good vaccine which can prevent this human papilloma virus infection. Thank you so much. One more thing. HPV vaccine, does it prevent only cervical cancer?
No, HPV vaccine has a wide gamut of benefits, starting from the male to the females. Since cervical cancer is the most common cause, common cancer among the females, this is mostly talked after, but otherwise it is also protective for the anal cancer, the perineal type of warts, the vulval warts, the oral cancers, the head neck cancers, and penile cancer in males.
So actually, many people, they think that HPV vaccine goes like that, the cervical cancer preventing vaccine. So it is not only prevent cervical cancer, actually there are many cancers. Just now we have heard from Dr. Debashish Bhattacharya, anal cancer, vulvar, cancer, penile cancer, oropharyngeal cancer, head neck cancers. So many cancers. So huge number of cancers are being protected from this HPV vaccine. So as it prevents penile cancer, so it can be administered in females as well as in males. So we know that only the cervical cancer vaccine, it is given to the females. Now it is known that males can also be vaccinated against this HPV vaccine. Now I will go to again to Dr. Chandni Sehgal. Why adolescents to be vaccinated? If we start late in adulthood, do we expect the same benefit?
Adolescents are a good option to vaccinate the HPV with HPV vaccine, because lesser the exposure, before the exposure, the efficacy is more. So strongest immunity is will be given if the adolescents are vaccinated before they are exposed to any kind of HPV infections. So, and mostly 2 doses for the 9 to 14, less than 15 years, 2 doses needs to be given, 0 and at 6 months, and between 15 to 26 years, 3 doses, 0, 1 to 2 and 6 months, and between 26 to 45 years, it's a shared decision. But yes, efficacy will be reduced because it doesn't prevent you from past infections, but only prevents the future infections, right? So if we start in late adulthood, the efficacy will surely be reduced if the patient has already been exposed to the HPV virus. But yes, ideally every female from 9 to 45 years should ideally be vaccinated against HPV, and males between 9 to 26 years.
Thank you. Now I will come to pneumococcal vaccine, which is a very important vaccine for adults, especially for the elderly adults. So actually pneumococcal vaccine, Dr. Shiv, please. Pneumococcal vaccine recommended in elderly adults. What are other new PCV which will come into market soon?
So recently the HB pneumococcal virus is coming. Recently has launched 2 months back, the HPV-20.
Yes.
And again the pipelines will be there, the 121 and 23 is coming in the pipelines.
So in our country, we have already having PCV-20.
Yeah.
That is the pneumococcal conjugate 20 valent has already come into the market. And PCV-15, PCV-21 and PCV-24 are available in US market, not yet come to Indian market. So these are the new vaccine which are already having in our market. Thank you, sir. And I will again request you, what is the current recommendation for PCV-20 in adults?
The one single dose would have to be enough.
Actually, Shindini, I will go to you. If you can elaborate that according to the which age group and the status of the vaccination, how will you give the PCV-20?
So for that,
we can categorize like that those who are above 50 years, those who are above 65 years, or those who have taken only one shot,
PPSV,
or PCV-13 or PPSV-23, or those who have taken both. So you can categorize in this way and you can say it.
Okay, so if the adult is of age more than 50 years and is unvaccinated, then we can give 1 dose of PCV-20. But if he or she has already taken 1 dose of PCV-13 or PPSV-23, then we have to wait for 1 year, and then after that we can give PCV-20. But if it is more than 65 years of age, then and already 1 PCV-13 or PPSV-23 is taken, then we have to wait for 5 years, and then after that PCV-20 is to be given according to the recent guideline.
Yes, this is the recent guideline, current guideline. We follow the US guideline only. So CDC has given this guideline. So it has already come into the market. And that is the greatest advantage, that if a child, if an adult over 50 years come to you, there is no need to give PPSV 23 anymore. You just give one shot of PCV 20, that's all. That's all he or she requires throughout his life. So this is going to do a great benefit for the elderly population who visit less and less to the immunization clinic. That is a very nice question. Actually, PCV means is pneumococcal conjugate vaccine. And PPSV 23 is pneumococcal polysaccharide vaccine. So there is a basic difference between pneumococcal conjugate and pneumococcal polysaccharide vaccine is that polysaccharide vaccine do not have any T cell memory. There is no memory. And being a polysaccharide vaccine, only 2 doses are recommended. And if you want to give the 3rd dose every 5 years, on the contrary of increasing your immunity, it will cause hypoimmunization. So I have seen that many elderly people are getting PPSV 23 every 5 years. So there it is not going to do any benefit. On the contrary, it is going to harm him, because it will cause hypoimmunization. The greatest advantage of PCV 20 is that it will cover the seroprotection. PCV 23 has got 23 serovalence, whereas PCV 20, what was lacking in PCV 13? 10 seroprotection level were less in PCV 13. As PCV 20 has come, so already PCV 20 has got more protection compared to the PCV 13 and similar protection to the PPSV 23. So that is the greatest advantage. Is it okay? And that doesn't need any booster? No booster, no PPSV 23. Understand? Is it clear? Okay. It may be. Any recommendation when it comes. So there is a sufficient data. I cannot give you right now the how many years it has been conducted. Like the 2 vaccines to be given in HPV 9 to 14. Yes. Yes. T cell memory will remain in the bone marrow lifelong unless there is a bone marrow transplant. It will be there. It will be there. No, it may be changed. Now, as on today, as present, I am telling that as present. As present recommendation is that instead of giving, earlier what we used to do, we used to give one PCV13, after 1 year we used to give one PPSV23. As because there is a 10 serotypes shortage in the PCV13. That is the main reason. So to cover up those serotypes protection, we used to give the PPSV23. Now as we are having PCV20 in our hand, so naturally we are covering almost all the serotypes which are present in the PPSV23. So there is no need for going for another vaccine with polysaccharide thing which has got no immunological memory. And PCV20 also, 24 also will be coming. 24. So it is better than 23. It will be also it is under trial and it will be coming to the market after a few years. Then also the guideline will be changed. So now again I will go to Dr. Sheep, please. 54-year-old male diabetic patient has visited you for advice on new pneumococcal vaccine. He has already received 1 dose of PPSV23 about 2 years back. What will be your advice?
2 years back, he has taken the PPSV.
He has already received 1 dose of PPSV23 about 2 years back.
Right now, our advice will be the PCV should have to be given only.
Okay.
Like, yes.
Thank you so much. Now again I will come to Dr. Alapan Bandyopadhyay regarding yellow fever vaccine. So a healthcare professional of UNICEF has visited Democratic Republic of Congo during late Ebola outbreak in the year 2018. Now he has to visit Sierra Leone for official work, whether he has to repeat yellow fever vaccine or not.
The short answer is no. There is right now the guidelines state, WHO guidelines, is that yellow fever vaccine provides lifelong immunity, and the card that is provided to every vaccine recipient is valid lifelong. So whether or not, and he has already been to Africa, he is in the DRC right now. So even if he travels to Sierra Leone, there is no need for him to repeat the vaccination until and unless there is he is severely immunocompromised, which it doesn't seem to be.
Yes, that is the right answer. And another question is there. A lady, 27 years old, will visit Kenya. She has a baby, 5 months old. The baby is on exclusive breastfeeding. Comment on yellow fever vaccine for both mother and baby.
This is a bit trickier on the end, because what we know as of right now is that yellow fever vaccination is contraindicated in children under 6 months of age because of the YELAND, that is yellow fever vaccination associated neurotropic disease. This is an encephalopathic syndrome that happens in children, very young children. The problem is that the ideal situation is to postpone the visit to Kenya as long as possible till at least the baby goes above 6 months of age. But if it is necessary, if it is unavoidable, then the mother should receive yellow fever vaccination, number one. Number two, the baby should be monitored. The exclusive breastfeeding should not be stopped. The guidelines clearly state that whatever happens, you should not stop exclusive breastfeeding. Keep on breastfeeding the child. Keep monitoring the child for any encephalopathic symptoms. However, you get the vaccine and then proceed.
Actually, there is a contraindication of the vaccine. That lactating mother should not get the yellow fever vaccine. That is why I put this question actually.
Right, but that is again, it has been stated that if it is unavoidable, it is necessary, extremely necessary that you have to go. In that case, you give the vaccine, monitor the child, but better postpone.
Because of the child will have the side effect.
This is a live attenuated vaccine.
Breastfed baby will be having the effect.
So it will get transmitted into the there is a child. There is a chance. Yes.
So thank you all. I will close here for your time spending at the late evening of the